ওখান বাইরে থেকে দিল্লি থেকে এখান থেকেই বল। টিভিতেও যাচ্ছে তো এটা, ওটা টিভিতে যাচ্ছে তো, টিভিতে সামনে টিভিতে যাচ্ছে তো। হ্যাঁ
Yeah, am I audible?
Yeah, you're audible.
Hi, good morning, Dr. Tarun. This is Dr. Sarojini Chatterjee. Good morning, how are you?
I am perfect.
So, do you have our extended view?
Yeah, we Dr. Bastav Ghosh and Rajiv sir is on chair.
Good morning, Dr. Bastav sir. Good morning, Rajiv sir. So, good to have you at Calcutta.
Thank you, sir. Can you hear us?
Absolutely crystal clear, sir.
Good to see you. I just have a couple of housekeeping things I'll do in the hall before I get back to you. Can you turn off these lights, please? They're not needed.
These lights,
Yeah.
yes.
Okay, so Tarun, we can see you. We have your external view. It's focused on you and on the drape. So do you want to start from there?
Yes, so first of all, let me welcome all the delegates who have taken the trouble to come to the City of Joy. I am very sure that the kind of work which we have put in behind this conference will show in the next 2 to 3 days. The target is to delve into the deeper topics of uro-oncology along with our colleagues of medical oncology and radiation oncology. This one is targeted towards the surgical approaches, so we have 6 cases lined up today. There are 3 centers which will be telecasting cases, so one is from Apollo, we will be doing 2 cases here. Then one is being telecasted from Rajiv Gandhi Cancer Institute, Dr. Amitabh Singh will be demonstrating the case there. Then there is a case from R.N. Tagore, and Fortis Hospital, Calcutta is also demonstrating 2 cases. So the first case which we are starting here is a prostatectomy. He is a 72-year-old male. He is hypertensive, had a family history of prostate cancer. His father died of prostate cancer at the age of 82. He was incidentally found to have a PSA of 15, which led to the imaging by the MRI. The MRI images, sorry, because the camera is not being able to focus these images, but the MRI images showed there were lesions in the peripheral zone, Pyrex 5, on both sides of the prostate, more so on the left side. His PSA was 50. We went ahead with a trust biopsy of the prostate, and the Gleason 8 was proven to be adenocarcinoma. Gleason was 4+3 is 7. 7 cores out of 12 were positive, the lateral cores were positive, and there was no PNI, there was no LVLD. Subsequent to this, we went ahead with a PSMA scan. PSMA scan showed localized disease to the prostate. There was a very small lymph node on the left side. The SUV was less than 2, but since they labeled it as significant, we have done a model dissection on an extended template on that side. There was no evidence of metastasis, and since there was a history of familial history of CA prostate, we gave him both the options. The first option being prostatectomy, the second option being ADT plus RT. He chose surgery over ADT and RT. So can we now ask Dr. Vanna? We are so glad to have her here. She is one of the most senior anesthesiologists at our center and one of the most experienced in the robotic arena. So I would ask Madam to briefly tell us about the patient positioning, and following which I will go to the port positioning. Mike, and port is still more. Mike. Yeah, just ask whether you're audible there.
No, we can't hear her yet.
Am I audible?
No, the audio is not clear at all.
Can you hear me better now?
Yeah, much better.
Yeah. So, I'm Dr. Vandana, consultant at Anesthesia of Apollo. Can you hear me now?
Yes, quite clear.
Okay, the patient, as Dr. Jindal mentioned, Mr. Ravin Das, hypertensive for the last few years, but the blood pressure is controlled. And otherwise, all his investigations are within normal limits. Just some, the lung fields, they shows a pleural nodule in the left lower zone. Other than that, all... Yeah, as you can show them the positioning, yeah, position. So, the patient, can you have the external view of the patient, please? So, the patient is in a steep tremor, the angle is around 30-32 degrees, and I would request Dr. Vanna to briefly tell us what are the anesthesia concerns about the positioning of the patient. Yeah. With this positioning, the airway pressures will go high, as also the BP, there will be a lot of fluctuation in the BP, and the more we are concerned about is hypotension in this position. But as you can see, if you can show the monitors please. Monitor. This monitor or that monitor. Yeah. So we have been about 2 hours into the surgery, and there you go. You can see the pulse rate, saturation, blood pressure all being maintained. It's a balanced anesthesia, a combination of inhalational and propofol infusion, but the patient is absolutely fine and stable. Thank you.
Thank you.
Thank you. Can we have the external view of the patient, please? Yeah, on the side. So the port positioning is pretty standard, but
Can you exactly describe the position? How should be the legs be? Should it be straight or should we bend the legs a bit?
So legs are straight because we're using an exercise system. There is no need for docking between the legs in this system. If you're using an X or an SI system, you will require a lithotomy because the robot comes in from there. In the next side, we have done a side dock, so the patient's legs are straight and the tremor is approximately 30 degrees. The port position is pretty standard. In the next side, you can basically put all the ports just above the umbilicus in a straight line, but we usually make a wide C. So if you can see, we are using the wide C configuration. I use the retraction on the left side. So to my left, there is the retraction, and the assistant sits on the right side. You will probably see a couple of surgeons flipping that area, so it depends upon your way of doing it. You can have the retraction on the left or the right. We are used to having it on the left. So the port configuration very standard. The assistant has 2 ports. One is a 12mm port, which is in the right iliac area, and we have a 5mm port because that directly gets up to the prostate fossa. So whenever you want to suck in, that is the most important port which gets you there, because with the side port, the suction might not be good. We also keep 2 suctions handy because one suction might get blocked. So that's the standard apparatus we have. Can we switch on to the end of view now? So just to save time, what I have done is I have already done the lymph nodal dissection, and the lymph nodal dissection is an extended one. I will just show you the lymph nodes. Can we switch on to the end of view, please? End of view. Do you have the end of view, sir?
Yeah, we do. Go ahead.
All right. So we started with the left. This person has had a history of bilateral hernia repairs. So there was some amount of adhesions where you can see the left ureter there. Can you just hold it for a while? This one? Yeah. So you can see the left ureter here. This is the external iliac artery. That's the external iliac vein. That's the internal iliac artery. That's the obturator area. You can see the obturator nerve very clearly. That's the abutated umbilical ligament. So we have done an extended lymph node dissection on this side. On the right side, we have a slight early branching, and that's interesting to see. So what's on the right side is this. So that's the external iliac artery, that's the internal iliac artery. The ureter is right here. That's the bifurcation of the external and the internal alveolar. That's the first branch, the anterior division, the agglutinated umbilical. That's the obturator, and you can see that there are a couple. So there is a branch which is going in there, which is the posterior division of the internal alveolar, and you have a branch which is going like this here. And if you follow it enough, so this is another branch which is going, that's the superior vesicle. Can you see the pulsations there? So this is the anatomy on the right side.
Perfect.
So now I'm using the 30-degree scope because I believe this 30-degree scope is very helpful once you're doing the posterior dissection.
And do you always do the notes first, or is it for demonstration today?
Sir?
Do you always do the notes first?
I always do the notes first.
Okay, fine. Thanks.
So this is a deep-seated pelvis. So in this particular scenario, the 30 up, the toggle feature of an exercise works very, very well.
Is the bladder empty? Seems to be little.
Yeah, the bladder is empty. The bladder is very, so this patient had chronic venous obstruction, so his bladder is actually trabeculated, thickened and huge in capacity. He also has a medium lobe. The bladder is absolutely empty. I always start with the posterior dissection. So this is relatively a vascular plane. We give a wide C, and then enter into this plane. Thankfully the planes are good.
Yeah.
So my idea at this juncture will be to go as far as I can because I do not do a ribs pair. So the idea is just to identify the domain release. So you can already see the surrounding vesicles coming into picture here. I'm going to clean this area.
Yeah. Dr. Tarun, we are watching you. We'll just go to
Certainly, please.
come back.
Carry on, please.
Yeah, just 5 minutes. Yeah, just introduce. I get a lot of calls from Dr. Raghu. Dr. Raghunath.
30 up coming.
Anyway, it's showing. We'll finish off. Yeah, Dr. Raghunath. Yeah, I think. We are on with Fortis Hospital. Anybody in Fortis Hospital who can hear us? Dr. Raghunath or Dr. Repeat. 1 second. Hello? Yeah. This is from the hall. Hello, good morning. Good morning. This is from the hall. I'm Dr. Gopi Chand here. We have Dr. Rajiv here. Hi, Dr. Gopi. Good morning. How are you, sir?
We can hear you. You can keep speaking.
Yeah, we have a gentleman here. I think this case history has been given already. Yeah.
Raghu, we don't have the history. This is Rajiv. Can you just give us a little bit about the history?
I can't hear you.
Can you hear us now, Raghu?
I have to hear.
Yeah, that's they are setting that up.
Hello. Good morning.
Can you hear us, Raghu?
Yes.
This is Rajiv. Can you just tell us a little bit about the patient? We haven't heard about it yet.
Yeah. So we are going to give a history.
All right.
Dr. Gopal Krishna, can you give the history, please?
Hello, I am Dr. Amivan Nundu from Fortis Hospital. So we had a 68-year male.
Yes, we can hear you. Please carry on.
Hello, can you hear me?
Yes.
Okay. So we had a 68-year male who had a history of urgency for last 2 years. He was on Silodel D8 for last 2 years and his PSA is at present 8.3. So we did a NPMRI showed T2 hypointers lesion in both peripheral zones, especially in the right side. It was a Pyrus 5 lesion. Also, the biopsy was lesion 3+4 and the PSMA test showed no metastasis. The patient is sexually inactive, he lost his partner. So now this patient is planned for this RARP procedure.
Okay, can you tell us about your approach, or maybe Raghu can tell us that? It's going to go posterior first.
Over to you, sir.
Yeah, hi, good morning. Morning. Gentleman with PSA of 16, he was taking dutasteride, actual PSA is 8, so since he got dutasteride, it's around 16, due to C disease, 4+3 disease, and he is not sexually active. So we are not planning to do any nerve sparing radical prostatectomy, and generally we go for the posterior plane. Here, this is falling up. Generally we use only 3 instruments. Here I may use 4th instrument. One, this is conference, and second one I don't want to have any impact. So to lift up this one, I will use a module driver. So we use only 3 instruments. Here I may take 4th instrument.
Is it working?
Dash is placed both with Dr. Nandana.
What is the Nemo? You want to record?
I can do it.
Actually, increase the Nemo regular. नीचे से increase the Nemo. Can you please increase the Nemo? I think we can manage this. We can manage this. It's fine. So this is fine.
Dr. Raghu,
Yes, sir.
yeah, back to you. This is SI system,
This is X system.
X
This
system.
is X system.
Yeah,
And biopsy has been done almost 6 weeks ago.
Yeah.
The planes are looking pretty, working planes are there. So can I have a 0 degree? Now I am working with 30 degree. Can I have a 0 degree?
so meanwhile, can you explain us where exactly should we take an incision? Which instrument should you retract the bladder?
Please change. Yeah, Gopi, I will start from the port placement.
Yeah.
Right now we have totally 4 ports, 4 robotic ports and 2 assistant ports. 2 robotic arms are on the right side of the patient and one is on the left side of the patient, so that we can have at any given time 2 grafting instruments.
Okay. So you put 2 robotic arms on the right side.
Yeah, 2 robotic arms on the right side, so that we can have 2 grafting instruments working at any given time simultaneously. If you put 2 grafting instruments on the left side,
But initially,
one at a time.
Initially you used to put 2 on the left side. You have changed to the right side now.
No, initially just for first few cases we used, then we switched over to this kind of a configuration. I'll tell you why, what are the advantages of this.
Yeah.
Yeah, see, say for example, if I had to graft something, see my 2 grafting instruments are there working simultaneously. Okay, this is a big advantage.
Yeah.
Yeah, that's a big advantage. So, and another advantage of having this configuration is, my assistant is coming from the left side of the patient, and since he is a right-handed person, he can assist me better than sitting on the right side of the patient. So these are the 2 advantages. At any given time, see, I can use 2 grafting instruments.
Yeah.
Okay, if 2 grafting instruments are coming from the left side, you can use any one at a time. So this is a big advantage. So this we have adopted from the beginning. And here, just about 1 centimeter from this, I have just opened up. Since this is non-nerve sparing, I don't want to go into the gelata fascia.
how lateral you can go safely? How much lateral?
As minimum as possible, just to get a proper view, that's it. If you go laterally, too laterally, sometimes you can injure the ureters. I will show you that. Because this is very important for the youngsters, those who are starting robotic surgery in the beginning. Once we identify the vast difference has two curvatures. So the medial curvature is fine. I don't want to go lateral to the lateral curvature. That's where the ureter comes. Did you get the prograph? Can you change to prograph? So here, see this tissue is following. I don't want to retract with needle driver. Generally we use only 3 instruments. Remove the needle driver. So here we are using progress. Generally not required in most of the cases, more than 95% of the cases, or clinical practice we don't use at all.
You use a needle holder for that work.
Yes. See, I'm not getting
Here the bladder is falling bit more, I suppose, no?
Yes. That's why I'm using. There is some moving from the here. Just leave that. You help the mesentery. Some moving there. I'm going to address that. Of course, this is just superficial one. Yeah. You can probably hold this.
Some people take a stitch on.
Yeah, we can take the stitch as well. Wait, Ali, I don't want to.
Dr. Raghu will continue watching, I think.
Can you please reduce the volume? Those who are talking, I cannot hear.
Yeah, Dr. Raghu, you continue, we are continuing to see you. We'll just go to Dr. Tarun and come back because he is nearly finished the posterior dissection.
Yeah.
Dr. Tarun.
Probably we can skip if both of us are doing the same.
Both of you are, he is a few steps ahead of you at this moment.
Yeah.
We'll come back to you. Dr. Tarun.
Right, am I audible?
Yeah. I think you're finished with your posterior dissection.
Yeah, so what I've done is basically, this is, the tumor is confined to the prostate. This is a dermal fascia which I have tried to spare. Though the patient is not very sexually active, I would still, this is the dermal fascia which I have spared. I have gone as far as I wanted to. This is, I was maybe still more clear a bit more, but spared the entire dermal because the tumor is lateral and is not involving the, so see this is the dermal fascia. Is it visual? So this is the dermal fascia. So, I have cleared everything out. Because the large pore needs to be done, I am sticking just above to the dermal fascia. So this is my plane of cleavage, and I have gone as far as I could. So then rest of the surgery probably will be done from the upper side. I have freed the attachments of the somatic vesicles, and as Dr. Raghu said, the most important, can you leave this section? Yeah. So the most important thing is this curvature. So if you go, so there are two curvatures. So this is the primary curvature and there's a secondary curvature. So if you go in the lateral to the primary curvature, there's where the ureters would lie. So I have freed both the somatic vesicles, I have freed both the vas deferens, and here my idea is to go up to the level of the bladder neck. So this seems to be the area where I will stop. And then I will proceed towards the bladder neck.
Anteriorly also you will free up to the bladder neck.
Yes, so this is the bladder neck, somewhere here, and I have freed the entire structure up to there. I have not used too much of a cautery in this area, but just spurts of it, and we have the entire clearance done.
Do you keep something there anteriorly to this somatic?
No, I didn't. To begin with, yes. So once I started the prostates, that was a time, yes, I was very scared. So at that time I used to put in a gauze piece, but not anymore.
Tarun, how do you decide how far anterior you wish to go on the posterior surface behind the seminal vesicles? Not anteriorly, but behind. How do you know that you've gone enough, or is there a limit to what you decide that this is okay?
So I can't hear your question. Can you be a bit slightly bit?
Yeah. So the question was, how do you decide how far distally do you wish to go on the posterior surface behind the seminal vesicles?
As far as I can, conveniently. So I would like to actually go as far as I can. So even if I'm able to go up to the urethra at times if the planes are good, I would actually prefer to go up to the urethra. So as far as I can, there is no limit to it, but yes, the minimum limit is that I should start seeing the denum, I should start seeing the posterior surface of the prostate. So see this, you can see the posterior surface of the prostate out here. So that is my idea. You can see the entire denum fascia, we have spared and we have gone up to the posterior surface of the prostate. If I can go any further, I would actually love to go, but I think this is reasonable. I would not go any further from here.
So there is some more distance that will need to be covered before you can actually get the prostate out. So you'll do that after you've decided.
Yes, from the anterior.
Okay.
So then once we have got the bladder, then we do it from the upper anterior side.
All right. Okay. Sure.
Alright.
And laterally, how far would you be comfortable going? Want to the lateral?
Again, so the idea is just to hug the vesicles and hug the structures. Don't go too lateral because you would have, if you want to do a spare, then the vascular bundles are just at the tip of some vesicles. So the idea to stay safe is just to hug the structures. If you keep on working very close to these surrounding vesicles and the vas, there should not be a problem.
Right.
Yes,
You do, try to do napstan in every case, right?
no, not in every case. So very selectively, not in a high risk case, despite it is, I would just do an incremental spare, not a final spare. In this case also, I would just, because the tumor will predominantly on the left side, on the right side we will do a slight spare. On the left side, I will still do an incremental nerve spare, not much of a nerve spare on the side versus tumor bearing. So that finishes nearly my posterior dissection. But no, I do not do nerve spares in all the cases. So I think you can use the Dr. Raghu all the time while do the job. So this patient had a hernia repair. You can actually see the sutures here. So can you see that? So there are a lot of reasons out here. You can see the previous sutures. Though this was done from this anterior intermuscular approach, you can still see something in the window. Right, I am presently on 30 up and the bladder drop is to be standard.
Dr. Tarun will go to Fortis Hospital for some time and come back. We are watching you. Meanwhile, you are dropping the bladder. I think you will drop the bladder superiorly or you will go laterally.
No, I usually would go like this, horizontally, and then from sides we drop it here. So the important message out here is that how far do you need to go? So we would go up to the level of vas difference. And this is the vas difference which you have already dissected out. So that's the landmark up to which we need to drop.
Vas is your boundary.
Yes, and we have to stay lateral to the obliterators. So this person seems to be having a direct inline hernia. So we'll see if we can repair that. So whenever we find a very interesting observation, so whenever we find inline hernias, we have repaired them, howsoever large or small they have been. So we just use a V-lock 3.0 and we do a RAFI of sorts or we do an anatomical closure. So in last approximately 27 or 28 hernia repairs, we have never had a recurrence. So we don't put in a mesh there, but we conventionally repair those hernias and the patients are very comfortable after this surgery. No mesh, no non-absorbable material and works very well.
That message is well taken. Mesh.
Does that mesh causes you problem in this particular case?
See, in an unfortunate event of if you have small amount of urinary leak, but if you have a urinary leak, the mesh has all the chances of getting infected. So that's why we were encountering hernia. So we thought that why not do an anatomical repair? If it heals well and good, if it doesn't, then we can counsel the patient for a subsequent repair. But to our surprise, anatomical repair works extremely well and there is absolutely no need for a mesh unless you have a very large hernia.
I had a separate query.
Yeah.
I wanted to know about this particular patient.
So the mesh is in the anterior aspect. So this surgery was around 15 years back. So there was no lap herniaplasty at that particular juncture. So what they have done is a conventional open hernia later. But patient can still, they might not have put a mesh inside. They might have just done a damming of sorts. But to me it seems that he has a direct hernia. If he has, we'll know in 5 minutes. And then I'll show how we repair that hernia.
Yeah, so we'll go back to Dr. Raghu.
Hi, sir.
Yeah, sir, I think you are finished with your,
Instead of taking the progress,
yeah.
tissue is falling, so I will probably do not dissect completely. I want to dissect little bit of seminal vesicles and go drop the bladder, go anteriorly.
Okay.
Conventionally, we do completely, posterior dissection is completed up to the apex of the prostate. Here, I am changing my strategy. Here the space is less, I don't want to waste time dissecting this. So, I will come anteriorly. So here, whatever, so far we have done, the left seminal vesicle and vas difference we have dissected. This is the right vas difference. Since the space is less, you may not be able to appreciate. So I will do a little bit of dissection and I'll drop the bladder anteriorly. When the space is less, it's a good strategy to go anteriorly. But for that, we need to dissect a little bit. Some cases we have done that completely anteriorly. So that also can be done. Yeah, can you just withdraw it a little bit?
So Raghu,
Yeah.
I'm somebody who does only anterior. I've never done a posterior. All my
Yes, sir. Yes, sir.
20, 15, 15.
So we have done many cases like that. Since ours is a training program is there, so always the fellows will start posteriorly. That's easy for them so that they don't miss the planes.
Right, so that's a debate for another day because I have never done a posterior and I've been doing this since 2006. I've never done a posterior ever. We're actually looking at our data because there are some of us who've done only posterior. I have done only anterior. We're looking at some of that data. So what do you think is the advantage of going posterior first? You've done both.
We can dissect easily, and in probably locally advanced cases, we can take extra margin of seminal vesicle. See here, which maybe it's slightly difficult when you go completely anteriorly. That is one advantage. We do a lot of locally advanced prostate cancers, including some cases in young patients where the prostate is abutting the rectum. We give neoadjuvant. In such cases, probably going posteriorly will have a lot of advantages. We understand the planes directly. I think that's where it makes difference for posterior dissection. Yes.
Can I ask a question, Raghu?
Yes, Sanjay,
What
please.
Dr. Rajiv was saying, like when I did about 200 cases anterior, then I shifted to posterior.
I can't hear. Can you increase the volume?
I'll talk louder. Can you
Yes,
hear me?
Sanjay.
Okay.
Yes,
So
Sanjay.
when we were doing the anterior approach and we knew that there was a suspicion of T3B, what we used to do was just keep on dissecting the bladder until you were at the tip of the seminal vesicle and
Yes.
lifted up the whole seminal vesicle along with all the fascia. Whereas
Yes.
whenever you do posterior, you always dissect the seminal vesicle, because of which you can't take all the fascial planes around it to ensure negative margin. So I feel whenever there is a locally extensive disease, anterior approach was better because you don't even dissect the semen, you just keep on dropping the bladder, keep on pulling it up, and then you see the tip of the vas, then you lift up everything. What do you think, Dr. Rajiv?
No, I don't agree with that, Sanjay. We can probably dissect here also. You go outside the seminal vesicle, leaving some, tissue adherent to the prostate, this one seminal vesicle. See here, I'm not going very close to the prostate. I'm not going very close to the seminal vesicles. You can do that dissection in locally advanced better here, I feel, rather than dropping anteriorly.
So I agree.
You can do it,
It's
you
just
can
a
do that.
matter of individual preference.
Yes,
and,
yes.
Whatever
I agree
you're
with that.
trained with, whatever you're comfortable with is fine. I've just never done a posterior. And I've been doing this since 2005.
How many instruments
Never
do
done.
you use, sir?
I use 4.
Okay,
I use a
that's where
ProGrasp, a
You can't
needle
do an anterior with 3 instruments. You just can't, just because of the amount of traction you need to get.
Yeah, I would agree with you on that. I need the pro grasp to lift up the seminal vesicles. I don't think I can do that with a needle holder.
Yeah.
So I do use a needle holder, a scissors, a pro grasp, and a Maryland, four instruments.
Till now, I haven't seen anybody do the anterior with 3 instruments. You always end up needing. So probably one of the advantages for India is if you want to do posterior, you can get away with 3 instruments.
The advantage for India would be no robot, but we can't do that either. So anyways, that's hardly an argument. But I agree with you. It's a matter of choice, actually.
Anterior dissection.
Sorry.
Can I talk?
Yeah.
You have done anterior dissection even with 3 instruments, and commonly we use only 3 instruments.
Yeah.
Probably I'm going to show that how we can retract effectively using by taking the sutures and retracting the sutures using the needle driver. That's very useful. So that will save your 1 instrument cost. Here I am using 4 instruments. Generally we don't use. Despite of 4 instruments, this is unable to, progress are taken, unable to lift it up. Because a lot of tissue is falling, bladder is falling.
Then you can ask questions, sir, Dr. Guinness.
No, actually, a continuation of the discussion, I do both. Usually, if you are used to laparoscopic approach in the initial period, we are tempted to go for anterior because we are using that initially. So,
In the telescope.
advantage about anterior aspect, one is if you have got lap experience is straightforward, then the dissection of bladder neck, actually going into other planes is less if you are going posterior and then cut. So for a person who is in the training period, posterior is better because he can identify the bladder neck and go in that plane easily. That is one advantage. For anterior approach, one advantage is the dissection of seminal vesicle. After the lateral aspect of seminal vesicle is difficult from the posterior aspect sometimes, but in the anterior aspect you can lift, and lateral aspect of seminal vesicle is easy from the anterior approach. So the posterior approach is easy for trainees because deviation in the bladder neck is less. Anterior approach, if you are used to laparoscopy, is easier because seminal vesicle dissection is easier with the anterior approach. That is what, and I find that is faster. Anterior approach is faster for me because a lot of dissection is unnecessarily avoided. So anterior approach, if I want to save time, I go for anterior approach.
But looking at the learning curve, I think to begin with somebody who doesn't have great experience, posterior dissection first helps a lot, no?
Yeah, I think I'd agree with everything that all of you have said. At the end of the day, it's a matter of individual choice. That is the bottom line. But yes, I agree, the anterior approach is faster. Again, this is data that we've looked at in the last 1 month, comparing about 150 anterior with 160 posterior. We haven't published it because we're still reviewing it. But the summary of that data was that the anterior is quicker, overall quicker by more than an hour in the overall outcomes. Otherwise, there's actually no other difference in terms of outcomes that we saw. We're still analyzing that data. But I also agree that the posterior is possibly easier for somebody who's starting off, because once you've got the seminal vesicle identified and pulled off, it gives you a lot more confidence when you're opening the posterior bladder neck. A common problem with going from the anterior approach is that you enter the prostate in the early part of your career. You are very scared of going vertically down on the posterior bladder neck towards the rectum, whereas you actually have to go vertically down from the anterior approach. And if you've already got that dissected out, there's a better chance that you can avoid entering the prostate. Otherwise, a common problem that I have seen on the beginners at the anterior approach is that they tend to enter the prostate because they are afraid of going vertically down on the posterior bladder neck. So yes, at the end of the day, it's a matter of personal choice. I completely agree with that.
Sir, would just like to add for the number of instruments in the anterior approach. I routinely do anterior approach, initially started with posterior, but in anterior approach I use 3 instruments, but these 3 instruments we use force bipolar. So instead of using needle holder, we will use just progress, force bipolar and the scissors. So it is usually good with these 3 instruments, and we are able to produce the same results, anterior approach 3 instruments.
Well, great. I'm sure each one of us has our ways of handling what we wish to do in our institution. For somebody who's starting off, I would strongly advise don't compromise on your instruments. You're already looking at a 5 lakh rupee bill. Another 20,000 rupees for an instrument shouldn't be an issue when you're looking to start off your experience. Once you've got enough experience, you can probably do it with whatever number of instruments and whatever combination of instruments you want. But when you're starting off, don't set conserving instruments as your benchmark. You've decided to do robotics, the patient's paying for it, he's been told he needs to pay for it. Do what gets the best outcomes. Tarun, can you hear us? We can't hear you.
Am I audible?
Yeah, we can hear you now.
Yeah. So I think, so you have wonderfully summed it up for, if you are subjecting somebody for a robotic surgery, absolutely 20,000 rupees do not matter. So I would hardly ever compromise upon having another instrument. So you are more concerned about the outcomes and the comfort of the surgery. So I believe having an extra instrument which will cost you 25,000 rupees is not a matter of debate at all. And as far as the posterior and I believe the problem lies not in the thought process, it more lies where you are trained. So whatever you see a mentor do is the technique you tend to follow. So yes, there are advantages and disadvantages. Yes, posterior approach makes me feel more secure as far as the rectum is concerned. But yes, everybody to its own. So what I've done is I've just cleaned the prostate. This is the bladder area, and how do I identify? The fat sticks on very nicely in this particular area. So that's probably the bladder area. You can very well see the anatomy out here. You can see the pubic-prostatic ligaments. I have divided the dorsal vein of the deep dorsal vein. This is the pubic-prostatic ligament. You can see the endopelvic fascia here. You can see the endopelvic fascia here. I have done a little bit of defattening what is required here. And then we are going to open up the endopelvics. So there is a technique. If you are doing a very extensive nerve spare, if you have spared the entire endopelvic fascia, probably you can get away without even opening the endopelvic fascia. You can actually save them. If you have a very restricted kind of a disease which is very localized to the prostate, not touching the capsule, you can even go for the hoop technique in which you can actually spare the entire endopelvics, you can spare the dorsal venous ligament, you can spare the suspensory ligaments of the prostate also. So I'm going to do the conventional way. I'm going to open the endopelvics and then take it from there. This person has a big prostate around 75 cc's. He also has a big median lobe.
So Tarun, do you intend to open the endopelvic fascia or not?
Yeah, in a bigger prostate, yes, but if it's something which is other, so if this was only a one-sided disease, I would have probably spared the endopelvic fascia on the other side. In the endopelvics also we try to preserve the, so that I'll try to show in this case if I can, so there are basically multiple layers in the endopelvic fascia also. So you can go very wide as to you bare the levator ani, or you can go a layer deep, so that there is a cover over the levator ani and there is a cover over the prostate. I will try to show that in this particular case if I can. And in the meanwhile, the third one is basically pulling the bladder behind. Here what I have done is basically I have not cut down the vas deferens. We keep the vas deferens intact usually. So that, let's start with the endopelvics. So you can see that recess. I would harness that recess. And let's see if I can show you those multiple layers.
You talked about preserving endopelvic fascia. Do you care about the process or the
Yes. So if you are sparing, but you can spare a part of it. If you are doing a hood technique, you can actually spare the entire thing. So we have done a couple of hoods and in very restricted diseases. And the best aspect is that once you have done a hood, absolutely confident on the removal of the catheter. There is absolutely no inconvenience. The same thing which I have observed is with the anterior approach. If I am preserving the bladder, the confidence rates are much better. So see this? You can see I have opened the endopelvic fascia and there is a cover on the levator ani. So we are working between the layers. I could have gone a layer down. So can you see now? That is the layer which I can go and that will bear my levator ani. But I have worked between the layers of the endopelvic fascia and the levator element basically is still covered with a facial covering. So you can harness the multiple layers which are present over the levator element. So see this, the muscle is there only here, but rest of the muscle is well covered with the fascia. So I've gone way behind. This is the sinuses of the prostate, and I will go up to the prostatic notch, which will be somewhere here.
Well, that's an important thing that people must see, that generally you must avoid bearing the levator muscle. If you've bared the levator muscle, that means you've actually gone wide, and it should be intentional if you're doing it and not a routine. And the other thing is, the more medial you are, the more likely you are to get bleeding because you can enter into the sinuses. So you need to stay in that plane that Tarun just showed, which is not bearing the muscle but not entering the vein either.
So this is a left-sided disease, so I would actually now, on the left side, I will bare the muscle completely so that you can see the difference between the muscle bearing and non-muscle bearing. So this is the recess, I will go now much lateral, and now you see the difference. The muscle is not there. Can you see that?
Yeah.
So because the tumor is touching on the left PZ, I would actually keep the maximum amount of cover available on the prostate so that I don't land up with a margin positivity. So if you see the difference here, this is the muscle which is completely back. Can you see that? Yeah. And this is the area, if I want to spare one layer, I can actually spare it like this. But if I want to take the entire endopelvic fascia and bear the muscle, this is the way forward. So this only I will do if the tumor is too much on the lateral aspect, and I would like to reduce my chances of a PSM.
And there will be less bleeding also once you bear the muscle, no?
Yes, the more lateral,
On the left side there,
lesser is the bleeding.
on the right, you can see the entire levator is completely covered. So can you see the difference?
Yeah.
Completely covered, completely bared.
Right, and that is exactly where the trick is, and that's again a place where people starting out often will get lost because of bleeding. And the bleeding typically is because you're too close, you've gone into the prostatic fascia. So it's a play between leaving the layer on the endopelvic that you've done on the right and going too close into the prostate, which could end up causing some bleeding. So it's a great play to show.
Thank you.
May I just introduce Dr. Amitabh Sheikh? He is sitting at Rajiv Gandhi Cancer Institute, New Delhi. I believe, welcome Dr. Amitabh. Can you hear us? Dr. Amitabh?
हेलो, थोड़ा स्पीकर बढ़ाओ, आवाज नहीं आ रही मुझे. हेलो.
Hello. Good morning.
हेलो. हाँ, गुड मॉर्निंग सर.
Good morning, Dr. Amitabh. Dr. Rajiv Kumar is there, the whole entire chair. Yes. Can you just brief out the case? I believe you are using SSI mantra here.
Yeah, sure. So, hello.
Yeah, we can hear you.
Yeah, you can hear me? Okay. So, where is the case? Can you display the case? So, for a while, I am giving my mic to Dr. Sarvartho. He is a junior consultant here. He is very good friend and very good junior to me. So, he will explain the case to you, and he will explain the whole setup of the SSI mantra. So, the good news about the SSI mantra is that now, today, we are using 5 arms. Because this is a modular setup, we have got whole separate arm for every instrument. So initially we were using only 4 arms. Now today we have got 5 arms. Can you show the setup? This set. Show. This was the case. Hello. Hello, I am audible.
Yes, we can hear you.
Greetings from Rajiv Gandhi Cancer Institute. Good morning, everyone. So today we are demonstrating robot-assisted radical cystoprostate from using the SSI mantra system. Please show us the camera. So the new thing is that this is Mantra system generation 3. They have come up with slick arms, and we have both 5 arms here. You can see one.
No, we don't have a visual, we only have your slide. Actually, we don't even have a slide, we have,
Okay, showing you shortly, sir. We are converting to surface camera.
yes, we can see the surface now.
Oh, so this is the 5 arms of the individual arms, and they are much sleek than the Mantra 2 version. This is the Mantra 3 version. So there are 5 arms, 1, 2, 3, 4, 5. The central arm is the camera arm. This is the camera arm, and we does this arm in the just from the Italy.
So your audio is breaking up.
Hello, am I audible?
Yes, you are audible, but it breaks up in between. You're okay now.
Okay. So here is the central arm. We have docked this arm to the camera port. This is the camera port. There is a 12 mm port. On the right hand side of this camera port, we have docked 2 arms, 2 individual arms. This is one right hand working port. We are using monopolar scissor in this arm, and here we have put another port on the extreme right side. Here is the we'll be docking here the harmonic. We have come with the energy source also, so we will be showing the use of harmonic energy source with this Mantra system. It is incorporated in it. On the left hand side of the camera port, this is the left working port. We have connected with bipolar this arm. Well,
No, we,
Voice is very muted. Dr. Amda,
Yes, yes.
your audio is breaking. Can you be a bit louder?
Hello, yes. Is it clear now?
No, it's very muted.
Yes, now. Okay, can you hear me? Hello?
we can hear you,
Can you hear
but,
me?
yeah, we can hear you, but when you move, the mic moves away from you. So you have to.
Okay,
Yeah.
okay. Let me explain, sir.
Yeah, so we've understood the camera port, we've understood the right side 2 ports. What do you have on the left side 2 ports?
So on the left side of this camera arm, we are having 2 arms, one for the fenestrated bipolar. Can you show the camera? उधर से आ जाओ, उधर से आ जाओ. Can you see, sir? Rajesh,
Yes.
sir, can you see?
Yes,
Yeah.
yes.
Sir. So this is dedicated for the fenestrated bipolar, and this is the 4th arm, last one, which is for the retraction. So we have already put the pro grasp into this arm.
Right, so Amitabh, the question then is that on the right side, you now have 2 instruments, that's a scissors probably and a harmonic.
Yes, sir.
Why do you need a separate arm and for the harmonic? You can ultimately be using only one of the 2 at one time. Your hand can either be using a scissors or it can be using a harmonic.
Okay.
Why do you need 2
So-
separate arms for it?
So actually the purpose of this whole modular arm was have to have a minimum assistance, minimum dependence on your assistance. So sometimes while cystectomy you are using scissor also, and when you retract the pedicle, you lift the pedicle, then you can apply the harmonic also. So that's why now today we are trying to use all the 4 arms along with the harmonic within a separate arm. So let's see how it goes, because before this we have done one case and we used the harmonic, it went very well. So now we are trying, this is for the second time actually, this whole setup.
All right, and do you still have an assistant arm or is there an assistant?
Yes, sir. Yes, sir. So we have got one assistant source for the suction and giving some clip, hemolock clip or some other things. Yes, sir.
So a single assistant port.
Yes, sir. Single assistant port.
All right, thanks. Just carry on then.
Yes, sir. Sure, sir.
Sorry, one more question.
And-
So the patient position is now Trendelenburg supine. There is no lithotomy, there is no instrument between the legs.
No, sir. So actually here also the position is pretty same as we are putting the patient into the Da Vinci, but we don't separate leg too much. So what we do, we bring the camera arm between the legs.
All right, so there is one arm coming between the legs and the 2 others on each side.
Yes. Now you can see, I think. sir.
No, we've
You
got
can
a
see
black
the whole setup
screen.
from the foot end of the patient.
No, we've got okay, now we can see it, yes.
Yes, sir. So these are the 5 arms actually docked all together.
Right.
And this is the dedicated camera arm, because
Got it.
actually we have got this dedicated arm, this camera arm, because now we are using Olympus 3D eye. So this
Right.
has got 12 mm diameter. So we have got dedicated port for that. Unlike Da Vinci, we can't reshuffle the camera like in between other arms, we have got this dedicated camera port for the patient.
Got it, understood.
That's why we are having this dedicated camera arm. Otherwise, we can shift the instrument from from the right to left side of the patient. It all depends on you whether you are right-handed surgeon or the left-handed surgeon.
Perfect, we understood that.
And this camera is 30 degrees. Oh, sorry, 0 degrees.
No, sir. Actually, it is a flexi tip camera, so you can make it 0 degree also. You can make it 30 up, 30 down also. So they have already provided a lever in the camera head and the locking system also. So once you want, like suppose you want 15 degree up, so there is a lever by which you can you can see the screen. You can see.
We can see you, we can't see the screen.
Endo view. This endo view.
Yeah.
Endo view जा रहा है उधर CIT में.
No, we are not getting the end of view. Yes, we've now got the end of view.
Okay, ठीक है. So can you see, sir? Can you appreciate this? Now I am flexing the tip,
Yep.
up and down. So once, like suppose you want 15 degree up, 15 degree down. So by flexing the tip, you can lock it by a locking lever.
Understood.
And up and down, I think the assistant has to do, the surgeon cannot do it.
Exactly. So now rotation can be done by the surgeon at the surgeon console. They have provided that control. I can rotate my camera clockwise
Left and right, yeah.
clockwise. But if I want 30 degree or 15 degree up and down, then I would ask my assistant to do that.
To do it, yeah.
So that control is with the
Assistant,
assistant. Yes. So you want to know about the case also, sir?
We need to know a little bit about the patient, yes.
So this is actually a carcinoma urinary bladder muscle invasive disease. We did TRBT 3 months back. He had a locally advanced disease. At that time, he had one pelvic lymph node also on the right side. The primary size is initial size of the lesion was 15 centimeter.
So your voice is breaking up again. Yeah, okay, it's probably an internet issue. Just carry on.
Yes. So now he gave me 3 cycles of neoadjuvant chemotherapy. So that pelvic lymph node responded after getting chemotherapy, but the residual lesion in the bladder slightly in the size. So that's why we counsel for this patient for the radical cystoscopy with IV therapy because he is a known case of diabetes, CVD, and he is already 67 years. So we gave him option of IV cardio. And today we are trying to demonstrate the intraperitoneal pelvic also with this ultra.
All right, so please go ahead and start. We're going to briefly go back to Tarun. There is an interesting finding. I need to find out what's happening there. So can you connect us back to Apollo Hospital? Tarun, can you hear us?
Yes, sir. So interestingly, this person also has an anterior lobe. So medial lobes can be posterior in certain patients. This is a kind of a very rare finding. This is a most likely the extension of the medial lobe anteriorly. So that's what it is. And you can see the posterior lobe right there. So I tried to preserve as much of the neck I could. I will show you one. So see this is a big medial lobe this person has. And I will try to dissect that as much as I can. And then we will show you how we tackle the medial lobes. The most important thing here is that we have to be very cognizant about the orifices.
Right, okay.
So traction.
So is it possible to get 2 screens at the same time? We're getting a single screen here.
Can you show this to Dr. Raghunath's screen as well?
Hello?
Raghu, yeah, I think for a long time we are not with you.
I'm using right now 30 degree, but 30 degree generally we use for bladder neck. We can do with 0 degree as well. Here, in the midline, you see here, the pubic symphysis is coming in the way that is blocking my view of the apex of the prostate, and I have to change to 0 degree. I will change that in some time after the bladder neck. Otherwise, we drop the bladder and we have not incised the endopelvic fascia to begin with. We may incise at the end of the, after controlling the pedicles. So I have kept the endopelvic fascia intact at this point of time. Can you change this one, clean it?
So is there any advantage, Raghu, of leaving the endopelvics intact?
In hood technique, we leave that completely so that we can preserve the nerves in the best possible way. other than that, here it is not going to be very useful.
Right, I remember you are saying that you're going to go wide and not preserve the nerves at all, so posteriorly you've
Correct,
gone
correct.
wide.
Correct. Though this is T2C, this is organ confined, it is not sexually active. His PSA is 16, so we are not planning to preserve the nerves. Let's see how it goes. And one peculiar anatomy you can notice here, I am with 30 down, this pubic symphysis, sometimes we do see this bony protrusion. So this is blocking with at 30 degree, I cannot see the apex of the prostate. So I have to change my, telescope when I start dissecting the apex of the prostate. Right now, I am okay to dissect the bladder neck with 30 degree.
Right, and again, something that you'd like to tell people who are just starting out. Opening the endopelvic fascia makes it easier. When you're doing all these dissections, if you've got your prostate clearly defined anatomically,
yes.
life
I
is
agree
much
with that.
easier.
I agree with that. Initially, we used to do that, now we stopped doing that. Probably I'm comfortable with the zero only, otherwise I cannot, it's going to. So these instruments will come in the way of, dissecting the bladder neck also. This protrusion, which is very rare, let's see. Go with zero only. Go with zero.
And again, I tend to find the zero works beautifully at most places.
Correct. We can complete the procedure completely with 0 degree.
Yeah, I agree completely with that. To a large extent, I would just go and finish everything off with a zero, but sometimes it really helps.
No, except in large prostates, sometimes while dissecting posteriorly at the apex, sometimes it is very difficult with zero. We have on couple of occasions we have used 30 up.
30 down, you mean? You're talking about the large median lobes, or you're talking about posterior dissection?
Posterior dissection, completely we are going behind the
dissection.
Between the rectum and the prostate.
Yeah, posterior dissection.
Yes, yes.
Sure, yes, I agree.
Yeah, this is much better, I think.
Please. Unmute. Yeah, am I audible, sir?
Yeah, we can hear you, Tarun.
Yeah, so for the people who are new to the surgery, so what I'm trying to show is this guy has a big median lobe, it's kind of floppy. You see that? So what I've done is basically put in a V-lock and I'm putting a traction here. Now the most important thing for me is to see where the VAGs are, and the VAGs are way down there. Can you see that? That's the VAG. I'm sorry, that's the VAG. Can you see that?
Yep, we can see the ureteric artery.
That's the ureteric peristalsis. So what I've done is just to give me traction, I've lifted this median because it's very floppy one, strongly with a V-lock needle. And since I know where the VAGs are, now I'm kind of comfortable and I'll go below the median lobe.
Yeah, that's a very good way of showing it. So you can clearly see the interureteric bar and you can see the two orifices. It's very well done.
The reason for this floppy, usually what we encounter if somebody was on a immunoadjuvant ADT. So that is the reason why we found it, but this person was not on any kind of ADT or any kind of treatment. Slightly strange. It's a very floppy one.
Another thing that you need to note is what Tarun is doing is making an incision not right behind.
Yes, so this is my median lobe, just slightly in front of the median lobe, just to be on the safer side, and that will lead me to the retrodragonal area.
Yeah, so that's an important point. Don't try and make an incision behind the median lobe. You will be left with no space and you can injure the orifices. So that's the right place to make an incision.
Madam Guru. Am I audible in the auditorium?
Yes.
Yeah, so another important trick, so how to identify for a beginner that where the prostate ends and where the bladder starts. So this melting effect, that's something which has been described. So this melting effect will happen only with bladder fibers. this will not happen. So the tissue, if you put on stretch, should melt under the effect of cautery. So that means you are in the perfect plane, you are not violating the plane at all. But if you enter into the plane state, spreading effect, see this, it's moving away. So this moving effect will not be there. So that's just to differentiate as to whether you are on the prostate or whether you are on the bladder area. Can I have the needle clean, please? Sorry, scissor clean.
Okay, can we get the, can we speak to Raghu there? Raghu, can you hear us?
Yes, sir.
Was that Tarun or was that Raghu? That was Tarun. I wanted to speak to Raghu if we could.
Sorry, sir?
I wanted to speak to Raghu at...
Okay, please.
Hi, sir.
Yeah, so this is an important thing that you are showing. You haven't divided the endopelvic fascia.
We have not divided the endopelvic fascia. I just started dissecting laterally to understand where is the bladder neck. I am not preserving the bladder neck, but I would like to have, if possible, a smaller bladder neck so that I don't have to reconstruct the bladder neck. So that's my plan. So initially I started here. Some muscle fibers were cut. Then I realized that, see here, I think this is the bladder neck.
Right, I agree with what you are showing, and my question again is that, is this easier or is it easier once the endopelvic is divided? Which is easier for...
No. Now, at this point of time, whether you divide the endopelvic fascia on either side, it is not going to matter much at this point of time. When you go posteriorly, probably that makes some difference. And in this case, in X system and XI system, probably I will keep the coagulation cutting artery settings to 3. Otherwise, even if you, at 4 or 5, even if you cut the prostate, it will cut like a cake. So you cannot identify what is prostate, what is bladder neck. So I keep my artery settings to 3 so that I can understand better. See here, this is prostate, clearly I can understand. This is the junction. So this is probably very important step to keep the cautery at a lower setting. See, I am separating this. Can you make out?
Yeah, we can see that.
This is prostate. I'm not a very, proponent of nerve preservation, this one bladder neck preservation, but we can preserve this in the best possible way. Can you make out? The prostate is peeling, separating. So this is the bladder neck. Any questions at this point of time?
No, I think you're doing fine, just carry on.
We keep on talking about the bladder neck and all. So,
Yeah. So again, I will not be doing this if the tumor is present around this area. I'm not comfortable doing that because we have to give a negative margin as well. That's more important than to doing the bladder neck.
but have you ever encountered hypercontinence if the bladder neck is very small and narrow?
No, I've never seen that. Except, I think 2 or 3 of our patients develop retention of urine after radical prostatectomy, and they had hypocontractile detusal. After giving, Bethanyl, they started voiding. This is very rare phenomenon. Can you make out?
Yeah, we can appreciate that. Now you are going to open it.
Yeah. No, we can even go behind and fish out the seminal vesicles, and we can define this even in a better way, but I'm not doing that right now.
This technique is better not to be done with big, large window like the Tarun.
Yes, it's difficult sometimes. Be ready to remove the catheter. Can you step out here? Any questions at this point of time? So we are not divided the endopelvic fascia as of now. At this point of time, while dissecting the bladder neck, you don't need to cut the endopelvic fascia. When you go laterally and posteriorly, probably at that point of time, cutting the endopelvic fascia may be helpful. Let's see. Sanjay is there? Sanjay?
Sanjay is in the hall talking to somebody else, setting up his next meeting.
this perfectly on the anterior part of the bladder neck. I'm going to open the I'll see the catheter. That is the bladder neck. Catheter is there? Catheter is there? Oh, can you change to 30 because I can't see with this.
Where is the catheter, Dr. Raghu?
We are not to open the anterior bladder neck. Here I may change from 0 to 30 because the anatomy is slightly different here.
And go back to Apollo Hospital.
Medial. So I dissected the entire bladder attachments. So the medial bed is now free. I have already reached to the area of the seminal vesicles. So now my plan will be to remove the traction suture and bring the seminal vesicles out so that I can pull them and use them for traction, not for posterior dissection. So if you
I think you're to be happier that you have started with posterior dissection with such a thing in your
with such a movement, yes, certainly, I am really happy. There's no doubt about it. So can you see this now? So we have done one dissection, the bladder is relatively free, now we'll target the bladder pedicles. You can see some amount of bleeding already happening from the bladder pedicles. That's the artery which goes from the bladder to the prostate. We have stopped that. Right. So we can remove the suture again.
Just for a demonstration, can you, before removing the pillow, show us the UTJ?
Show the what? Visual.
The urinary copy.
Urinary orifices were way away. So, leave it. So this is the trabeculated bladder, this is the edge which I created, and you have used the right bed. Can you see that?
Yeah.
This one, that's the other one.
Yeah.
Can you see that? So now we will hit upon the bladder pedicles.
So now we should do any mother. So I think that you always do hand to that. So,
Scissor?
So in the anterior dissection, again, the medial lobe is
Am I audible?
exactly like this. Exactly the same. There is absolutely no difference. It's actually exactly the same.
Keep the clips ready, huh? Clips.
Yes, so that is a sense of security, which I completely agree with, that if your posterior dissection is done, it gives you a lot of satisfaction to know that you're in the right plane. But if you've done enough anteriorly, you know that you're cutting in the right plane. And ultimately, the posterior division of the bladder neck is the same, whether you're doing it anterior or posterior. You still have to divide the posterior bladder neck. And the most important caveat everybody needs to remember here is your angle when you're cutting the posterior bladder neck. The commonest mistake is you tend to dissect horizontally. You have to dissect vertically downwards at the posterior bladder neck. That's the commonest mistake I've seen happen. If you dissect more than an angle, less than an angle, you enter into the prostate posteriorly. So on the posterior bladder neck, your incision has to be virtually vertical till you've divided all the fibers of the bladder. So when we started doing this, we used to make the incisions very small on the anterior bladder neck and on the posterior. We used to make them very small, and we were virtually working in a hole. We've stopped doing that. After we've opened the bladder, we now open it reasonably wide at all the level, then it becomes easier. So we don't actually come from lateral, we still have to divide from the midline on the posterior and then go lateral. But I think a lot of it is to do with experience. Once you've done some, you get more confident, it just becomes easier.
Dr. Raghu, we are back with you. Any tips here how to go from, because this I think for a beginners, this particular step for anterior to posterior is the most challenging step.
Yeah, this is the bladder neck. Generally, I keep my bipolar inside this to see the posterior wall of the bladder.
Yeah.
And I go parallelly, as Dr. Rajesh has said, I go vertically down. Vertically, again, visually it can be different when you are using 30 degree or 0 degree. Here I am using 30 degree, it can be perfectly vertical. It also depends on, when you try to pull it, you cannot see properly and you end up getting into the bladder.
Yeah.
So that should be avoided.
The buttonholing of the bladder should be.
Buttonholing of the bladder should be avoided.
Yeah.
Here. So that's very, very important. So after reaching one place, see,
And direction of the fibers can recognizing the.
yes. Once you identify the denominal fascia, just open up like this.
Yeah.
See, it's opening. That is, I'm sure that this is denominal fascia only. This is nothing else.
Okay.
So once you identify that, chance of buttonholing will be very less. And here, again, we can use clips or depends on your convenience, whether you are preserving the nerves. If you are preserving the nerves, we generally, it again depends on whether it's completely intrafacial or interfacial. We can use the clips. Here, we are not using we are not sparing the nerves. I am not going to use any clips.
So I'm just using the cautery and
Yes. Any questions at this point of time?
So
I think I'm okay with that.
yeah.
That is denominal fascia. I'm going to cut that. You'll see the seminal vesicles. Very rarely, Gopi, are you with me?
Yeah, we are with you, sir.
See, sometimes the bladder recess can go up to here.
Yes, yeah.
When we are cutting here, we can enter the bladder at this point of time as well, at this site.
Yeah.
So we should always put your bipolar into the bladder and see.
And appreciate the bladder there.
Correct. That's very important. So now I know that this is not bladder.
Yeah.
Perfect. Can we get a look at what's happening on the cystectomy side? Yes, sir.
For a moment, with due permission, can we go to NH? I believe they are getting ready with the case. NH, audio can be switched on?
So, kindly
Am I audible, sir?
Can you hear me?
Sir, good morning, sir.
One second. AV team, kindly shift the Apollo to RNT and the Fortis view to Delhi RGCI. RGCI also wants to show something. From RNT, Dr. Maharaj, please go forward to the presentation.
Sir, good morning, sir. Am I audible, sir?
Yes.
Sir, very good morning to all. Sir, I am Dr. Aftab from RNT Hospital. Today, we are going to demonstrate this Redzis sparing radical prostatectomy. Dr. Sudhir Rawal is our chief surgeon, and he will be performing and demonstrating all the steps and everything. To summarize the case, it's a 62-year-old male which presented to us with a history of noxuria only. His initial PSA was about 3.8. So on DRE examination, nothing abnormal was found. The prostate was found around 40 gram. So we keep that patient on surveillance, and the PSA was found to be rising. And in 1 year interval, it came out to be 6.1. So we decided to do a MPMRI, which showed lesion in both right and left lobe peripheral zone at midpoint level. So we did a biopsy. After that, this came out to be adenocarcinoma prostate with lesions 3+3. And then we also performed TCM PET-CT, which also showed this.
Yeah, now the room.
So this is about the case summary. Now
Stay close to the
I
prostate.
handing over the mic to Dr. Sudhir also, sir, please.
No median lobe, 40 grams prostate, no median lobe.
Morning, can you hear me?
Yes, sir. Good morning, sir.
Yeah, hi Dr. Rahul, we can hear you.
Yeah, so I'm planning to do, it's a low-risk disease in a young man, brother of a doctor. We are planning to do radius-sparing radical prostatectomy, where I already dissected the seminal vesicles. If somebody can have endoscopic view, can show them seminal vesicles and Ross, I have, already dissected. And I have lifted up with the holding the Ross only. These are seminal vesicle and Ross. Can you just hear? So I have gone posterior to the prostate, remaining close to the prostate, like not classical intrafacial, but not extrafacial at all. And I have dropped the rectum and the lateral side, I have dropped the neovascular bundles also on both sides. Now to save this further neovascular bundle, when I take the lateral pedicle, I will be close to the prostate. Lateral pedicles are here. You can see these are defined as lateral pedicles. You can go here if you are doing extra patient, but if you go here, you will be close to the prostate and you will be saving the neovascular bundle. It's done very beautifully with radius sparing. The best advantage, all of you know that the radius sparing has is the return of continence is very dramatic. Most of my patients to whom we do radius sparing, when they come after 3 days of catheter removal, they are actually most continent, very satisfactory. They do not use pad even many of the times. These patients, they tell me like this. So this you can see I am in intrafacial plane, neovascular bundle have gone laterally and down. So I'll just go to the lateral pedicle on right side and then on the left side. Any question?
This is an XI.
Hello?
You're using an XI machine, no?
It's a X, not XI.
It's an X. Okay.
X machine.
And what is your criteria for selecting patients for a radius sparing?
Anybody who has low intermediate risk, not very local advanced disease, and the prostate is around, size doesn't matter, but I don't do in a patient who has got 140 gram of the prostate. But post-TRP is not a contraindication. But before that, we'll do cystoscopy sometime. If huge bladder neck, then I'll go anteriorly. Otherwise, most of our patients, they are actually go for radius sparing in our institute when they are, they are eligible.
Okay.
Rajesh sir, am I audible?
Yeah, Tarun, I can hear you.
Yeah, so I just wanted to quickly show to the people there, this is the prostatic artery. Can you see this?
I am assuming we are seeing you, I don't know who we are seeing.
That's fine.
I don't think we are
I will believe when it will bleed, so that's the prostatic artery. This one?
ज़्यादा पास में आ रहे हैं.
Yeah, okay, we can see that now.
So this one is the neurovascular bundle, so that's what the Dr. Patel mentioned about. So this is the prostatic artery. Can you see this, sir?
Yeah, we can see that, and you're also likely to get a number of other smaller branches, so it's almost not just one, which are
so you can see that this is going like this, there is another branch here, so there are two at least which we can see.
Yeah, so there
just wanted to show this.
Multiple branches there, although one is...
One audio is on, can you switch off one audio?
Switch off my audio. Switch off my audio. No. I'm sorry. No.
Can we get the feed from Mantra somewhere?
No. Two. You need to allow. Yes.
Are you getting the transmission from Delhi?
So, AVT, can you switch to RTC Delhi, please?
Hello.
नीट वाला आ जाएगा उससे भी दूर है अब दूर है वो थोड़ा सा पास में था.
So I should let all the surgeons know that there are times we can hear you. You may not know that we can hear you, but we can hear you. So this is something I think all of you should know, that your audio feed is coming even when you think we can't hear you.
Hello.
All right, Amitabh, do you want to show us something? We're getting only a surface view.
Not possible.
Can you hear me?
I can hear you, yes.
Okay, so just first about to be SSI mantra, so I would say this is very high time for SSI mantra because now we are using 5 arms. No modular robotic system have ever been used, have been able used to 5 arms right now. We are using 5 arms. No, just I wanted to demonstrate how we rotate this camera clockwise and anti-clockwise. So what we do, we press the camera clutch and we press the right or left cautery paddle. So now just I am pressing the left button, so it is rotating anti-clockwise. Now I'll just be pressing the right button, so it will rotate on the clockwise, like this only.
Right, can we get an endoscopic view? We want to see the working of the instruments inside.
Okay, sir. So working of instruments. So I have done already. I have completed this right side pelvic lymph node dissection. So very quickly I will be just showing few anatomical landmarks. So this is right ureter dissected up to this part, false pelvis going up to the tunnel, ureteric tunnel on the right side. This is obliterated ligament, this one. So this is obturator vessel which is going into the obturator fossa. This is obturator nerve. I have completed this whole lymph node dissection. I went up behind the vessels also. You can very well appreciate this. Now you can see this common iliac vein also, part of the common iliac. There was a lymph node. I took it out already. Now you can see this obturator nerve going into this pelvis up to the. Now if you will give us some time, then I can show some branches of sciatic nerves also. You can see some part of this branches along with the obturator nerve. So on the right side, I have completed the pelvic lymph node dissection. Now just I shifted on the left side. So this is my progress. The best thing is that during this dissection and moving my instrument, I am not having any clashing despite of docking 5 arms on the patient. So every arm is doing very well. There is no clashing. They are working very smoothly. Now just I will rotate again here my camera clockwise slightly just to have a better orientation. So on the left side also again you have to press correct. So I have just mobilized this whole complete left ureter up to the tunnel. Now you can see this thing going up to the pelvis. Now this is these are the seminal vesicles. So after completing the lymph node dissection, I will take the pedicle, then I will go for the posterior dissection. So for the beginners and the students who are sitting in the hall, I would say this cystectomy is all about the spaces. If you have made your spaces very well, like both paravesical space and the posterior space and the anterior space, then the cystectomy is the easiest operation I have ever seen with the robotic. So you just take the pedicle, go on taking the pedicle up to the prostate, and the whole specimen can be taken out very easily. Now I can see this enlarged lymph node on the left pelvis. So this could be positive lymph node also.
Dr. Amitabh.
Yes, sir.
Dr. Saranjit here, your colleague.
Okay. Bolo, go ahead.
बहुत बढ़िया.
Thank you.
There are 2 questions from my end. You told this case is post-NSCT, right?
Yeah.
So do you actually find any difficulty in dissecting in post-NSCT cases compared to?
No, not at all. Not at all.
And just now you mentioned that you are taking out a suspicious lymph node which can be positive.
I will do
frozen.
No. So I will do a formal lymph node dissection. So because this patient I already told in the history of the patient, after giving NSCT, the bladder lesion probably they didn't respond, they slightly increased in the size. So the purpose of cystectomy is probably palliative. I am just giving him symptomatic relief so that he should not get any hematuria, dysuria, anything. Probably require immunotherapy after this cystectomy also because chemotherapy didn't work for him. So I will not send these lymph nodes for the frozen section analysis. I am not going to abandon this procedure because I have already explained to the patient attendants. The primary aim of this procedure, the radical cystoprostatectomy, is just to have a symptomatic palliative cystectomy, just improve quality of life. I don't know whether this will add on the survival of this patient or not. He will definitely require some sort of adjuvant therapy in form of probably immunotherapy, and they agreed on the procedure. Any other question?
In your case, Dr. Amitabh?
So if after NSCT, if the disease is not responding, then you can't say that the cystectomy is going to increase the survival. So mostly in the setting of progression after NSCT, cystectomy is just for the palliative purpose. It will just increase the quality of life because the patient will not have any lower urinary tract symptom, which will just reduce him require multiple hospital admission, dysuria, clot retention, hematuria, and all these multiple surgical interventions. Nobody can be sure whether it will add on the survival or not, but definitely it will improve the quality of life of the patient.
So, if I understood you correctly, Amitabh, this is a patient who had a node at the initial imaging before the neoadjuvant.
Yes, sir. He had lymph node actually on the right pelvis. On the PET scan, that node responded, but the lesion in the bladder, they increased. But now I could see this lymph node also in the left pelvis, which they couldn't see on the PET scan. And this looks positive because it is not a longitudinal, it is just necrotic node. This looks positive to me, sir.
Right, but our current understanding of bladder cancer is that even if you have nodes in the pelvis, there is a role of cystectomy.
Yes, sir.
There is still a role which is with curative intent, not with palliative intent. That even if you do have pelvic lymph nodes in the bladder, in CA bladder, you
Yes,
can
sir.
still attempt it with a curative intent. I think that is Harry Hurt's data from late 90s or 80s, that about 30% of them will actually
Okay,
be
sir.
cured, will not get a recurrence even though they had a positive pelvic lymph node. So you're completely justified in doing a cystectomy
Yes, sir.
if there is only pelvic lymph nodes which are there in bladder cancer.
Yes, sir. This could be true with the very minimal burden like 1 or 2 node. But I don't know these data had NSCT before or not, sir.
These are not based on neoadjuvant chemo. At that point of time, it wasn't a standard
The
of care.
problem with this patient is that he is having lymph node despite of getting NSCT. So probably he will be having micrometastasis also. We don't know.
Right, it's quite possible, but I would still assume that your attempt is still a curative intent. That is
Yes,
the
sir. Yes, sir.
objective.
to RNT.
Rajesh sir, may I ask something to you? In these sort of cases, as you were saying, there is still survival benefit. You go up to retrograde and lymph node dissection also.
I can give you an answer from theory and an answer from practical. The answer from practical is I don't. I don't, as an individual surgeon. Theory, you should do as wide a lymphadenectomy as you can. So theory, there is an advantage of going very wide. In practical, other than the real diehards, I have seen very few people actually go up into the retroperitoneum. So I don't, that's a practical answer. And nobody at my institution does. We all go up to extended lymph nodes, that's fine, but not beyond that.
Dr. Dasav Ghosh, sir. Sir, Sudhir Raval sir from wants to say something, please go.
आवाज आपकी आवाज आ रही है.
Actually, I just wanted to show before, you can go ahead with other OTs. I have taken the lateral ligaments on both sides, here and here. On right side, I had to put multiple clips because of, because I was very close to the prostate.
Right.
Now, the defining, just a tip of doing the surgery, when you come anteriorly, you can go rather here, but I generally prefer to come from the lateral side. You can see the prostate, because prostate is already defined, so I'll come from the left side, lateral side, and then come in the middle to the bladder neck and urethra.
So what is the advantage of coming laterally?
Say that again, Ravi.
What is the advantage? Is it not easier to just cut in the middle?
Yeah, in the middle you can probably lose the landmark. If you come from laterally, then you know where the prostate is, and you will not lose the landmark. Because you may enter in the bladder or something, if you go straight away. Like here, if I go here, I may not be knowing that very well that I am at the bladder neck or somewhere else. So if I come from laterally, reflecting the bladder up from the prostate, the bladder neck and urethra gets automatically defined easily.
So what if
This is a one shot.
What if you use the junction of the seminal vesicle and the prostate, that as a landmark to open the posterior bladder neck?
No, that can actually be very deceptive sometimes. Okay. And I have seen this in the beginning of when I started doing this surgery.
Okay.
So started them using the lateral, from the lateral side, but definitely in many times it will be okay, but if the patient has had some surgery or there is a big median low, so coming from the left side, lateral side is I'm more confident. But definitely with the experience you can definitely come in the middle and straight away to this. But you can see on the both sides, as in this case, because on the already left side you know the prostate where the prostate border is. And this is the blunt and sharp, so you just keep reflecting the bladder off the prostate. It comes, so there will be some bleeding always, but best of not, no worry, you can just buzz them. So long you are not at the apex. When I go to the apex, I just buzz the artery, not the vein. And most of the time we do not open the DVC in this technique. We will be below the dorsal venous plexus. Even if it gets open, you can easily repair that.
Right.
So you can see that lateral prostate this thing, and I am coming in the middle. So it defines very well. So this is the practical point which I have learned in my doctors. I keep telling to my juniors and everyone.
Right.
You see?
You see, it's very tempting. It's very tempting to give an incision there and open the bladder. But then this is somebody with an experience of exactly 0 in this surgery. So I really have no experience of this surgery at all.
See, this is the median low value.
Yeah.
Yeah.
It looks very nice. The way the prostate stays behind and the bladder peels off, it looks very pretty.
Yeah, and then when the patient comes back to you, in follow-up, you feel happy that he nicely confident within a few weeks.
Yeah.
So you can go ahead with other.
I think Dr. Tanujindal wants to say something.
I'm just, am I audible?
Yes, yes.
Yeah, we're doing the apical dissection. You can see a benign nodule of the prostate, which is slightly jutting out. I will show it in a while. So we have done incremental announcement on the right side, and we have taken the entire neurovascular bundle away on the left side with the prostate. There are the peculiar findings in this patient. I'll show it to you once the camera gets in. So I have already cut the DVC. I cut the DVC cold. So I believe this basically helps us in identifying the urethra better. So can you see that this one? That's a nodule of the prostate which is jutting out. Right? And this is the urethra.
Yes, yes.
So there is a nodule which is actually jutting out. So you have to be cognizant because apex can be tricky in these cases. So what my third arm is doing is basically put the prostate down towards the pelvis, and I have overswung the dorsal venous complex, and here I would cold cut 50 times, so you can already see the urethra here. There are some strands of fibers there, which I am now going to dissect. My idea is to prevent as much of the urethral length as I can without compromising on the margins. So probably this seems to be adequate to me. Water?
So what is your camera right now, Tarun? Is this a...
It's a 30 down. It's a 30 down, sir. It's a 30 down. I 30 degree for the entire case. I don't flip cameras.
Okay.
Do you have a catheter in? No.
With a 30 down, the view is a little more vertical generally. Okay, sure.
So that's why I undercut. So I'm basically, if you see my scissor is like this.
Yes.
So I'm undercutting. You can already see the catheter coming into picture here.
Actually, you can see it better than us.
So this is the catheter, sir.
Yeah, I can imagine, I can see it now. Yeah, okay, fine.
So now I will be going all around the urethra, so I'll remove the catheter. Can you lift the catheter? Right. Suction.
Yeah.
Switching to zero does give advantage.
It's fun. I mean, yeah, if this particular juncture it's surely fun. Because you see as an exam, it can, yes, but we are habituated to this, so we keep on following the same steps. So you can see this is the Virumandam. Can you see that? Can you see this?
Not very sure. Yeah, we can see it on the big screen.
So that's the Virumandam.
Yes, yes, absolutely.
Can I connect with the? Hello, Raju sir?
Yes,
Yes. Yeah. See, here I would like to tell you a few things. Here,
we can't see you, Raghu. Can you switch to Fortis for the image? Fortis for the image.
can you see?
Raghu, we don't have your image. I can hear you, but we don't have your vision.
Can you connect with them?
Yeah,
Video, please.
video from Fortis.
This is very important. No, endo vision video.
No, we can't get your image at all.
So I want to make a quick and very important point, which is a very useful technique for Indians, where we are using only 3 arms.
Right, go ahead. We can now see.
Okay. Can you see?
Yes.
So here, I took 2-0 white wheel suture, about 30 to 35 centimeters. I have taken just one at the base of the prostate,
Right.
one here, one in the midline, one here. This hardly takes about 5 minutes to take these sutures, right?
Okay.
So instead of assistant holding all these things, okay, we can, as we are not going to use progress in any case, we can utilize this to pull out, this to retract. It's very easy. And most of the times, when the assistant is holding these seminal vesicles for retraction, seminal vesicles will be, separated from the main prostate specimen, right? That's one thing. So by taking these sutures, we are going to avoid that, and we can avoid using the progress. That's number one. Number two, when we try to hold the tissue with the progress, okay, some damage will happen because of the instrument. So that can cause positive surgical margins artifactually. So we can prevent that one. Third one, even by using, hello? Can you hear me?
We can hear you. Carry on.
Yeah. So when I try to do anastomosis or cutting the DVC, I've taken a loop. Can you see the loop here?
Yes.
So I can retract this loop using the scissors. We can utilize the scissor to retract this, and I can start, suturing the DVC. So these are the advantages of taking this suture at maybe 5 or 6 o'clock. So this hardly takes 5 minutes, and this prevents positive margins, and it's easy to retract, and you can avoid using one extra instrument. Can you make it?
Very interesting steps, Raghu. Very nice and very interesting.
So if you take one stitch in the midline, assistant do not have to hold this one. I do not have to use progress to retract this. So you can see, you can go easily and do the complete dissection posteriorly with this. And I'm using the same needle driver, which I'm going to use for anastomosis. So this way we have probably done more than 100 cases like this. They are very useful. I mean, they are very happy with this. And our paper is also accepted in ERAS next month. Any comments?
No, show us the anastomosis also, while doing it, just tell us so that, your video is on at that time. That is very important for us.
Yeah, and Ravi sir, so far we have not cut the endopelvic fascia.
No, I agree 100%, Raghu. It's a very nicely demonstrated thing. And I agree completely. The endopelvic fascia doesn't have to be divided in the beginning. It can be done later. It doesn't even have to be done if you're doing the hood. I just prefer doing it and showing it because I just think it makes life easier at the beginning to have it open, because I go anterior first always. So it
Correct,
makes the
correct.
prostate sit out in your face. When you've divided it, you can see everything of the prostate, that's all. But this is very well done, and the sutures are really nice.
So I'm not taking any help from the assistant to hold the seminal vesicle. I'm managing myself. It's very easy. You can save one instrument which costs about, say, 25,000 rupees.
Right, very well done.
So here, I identify the endopelvic fascia and I divide at this point of time.
एंडोस्कोपिक भी
prostate निकाल देंगे वरना।
Can you switch to Narayana?
राजीव,
हाँ तो बस आ गए
राजीव,
हाँ, Dr. Rawal, I can hear you.
okay, and I'm just going to remove the prostate. I wanted to show you the, the LTA, how we save the seminal, DBC. So this is the actually anterior part of the urethra.
Yes.
Yeah, which you have to cut, you can put a, your progress or anything, or you can cut it directly. After that, my dissection will be cold, and any arterial bleeder I will buzz. Because we are going towards the sphincter, which is dorsally placed.
Yes.
But you have to stay close to the prostate, and just with the blunt or sharp dissection, the whole of the thing that gets the dorsal venous complex with the sphincter, it will be reflected away from the prostate and then reach to the urethra easily.
Dr. Rawal, have you already placed the bladder neck sutures, or you will place them in the...
No, I don't, I have already placed, that I did, this one I have already placed the bladder neck. This one, 6 o'clock, I have not done it. I will do it after removing the prostate, then I will use 30 days up.
Okay.
Then I will put that suture. That's 12 o'clock, 6, this is 12, this is 6 o'clock, I put it, because you have to retract this thing, bladder up. Any arterial bleeder can be taken, otherwise these bleeders are not of much, concern. They stop once the prostate is out, they stop easily. I was looking at this thing. I did not understand what he wanted to show that the instrument using only 3 instruments in the anterior, or what there was some other thing.
No, he was talking about avoiding 4 instruments by going when he's going posteriorly. He uses the needle holder to retract instead of using a progress.
Yeah.
And he places sutures on the prostatic capsule at multiple places.
Yeah.
He uses those sutures to retract and hold them in the needle holder. So he can avoid a progress by placing those sutures.
Yeah, you do require suture if you use 3 instruments, definitely. Even in radius aspirin, we use 3 instruments. Here I am using 4 instruments because of the workshop, and we put suture on the bladder. So we just reflect it up. We just recreate it.
Each one of us has learned frugality as a part of growing up in this country, and each one of us has his or her own way of justifying it. If you come to my institution, I'll show you how we do it. I can't tell it to you in an open forum, but we will show it to you when you come to us.
Sir, Dr. Amitabh Singh from Delhi would like to give some inputs on the case.
Yeah, please.
Dr.
Can we
Singh,
switch to Delhi, Rajiv Gandhi Cancer?
the central screen.
Central screen, yeah. Audio to the central screen.
Sir?
Yes, we can hear you, Amitabh.
Achha. So, sir, I have dissected the proximal and distal bladder pedicle, superior, or you can say superior or inferior vesical pedicle. So just I wanted to demonstrate the harmonic of SSI mantra. So you can see this is obliterated umbilical ligament which is arising from the internal iliac artery. This is internal iliac artery.
Yes.
So ureter will always be medial to internal iliac artery. So this is a very good learning point for the beginners. So now you can see this is the first branch of you can say either obliterated or internal iliac artery which is going to the bladder. This is superior vesical artery. In female it becomes uterine artery.
And now this is the second artery which is arising from the primary, you can say common internal pudendal or artery or whatever. So this is another branch, this one, which is arising and going for the bladder pedicule. So I'll be just taking with them the harmonic of SSI mantra. So this is in the fifth arm, as I have already told you. So now on the surgeon consoles, I have got two swapping buttons on my foot control. In Da Vinci, we have got only one swapping button, but here we have got two swapping buttons, one on the left side, one on the right side. So for the right side instruments, if we want to, like suppose, if I want to swap between my hot shear and the harmonic, I will press my right side foot switch, swap button. And if suppose I want to swap between the pro grasp and bipolar, I will swap my left foot switch. Now,
We will start needing 4 or 5 arms for each surgeon very soon to be able
yes, sir.
to handle everything. But it's very nice.
Yes, sir.
Gives you a lot of
Now this
options.
is- Yeah. So now I'll be just applying harmonic. You can see. बाद में लगा देंगे. Let's see कैसे काम करता
So
है.
the tip of the harmonic is the original J&J harmonic. Or
So I think they have got tie-up with some third party. So it is not J&J harmonic. It is some Avista or some other company. And
Okay.
They have modified it for their system.
all right.
Yeah. Now you can see that hemostasis is perfect without any bleeding. It's done. So
Yeah, very nice.
precise hemostasis without any bleeding, but for the safer side, I will put a hemoloclip at least on the obliterated umbilical ligament.
I agree completely. I would also sleep happier if I had a clip on it.
Yes, sir.
Raval has some input, sir.
Yeah, let's go to, you can see the urethra, disturbed urethra nicely there. Dr. Raval, we can see you. Audio. Can we get the audio with Dr. Raval?
Ravi,
Dr. Raval,
I'm just going to remove the prostate.
yeah,
So
we
I
can
just-
see you. We can see your urethra dystally.
You can watch my anastomosis when I do. I use 30 centimeter V-lock. कैपिटल निकाल दो पूरा निकाल दो Yes. This technique avoids a lot of steps. So you can do it fast in really selected patients. So करने ना रहो. Once we cut the urethra, you know, the prostate comes on its own. We don't want to disturb the posterior urethral plate too much. So that is why I don't dissect posteriorly. Once I cut the urethra, it comes very easily. Here. So come and give me the double holder and 3-0. Plus at least 30 degree also.
Very nice.
So we will change the telescope and take the, 6 o'clock suture on the bladder neck, and then we'll do the anastomosis using 30 centimeter V-lock.
So you will start with 12 o'clock on the bladder neck.
Say that again?
You will start the anastomosis at the 12 o'clock position on the bladder neck.
Yes, 12 o'clock. Reverse then the anterior.
Yes, it will have to be the other way around.
Yeah, I use 30 centimeter for DVC and continue same thing for the left side anastomosis. For the right side, I will take the 15 centimeter stratafix.
Okay, perfect.
And now we change the telescope to 30 degree.
Muscular pedicles, Dr. Rawat. Suddenly we are.
Hello?
Can you show
That's
us
okay.
muscular?
Yes. See, they are here. Both were dissected in the beginning of, when I started dissecting the rectum, I went laterally, you can see all plain intrafacial, and here they are very well defined here.
Dr. Tarun Jiddal has started his anastomosis.
That is observable.
Can we shift the audio to Apollo and take some inputs from there, sir?
Okay.
Dr. Jiddal,
Yeah.
we would like to hear some closing remarks from your surgery. You've started the anastomosis.
Yeah, so this was a big bladder neck, so I've done a bladder neck reconstruction. So this is posterior tennis bracketing, which we have already done. Because the yard was very big, I have put in a roco to bring the bladder closer to the urethral anastomotic area. And we use a Stratafix 3O on double needle for the anastomosis, and anastomosis is routine. I mean, there is nothing special about it. Just needs to be watertight, and that's what we are going to start with. And meanwhile, let me show you the prostate. So if I can, so this is the seminal vesicle area. This is the apex. You can see the jetting of the nodules of the prostate here. This is the urethral margin which we have taken. This is the median lobe. This is the anterior lobe which we have here. That's the bladder neck. And if you see on this side, we have spared majority of the nerves because the prostate appears to be bare. But on this side, which is the tumor bearing area, we have taken the entire neurovascular bundle along with us. Can you see that?
Yes.
That's the difference.
Yeah,
Thank
well
you.
done, Tarun. Very well.
Thank you, sir.
I think we need to also appreciate that Dr. Arul's managed to get the prostate out in less than, 45 minutes to an hour, so beautifully done on all sides. Very well done.
अभी तीन लोग निकालना चिपक रहे हैं ऑडियो बंद करो ऑडियो बंद एक्सटर्नल वाला बंद
Can we go back and see what Raghu is doing?
Yeah. Can you hear me, sir?
We can hear you, but I don't think I can see you.
Yeah.
We don't have a video feed, I can hear you.
First one is
First one is Tarun, ये cystectomy है बीच में.
Ability to switch to bodies.
Yeah. I can probably.
So we are closing the screen for Dr. Tarun Jiddal from Apollo and shifting to Fortis. Thank you, Dr. Jiddal, for your excellent presentation.
Well done, Tarun.
Very well done.
Can you see?
I don't think we have your video.
Fortis,
here.
just a second, sir, we will just put you on screen. Fortis to be on screen.
Yes. Now we can see you.
So I just divided the DVC,
Yes.
preserving all its attachments. You see here?
Yes.
The endothelial fascia, which is reflecting on the prostate, I preserved to have a best, it is like anterior edge sparing. I went very close to the prostate. There was one nodule. I wrongly entered this plane, then I revised that. Can you see? The capsule is intact here.
Right.
On the left side, this nodule is projecting outside. So here I am going very close because this is organ confined disease. I don't want to, compromise on the sphincter. So I am going very close to the prostate. So this is the urethra. I am going to cut. Can you show me? Or better, I can suture this so that the bleeding will be less. Let me just suture that.
So, Raghu, do you sometimes feel that if you were to take those fibers of the muscle inferiorly at the apex, it gives you a little greater length on the urethra, so you can
I think so, sir.
you can
Yes.
appreciate the length a bit more. So I tend to
Yes,
sweep
yes.
all of that off, and it gives me a little more visible.
Exactly. I totally agree with you. Here's little bit of difficult anatomy is there. You can make out, I'm using the 0 degree, with 0 degree this is coming in between. I'm measuring my scope. Just underneath that, it is hitting, my scope is hitting, I cannot move.
Right.
Okay?
Yeah.
And see, I'm preserving all the reflections of the endopelvic fascia onto the prostate. So that gives better support to the sphincter. It is not just the length. Even the support system is very important. See, I am not dissected. Earlier what I used to do, can you see here?
Yes.
If you cut the endopelvic fascia, you end up cutting the endopelvic fascia up to there.
Right.
So I don't do that. So the advantage of leaving this endopelvic fascia till you start cutting the DVC is you can preserve these attachments. This is endopelvic fascia, part of the endopelvic fascia which is coming onto the prostate. So this will better preserve the function of the sphincter than going there. And it also probably get the better length. What are your comments on that, sir?
Slightly different from what I do, Raghu. So that doesn't mean that what you're doing is wrong or what I'm doing is right, but it's just slightly different from what I do. I tend to open the endopelvic fascia right in the beginning, like I said, and I tend to define all the sides and the margins of the prostate before I divide the urethra. So that's just the way I do it. It doesn't necessarily have to be the only way. There are multiple ways of doing it. I just like seeing a length of the urethra before I divide it. That is the way I prefer doing it.
I have some issue in measuring my needle driver because of this bony projection.
Right.
So we always cut the DVC, then suture it. Of course, we may lose little bit of blood loss. We may lose little bit blood, maybe around 50 ml, but it's worth. I can precisely suture. Risk of bleeding post suture after cutting is very less.
Yes, I agree with that. Also, we've stopped doing the DVC suture in the beginning. We now do it only after dividing it. We used to do it in the beginning when we were afraid of unclean field, but we no longer do it. So now divide first and suture later.
This is more secured way of controlling the DVC. Otherwise, what will happen if you suture the DVC, then cut it, the sutures can become loose.
Completely agree. Yes.
This is what I see. Here, I can probably utilize my suture. I mean, for suturing the DVC, I can utilize even this.
Yeah, which I think you showed us. That was nice.
Yes.
But unfortunately, you need the right hand. Oh, you've got two instruments on the right side. So
Yeah,
you can.
that is the advantage, sir.
Right, right.
So I'm retracting, and without taking help from the assistant, I can do this job.
Right. Yeah,
I have some difficulty in the vision and memorizing this needle driver because of this bony prominence, but we can manage that.
So sir, it's 11:15 and we are at the closing part of our first session of the surgical workshop. I would like to give a lot of thanks to our chairpersons, Dr. Rajiv Kumar, Dr. Bastav Ghosh, Dr. Gopi Chand, and thank you Sharanjit sir for helping us out with this session. The next set of people who are going to take guard are sir, Dr. Kalyan Sarkar sir, can you please come on stage? Dr. S.K. Raghavan sir, and Dr. Srivatsan sir, please come on stage for the chairpersons. And I would like Dr. Saptoshi Mukherjee to moderate this session. So this session, at present, 3 surgeries are going on, as we see on screen. All the surgeries are at the latter half of their progress. So I would request Dr. Dr. Rajesh Adapala to prepare himself, and we can start off with a small surgical technique video of the day session. It's a 7 to 8 minute session, crisp lecture. So I would ask him to prepare and start off the session with this small lecture.
Hello. Thank you, Shumantro. I must say that SOGOCON is on its full way. Good morning to all of you. Wonderful, skillful presentations going all around. So now we would like to have the crisp academic presentation on negotiating the robotic learning curve to minimize complications by Dr. Rajesh Adapala. So if we can have Dr. Adapala on stage.
Good morning, everyone. Yeah, I'll hold on. Yes, yes. Sure, sure. Can I start? Yeah. Good morning, everyone. I'm Dr. Rajesh Kumar Reddy Adapala, greetings from AINU Hyderabad. I'm going to discuss the strategies of negotiating the robotic learning curve to minimize the complications. So I have taken a couple of videos from YouTube. So before going to the core topic, what is learning curve? Learning curve is a correlation between a performance level of a learner and the number of trials or time required to achieve that skill. It starts with slow beginning and gains the momentum till it reaches the proficiency. Once he reaches the proficiency, it becomes plateau again. So this is learning curve. So what are the strategies of negotiating the learning curve? There are two objectives. Number one, shorten your learning curve to a significant extent. And second thing, ensure the patient's safety throughout your learning as well as after learning. There are 4 psychological or cognitive phases of learning curve. So number one, initially the trainee doesn't know what he doesn't know. So that is unconsciously incompetent. He is not aware of his incompetency. Then slowly he will get to know what are the things, what are the limitations he has got. So then he will become consciously incompetent, then he gains the momentum, then he reaches a consciously competence level, and slowly once he reaches the competency level, he will not care about the competence levels, all these things, he will keep doing the things. So these are the 4 phases. So first and foremost important thing is knowing what you don't know is most important thing in the learning curve. So know your basic skills properly. And learn and practice. It is not ethical to learn on the patient directly. It is very harmful to the patient and it causes adverse perioperative outcomes. So you have various simulators which are available like benchtop endotrainers, animal models, cadaver models, and the virtual realities with their own merits and demerits. I'm not going deep into that. And this is the hydrogel model which I observed in Johns Hopkins recently. Here the mentor is trying to demonstrate how to hold the needle and how to take the bites for vesicular erythroanastomosis during robotic radical prostatectomy. So the hydrogel models are almost similar to the natural tissue texture.
Just a second, Dr. Adapala. I think Dr. Sudhir Raval has a 1 minute input regarding a step he's going to start.
Yeah, sure.
I'll just ask you to pause for 1 minute.
Yeah.
The audio to RNT, please.
अच्छा अरे यार मैंने वो दिखा दिया हेलो विमेश बताओ
Sir, we can hear you.
sorry actually I wanted to show a suture when you do this analysis, especially at you can say this is 12 o'clock, then 9 o'clock, 3, 6 and 9. You go to the 9 o'clock suture, that's very tricky situation in Rutgers pairing and osmosis. And here the middle has to be like this. And you have to hold it with this and then you come inside. And many times in the beginning, the juniors I have seen, they tear the bladder and neck. So it's a very strict movement like this. So this is just understand that this is the most difficult part of the anastomosis. Once you master that, there is no problem. Like this, you can see it has come. So that's the only thing which I wanted to show. I have already done that. Please go ahead with your presentation. Sorry to, coming in there. Please go ahead. Thank you.
Thank you, sir.
Yeah, I'll continue the presentation. Next most important thing is finding a good mentor or make sure that good mentor is finding you. Anyway, so the mentor is different from teacher. Teacher just instructs you what exactly to be done. But mentor guides you, trains you, supports you, motivates you, and he directs you towards the goal. Having a good mentor with inclination towards training with dual console is a boon for the trainee. Whenever you are in trouble, mentor will take over and he will correct you in real time. So it reduces the patient's perioperative complications significantly. Modular or structured training. Start with less complex cases initially, gradually progress to critical steps like highlight dissection, enucleation, nerve sparing. That's at the end of your training. And repeat the same steps as many as possible. And in the initial practice, select your cases. Select less complex and low-grade cases as much as possible to avoid complications. And how many cases to become competent enough? There was a interesting study published in European Neurology in 2019, which studied impact of surgical experience on perioperative outcomes after partial nephrectomy. Surgeon could get plateau after 150 cases for warm ischemia time. However, for perioperative complications, trifecta complications, they did not reach plateau at all. That means even after 300 cases. Here they reached plateau for warm ischemia time at 150 cases. Here even after 300 cases they did not reach plateau. That means the more cases you do, the lesser the complications and better patient safety. And keep your confidence levels at an optimal level. That is very important because there is an interesting observation called Dunning-Kruger effect curve. It is true for many of the beginners. Initially, after learning the basic surgical skills or robotic surgical skills, they overestimate their skill. So their confidence levels will go up to the Everest. And then they'll get some complications because of the overconfidence. Then the confidence levels will go down to the valley. Then actual learning starts. So avoid this overconfidence. Should be neither diffident nor overconfident. Be flexible and open-minded. Ask for help whenever in trouble. Don't hesitate. Don't hesitate to convert to open surgery. And keep learning collateral things like laparoscopy, open surgery, endoscopy. Whenever you get opportunity, keep learning everything, including the non-surgical skills like communication skills, interpersonal skills, video editing, everything. Keep learning the things. During my residency, there was a wrong notion that laparoscopy is not required for robotic surgery, but it may not be true. So laparoscopy, there are many things which are similar between laparoscopy and robotic surgery, starting from patient position, creating pneumoperitoneum, port placement. Even the laparoscopy and robotic view are entirely different from open operative view. And you got to be a good laparoscopic surgeon to assist properly during surgery. You want to be a good bed assistant, you need to have a laparoscopic skills. For small, like simple surgeries, like simple radical nephrectomy, you don't need to resort to robotic surgery every time. You can do lap radical nephrectomy. And whenever in trouble, if there is any technical error with the robo, you can finish the job with laparoscopy. So never underestimate any the surgical technique or non-surgical techniques. Keep learning the things. And team learning, be it a bedside assistant, anesthetist, scrub nurse, floor staff, let them get orientation towards the robotic things, they'll help you a lot. And sometimes you will you will get to know many things from them. Track your skills. Have an honest self-assessment, record your surgeries and review them critically, show to your mentor, show to your friend or senior, and let them assess critically, let them, give their comments, give their inputs, so that it will improve their skills in the faster way. There are various track assessment tools like global evaluative assessment of robotic surgery for motion metrics like depth perception, bimanual dexterity, efficacy, force sensitivity, everything. And even recently My Intuitive app, which was introduced by Intuitive, you can even track your dexterity, track your the economy of the motions, and you can even know how many times clashing happened, instrument clashing happened, how many times instrument went away from the view. These things you can track. You can even compare with the global standards. You can compare with the global average and even the top 10 robotic urologists in the world. And be up to date. You know that evaluation of the medical field is a process of continuum. Every time, every day we'll see the new things which are important, and keep try to keep pace with them, and that is very important for the patient care. For example, this 3D modeling which happened, which was introduced recently. This is our patient with endophytic tumor. So with the 3D view, we can understand the tumor location and its relationship with the vessels. We could do partial nephrectomy. The iris, you can view the 3D. You can view the 3D model right in front of your eyes through the Trial Pro. You can even manipulate during surgery. Augmented reality. Superimposition of the 3D model onto the target organ and navigate your dissection. And the next level is metaverse. Here the surgeon's avatar goes inside the metaverse. He analyzes the tumor location and its relationship with the vessels, pelvic calcium system thoroughly. He will try to rehearse on it before going for actual surgery. So that definitely improves the perioperative outcomes. And most important thing is not only learning, learn to unlearn and relearn. Empty your cup whenever possible. So outdated things, you leave it, get new stuff. Once the cup is fully, it is already full, you cannot fill it again. So what is the problem with the full cup? So you will become mediocre. After reaching the plateau, you will stay there only. And sometimes you, with the continuous efforts, you will go to the next level. Otherwise, sometimes there is a risk of decay also. Your skills will get downgraded. So keep updating yourself, keep emptying your cup in regular basis. Surround yourself by motivated people who have got positive attitude. They'll keep motivating you. They'll be the source of continuous inspiration for you. You also can set example for your juniors. So at this juncture, I would like to thank all my teachers, mentors, directly or indirectly inspiring me, motivating me, or mentoring me. Thank you.
A wonderful presentation, I must say, and most importantly, it was within time frame. So, Kullan sir, if you would want to give your inputs or ask anything. Definitely. So, Shubhendra, if we can move on to the video to Rawal sir or any of the centers.
Yeah.
We are moving to the video 40s.
Sudhi sir, we are with you.
So can we have the audio of Shudhi sir? And thank you, Dr. Rajapal sir. So
Thank you. Yeah.
It was a wonderful presentation. If we can have inputs from Shudhi sir.
Audio input from RNP, please. Audio input from RNT, please.
Sujit sir, are we audible from the hall?
yes.
Okay, sir, if you could kindly carry out with the steps. We missed you out as the presentation
I
was
was
going
doing the
on.
last verses, just going for doing the final touch-up of taking the bleeders, and they are putting the catheter, actually catheter now. We are reinserted in the villain. ये क्या ये catheter है यहाँ पे? हैं? क्या करो? Anyway, the last verses are finished using 3 sutures. One was 30 centimeter 30. And other was 15 centimeter. The middle is big in the second suture, which you can see here. I generally don't use in a big needle, but this one here, so they gave it to me, but you can use it. If you use big needle, then you have to move your wrist in more complex way. First you take it, you hold from here like this, and then do like this, and then more effort you have to make in comparison to the this small needle. But then it is doable with any needle, only thing that you have to evolve into the technique. It's not a big deal, anybody can do. I think many young guys are doing religious skill. Any question you want to ask me, any technical, some question?
Dr. Rao?
Yes,
Yes, this is Dr. Kalyan Sarkar.
sir, good morning.
Good morning, good morning. I just wanted to ask you, what are the specific indications and contraindications of doing this particular approach? It's a very elegant demonstration, but where are the situations you would recommend it in preference to all other techniques in your practice, and where you...
Yes, sir. So, sir, for beginners, they should do a small prostate, preferably in the low intermediate risk, but as you grow, as you learn, you can use this technique in any prostate, big prostate, post-URP, median lobe, anything you can use. I generally do most of the cases using this approach, except the patient who has had locally advanced disease, PSA high, bigger prostate is not contraindication, especially in the high-risk cancer patients. They can do the extrafacial dissection when you use this approach. The advantage is I already told you the return of continence is very fast. So with experience, you can remove any prostate from this approach, but I prefer to do in the patients who have prostate around up to 80 gram, up to the 80 gram. Preferably a smaller prostate, you really enjoy the dissection. The larger the prostate, you have bloody dissection, but then it is doable in any type of prostate, except that locally advanced prostate cancer where we have to do extended pelvic pelvic really has to go low on the ligaments and lateral ligaments. There I will go for anterior.
So what is the situation where a man has a large inguinal hernia, or has had previous unilateral or bilateral surgery for hernia? Would that be a sort of a situation where this approach would be particularly useful?
Can you repeat the question?
The question was that, say a person has had inguinal hernia surgery in the past, or bilateral inguinal hernia surgery, or a mesh plate.
Bilateral.
Yeah.
Okay. No, they are the ideal. You don't have to drop the bladder. For male hernia surgery, you are actually between the rectum and the bladder. So you don't, they're very easily doable rather. It's preferred that you do.
That would be an unique indication for this.
So they are the best patient rather if you do this. See, I replicated the surgery in open surgery also through transcoccygeal approach. Unfortunately, I could not get the cases to be robotic, but we did it in a open method where we did like a case sparing. The advantage in those patients like doing from perineal or transcoccygeal, the patient if he has a lot of abdominal surgery, you don't have to go to the abdominal route, you can do it from posterior. Same way if the patient has got hernia care or something, this sparing is the best for them.
So what are the current situations where you would not be, be doing a pelvic lymphadenectomy for robotic radical prostatectomy. So you are not able to do lymphadenectomy here.
I'll do the lymphadenectomy. I'll do the lymphadenectomy in patients, but traditionally or according to guidelines, nobody follows them. You can avoid lymphadenectomy in low-risk cancer patient like he has, but we do lymphadenectomy for these patients just to, our sapling or maybe their the Gleason score is different between the pathologist, somebody will say 3+3, other will say 3+4, somebody will say 4+4. So to avoid that variation, we do lymphadenectomy to all our patients because one shot, the best shot is first shot.
And sir, what are your criteria for selecting a patient on the basis of which you do decide a nerve sparing in this sort of cases? So in your institute?
Yeah, nerve sparing, there is definite indication. In young patients with a low risk, intermediate risk, even if there is extracapsular involvement on one side, you can save the nerve on the other side. So especially in young patients, we should always do nerve sparing. And the patient with intermediate and low risk cancer patient, or even the patient with high risk at one-sided involvement with the extracapsular neovascular bundle, you can sacrifice on that. But the other side, you should try to save rather too, because it helps in return of potency, also return of continence is better. So nerve sparing is definitely preferable in wherever it is possible.
Right, sir, and from the technical perspective, as we do understand that one of the basic rule of thumb has been that the liveral ani muscle must not be exposed. We should go in between the prostatic fascia and the liveral fascia. And your special tips and tricks on that, sir, on that particular technical step, sir?
No, actually, everybody has a different technique. If you go and see the Vipul Patel, he will first go and cut down the pelvic fascia only, and even then he does very nerve sparing. Nerve sparing is mainly associated with the prostatic fascia, interfacial dissection or interfacial dissection, where you can do the best nerve sparing. Cutting the endopelvic fascia doesn't matter actually. So without endopelvic cutting, without cutting endopelvic fascia, without cutting prostatic ligament, you cannot remove the prostate. So the right way people feel that when you are not in the endopelvic fascia, you are probably doing better nerve sparing. I think that's not correct. Everybody is comfort with that. You can do that, but then the nerve sparing can be very well done when you cut the endopelvic fascia. You go to the prostatic fascia, put the neovascular bundle down. I'm talking about the anterior technique. In this technique, we dissect from the posterior, and when we put the rectum down and then you laterally, then you can easily see the neovascular bundle as I showed today and reflect them away from the prostate and then take the lateral particles close to the prostate. So it's not that the endopelvic fascia being not put, it will be cut anyway. It will cut a bit over the prostate or you are cutting in the levator ani. That's, I think, probably that. That's why we see. That's why I understand. This is how I understand.
Sir, Dr. Srivatsan here. I have two questions, sir. Where do you think is the most traction injury to the neurovascular bundle? Is it from the red-chase sparing or is it in the anterior approach? And second question is that have you done any post-focal therapy red-chase sparing? Sir, is it more difficult or is it you find it easy? Post-focal therapy.
Post-focal therapy, I have not been red-chase sparing so far. I am anterior radical prostatectomy. Post-hypho, I have done anterior only because hypho I was doing back in 2010, 11. Now we are doing hypho more frequently, so let us see if that is will be getting that and do the red-chase sparing. And your first question was where I feel
traction on the neurovascular bundle is more during the red-chase sparing, or you feel it's the same with the?
No, I feel both techniques are very good in that. There is no difference. I do it with both the techniques and both are same.
Okay, thank you.
So with your wide experience of prostate cancer surgery, if you were of all the techniques on show, if you were put in a position to do a salvage radical prostatectomy after radiation therapy, which is the approach you would choose?
For salvage radical prostatectomy, I probably go with the anterior approach only as of now, because so long, since I started doing ridgeless aspirin, I have got patient to do the salvage radical prostatectomy. Many patients who are failing now radiation, they go for ablative therapy. Like we have done one case of post-radical radiotherapy. I have done HIFU. I am not getting patient for radical prostatectomy nowadays. But as you said, which one, if it is possible, but definitely I will make an attempt. I will go in the posterior approach first only. If I will see if it is possible going from there, then probably I will go. Otherwise, I will prefer to go anteriorly.
Thank you, sir.
Thank you. Thank you.
With your kind permission, we would like to shift to the Fortis Hospital. They are on the verge of completion of the anastomosis. If we can have the audio from the Fortis Hospital.
Hello? Is this Dr. Raghunath? Hello? Dr. Raghunath?
Raghunath, sir, are you audible from the hall? So, there is some. Okay, so they are on the verge of completion. In between that, we will have another crisp presentation from Dr. Gopichand sir on dealing with a large or difficult median lobe during radical prostatectomy. So if you can have Dr. Gopichand sir on the dais.
We apologize at the outset itself. We have to make a break in between the talk in order to take care of the OR as well.
Yeah, thank you. Thank you very much, Dr. Sanjay Adla, sir, for giving me this opportunity. And thank you, the Council of SOGO, also, for giving this opportunity. You can stop me in between whenever needed. Yeah. Yeah, dealing with large or difficult median lobe during radical prostatectomy. Disclaimer is some of the videos are not mine, and second disclaimer is I think Dr. Tarun Jindal has already shown us in the morning case how to deal it with so beautifully. My talk is about preoperative assessment, median lobe, planning for the surgery, anatomical variation of prostate lobes. You should think ways to tackle the median lobe, various techniques, critical steps to address it, identification of the site of bladder prostate. This is the way I'm going to tell you. It is a potential problem. There are various things that can happen. Difficult posterior plane, we might injure the ureteric orifice. There is wide bladder neck which opens up. This is a true technical challenge. Ureteric injury is a real problem. There are various papers on this that it's a real problem, but these three things are the most affected one: longer hospital stay, longer operative time, more blood loss. There are some papers which are controversial things that they maybe have some poor recovery of incontinence and higher surgical margins, although these two can be contented. Most of the median lobes do not have malignancy in that, so this higher positive surgical margins is a plus minus. Hints to diagnose this: prostate median lobe, ultrasound, MRI. Ultrasound we must all know. There's a small thing about median lobe and posterior lobe. Sometimes the lateral lobe pushes the bladder and will look like a median lobe. This is also to be tackled the same way as the median lobe. We must all learn to appreciate the median lobe. The MRI pictures is a very important thing now because all of us do MP-MRI. So the clues we can have about the presence of median lobe from MRI is there. There is various ways to tackle it. Mick et al. Use this Carter-Thompson needle grasper. There are other groups like Suchin Patel et al., automatic grasper they have used. Some do ureteric stenting preoperatively. Some use rescue stitch and all with Hemlock clip. Immediate visual clues that we get in the morning case also, we saw that the balloon would be on one side and as soon as you open the bladder, you will not be able to visualize the ureteric, the Foley's catheter, which goes most of the time to one side, either left or the right. So the steps in this case is pretty similar. Like we do, it is important to identify the bladder neck, a little more steeper learning curve. It is definitely associated with increased operating time and estimated blood loss, but they have similar oncological or functional outcomes. Most of the time, the median lobe doesn't have the malignancy part in it. Understanding the key steps to facilitate the bladder neck resection is vital to avoid serious intraoperative and maximize the outcomes. Thank you.
Thank you, Gopichan sir. That was a wonderful, enlightening presentation. So, thank you. If we can have a bit of the last minute input from Fortis Hospital, as we can see the anastomosis is on the verge of completion. If we can have Raghunath sir.
Hi.
Yes, sir.
Yeah.
Yes, sir.
Hello, yeah. Here we are taking little extra time because it's a very narrow passage and this bone is coming in our way. Otherwise, we are quite happy with anastomosis. We took the ROCO stitch and now I am doing the anastomosis. 2 layers anastomosis using 3-0 VLAP. Generally we use 4-0 VLAP for the anastomosis. Here they have only given 3-0, so we are using 3-0. We started the anastomosis at 6 o'clock. We are coming using 2 needles. This is the ROCO behind, and we are unable to take the suture here because this is already hitting. Even this also, to take the stitch on the left side, it is in the way, and I am managing with one needle driver. Generally we take needle drivers, so we can easily manage with one needle driver. In clinical practice also we use only one needle driver. We don't take 2 needle drivers. So I am using one needle driver. Any questions? I am happy to take.
So can you, am I audible over there or would you be taking?
Yes. So, Catherine, please.
Morning Raghu, this is Manav.
Take Manav.
So I just wanted to ask you, would you believe that in case of a bony island you would be happier doing an anastomosis on a 30 up?
No, here anatomy is such that if 30 up, I won't be able to see this. I am using 0 3.
So actually,
0 is quite comfortable for me in this situation. 30 up won't be.
Okay, thank you.
To see the floor, 30 up is not a good one. I am quite happy with this, but we are just taking little extra time. That's it.
So Dr. Srivatsan here, would you have been happy with the left-hand needle driver as well?
Yeah, left hand we can take, but I use regular only one needle driver, so I am happy with it. I am perfectly okay with one needle driver.
What would be your suggestion to younger uro-oncologists doing?
No, you should always take 2 needle drivers. Always you can take, anytime you can take needle drivers. Even if I am struggling, I can take 2 needle drivers, but I am not taking 2 needle drivers here. So it's your personal preference. If it is difficult to take sutures on this side, left side, you can take. You can, instead of suturing backhand with the hand needle driver, you can always take the needle driver on the left side and you can suture like this.
Yes.
It's fine. But I am perfectly okay with it. I take one suture here at Pollock so that I can give a traction and I can understand the bladder neck in a better way.
So recently I've started using this force bipolar with the strong arm distinct
Yes,
as a needle driver.
Yeah, we do use that. But because of the force bipolar is longer, and narrow pen sometimes it will be very difficult. I'm taking very thin bite of the
muscle.
See, it is hitting. Can you make?
Yes, sir.
When I go close, you may not realize.
No, that's a big knuckle of the pubic bone that's coming your way.
Yeah.
I always wonder whenever this comes, what would be the nature of the open surgeon's nightmare surgery this would be to do as well.
Any questions? We'll be completing this in the 5-10 minutes.
So with the fear of being repetitive, just wanted to re-emphasize on one fact. During bladder neck division, how to identify between the prostate and the bladder neck? This is a quite common question we do know while incising. If you can just re-emphasize on that fact, sir, once.
Cutting the prostate, I mean, can you repeat again?
Sir, during the bladder neck division part, identify between the bladder neck and the prostate tissue.
Okay, there are so many ways. One, when you put a pre-prostatic fat, the pre-prostatic fat generally ends at the bladder neck. That's number one. And you can pinch the bladder neck and between the prostate. You can slide these two instruments on the surface and the contour of the prostate. That you can pinch it in between. That is the bladder neck. So there are many other ways, and you can pull the inflated catheter. So catheter bulb will come on to, you can identify the contour of the catheter bulb. So that is the bladder neck. There are so many ways.
Right, sir. Right.
Also, it's a good way to see the median lobe as well. You can see the catheter moving sidewards when you...
That's the most common thing, tugging the catheter towards there, so these are the...
I mean, however much ever experience you get doing the anterior, but I think we should all do this maneuver just to be sure that as the first talk was, don't become overconfident.
Right, there is multiple maneuvers may help us out in some problematic situations. Thank you, Raghunath sir. So if you don't mind, we can just shift a bit to Dr. Amitabh sir.
Please.
From RTCI. Dr. Amitabh sir, are we audible from the hall? Delhi RTCI.
Dissection of the bladder. Hello, can you hear me?
Yes, sir.
Yes.
So I have done posterior dissection and completed it up to the prostate. So now I am just dropping the bladder from the anterior abdominal wall. So I did nerve sparing on the right side also. So I can show you some landmarks of this nerve sparing which I did on this patient.
Dr. Amitabh Srivatsan here. I was just wondering why you didn't use the harmonic on the there, though I understand now that you were trying to do a nerve sparing.
No. So I didn't use harmonic for the nerve sparing. I used harmonic for the pedicles only. For nerve sparing, I used only a thermal dissection.
One question.
See, can you appreciate? So this is a very clean surface of the prostate without having any residual tissue, neurovascular tissue at the posterolateral surface of the prostate. So this is fascia, levator and fascia, which is well preserved. So I didn't cut it, I didn't dissected it. And even you can appreciate I am teasing off all the fascia from prostate, whatever left on the prostatic surface. Now this is the non-velar fascia posteriorly on the prostate. So these are few clips which has been applied the prostatic pedicle just to separate the neurovascular bundle from the prostate. So could you see this prostate?
Yeah, I can. We can see. We can appreciate that.
So can you appreciate this surface?
Yeah.
Posterolateral surface of the prostate?
Yeah.
So it is completely actually nude, you can say.
Yeah. So you're almost stripped off the this thing so that you're preserving the.
Yeah, exactly.
Is there any use of preserving the fascia per se? Like you're not looking at the continence here, right?
So actually, this is patient is this patient has been planned for ileal conduit. So it doesn't matter whether you are preserving the levator fascia in this patient or not. Okay. So this is just technical demonstration with SSI mantra that all these things can be possible with SSI mantra. So there is no limitation to the mantra. You can see.
Okay, great. I have just one question. Similar to the intuitive harmonic, does this harmonic have a? I think the intuitive guy's harmonic also doesn't have an endo wrist. So does the SSI have an endo wrist of the harmonic, or is it like the same?
It doesn't also have any endo wrist. Only you can rotate this harmonic.
So it's just a straight harmonic which gets rotatable. That's,
yeah. Straight harmonic. You can rotate it clockwise and anti-clockwise, and
because I think endo wrist will help you if you're going to go to the pedicle of the prostate and all those things riding on the rectum. So exactly. I think like an end seal, but I think here.
But because of the technology, we can't have an endo wrist on the harmonic.
Yeah, because it's proprietary, I think. Second thing, exactly. We have a vessel sealer in SSI mantra, which is similar to extend in.
No, sir. So this is the first energy source with SSI mantra, and this is only harmonic. We don't have any vessel sealer with the SSI mantra.
Okay.
Yeah.
Thank you.
But we do have clip applicator also.
Okay.
So we can apply 10 mm with the Hemlock applicator.
Okay.
Just same as Da Vinci.
Okay.
Here
Is it the same
you
like
have-
Hemlock diopter or is it something?
Yeah, exactly. Yeah, same. You can use some like Indian ones also. It's not mandatory that you should always use VEC because the configuration and the size is same.
Similar, okay.
Yeah, so similar.
So considering the fact you have been doing SSI for quite some time now, what is your, I would ask you the truthful this thing that you seem to be quite comfortable doing that, though I think the consoles seem to be slightly different from what I have seen before. Is it something which has changed in Mantra 3 or is it very similar to what you had before as well?
Okay, so in Mantra 3 actually they are trying to incorporate their Maya system also. So where you just need to wear a goggle where you will have all the 3D vision just like we are having this video games camera. So you will not have to use this 3D vision in front of
Because you
need
seem to be
have-
moving your hand in the hair more, like it looks like that.
Yeah, exactly.
So, okay. What is your, I mean, I'm pretty sure you had a input regarding SSI Maya. So what's your, I mean, have you seen that and have you used it or something like that?
So till now I have got the demonstration of Maya for just having a OT setup. I didn't use it for the real patient setup.
Okay.
Where you just operate the patient and you don't use any screen, you are just using the head-up camera lens.
Okay.
It is under trial, probably in very near future we will get that thing for testing because whatever they make, we do test after getting a clearance from IRB and the Government of India Authority.
Okay.
Just like we did for Mantra 1, Mantra 2 and Mantra 3. And after that probably we will start having this in the market.
Do you think this is going to be a game changer?
For this thing, head camera?
Yeah, the AVR kind of thing.
I don't know till now because I haven't used it. So we need to see, especially for the dizziness and how well the surgeon can accommodate with it. Because all these surgeries, they are almost 1 hour, 2 hour, 3 hour surgery. So we need to see like how much surgeon is comfortable with this head-mounted goggles with 3D.
Dr. Amitabh, Dr. Rahul sir wants to
have a closing comment.
Yeah.
We'll have Sudhir sir.
Hello,
sir.
So
I just wanted to make on, you were talking about harmonic.
Yes.
In Mantra. Right now, harmonic in Mantra is from third party, is Chinese probe. The problem with this probe is it's a smaller probe than the other robotic arm. That is why this fifth arm has to be docked a bit more down on the right side, and also we can now use the long probes which can avoid further cluttering. Though cluttering doesn't happen even with this setup. They are working on high-energy probe, where hopefully they will be given the endurance also. So once that comes, then probably things will change anything, especially for doing this, like cystectomy and maybe intracorporeal diversion. So that's what the comment which I wanted to make. I think
I feel a straight harmonic in a robot doesn't make any sense, sir. As well as my experienced assistant could do the same thing with a straight harmonic. So that's what I was saying.
No, say that again, I didn't get you.
I think a straight harmonic without the endorist doesn't make any sense because my assistant
I think only this is difference to the GT surgeon in the liver.
Oh, yes, sir.
We use without endorist and military don't require endorist. They do for hepatectomy, not for us. Always, I think unless they have endorist, we probably not be able to use it as frequently as a surgeon are doing.
Yes, sir.
Doing hepatectomy, they are using regularly the thermometer. I have told them that if you want to make thermometer, make with this endorist, otherwise there is no advantage for us. Hopefully they will do tomorrow. Dr. Suresh Shastra will be there. You can interact with him.
Yes, sir.
They are working on it. This Mantra 3 has sleek arms. We can actually very easy to talk this robot as we do in F5. Mantra 2 we are having problem, especially in the kidney surgery. So that thing is improved with Mantra 3, and I still don't feel that the ease of using a robot is same as Mantra 2. Otherwise, even unheard can tell you so everyone, they are celebrated like mantra too, but they have huge potential to improve in mantra in future, because of the data is sorted out, which is the most important actually. Then you can make a lot of improvement in future.
Understand, sir. Thank you, sir.
So, thank you, sir. As we are continuing with the various surgical demonstrations, in between also we would have another interesting talk by Dr. Sanjay Shurekha, that is sporting with the post, about the nuances and innovative usage of port placement. So, if we can have Dr. Shurekha, sir, on dais.
Yeah, a very good afternoon. Thank you, Dr. Sanjay Adla, for giving me a very innovative lecture. And when I saw the title, I was a little confused. I thought probably he has, instead of port, he has used post. So I went through all the, now Googles are always available, so I Google it, and then I realized I am going to give this lecture in the city of Calcutta, where there is a famous race course, and lots of betting and gambling is there in the Calcutta. Probably in cricket betting, cricket gambling, race course betting. So sporting with the post is basically a media platform that give you all the information regarding horse betting and betting in different kind of sports arena. So this is the sporting with the post. So I don't think I want to make you a gambler, but I will try to aid you in for being a better laparoscopic and robotic surgery with some tips and tricks in port placement. So I will discuss few basic philosophy of port placement, and then I will discuss some organ and approach specific modifications. Just a few slides regarding the access sites and access approach. You can have a close access like with a varus needle at the palmar point, as we all know. So in kidney surgery on the right side, you can use the opposite of the palmar point on the right side. And for the pelvic surgery, either you can put a varus needle at the umbilicus, or I usually prefer either left or right iliac sides. Probably it's your experience and preference. Though I am a proponent of open access for the access, initial access, so I always like to put a access through an open technique, except in robo, because putting the 8 mm in XI after open technique there is always leak. So you can use, there are other VisiPort and all, so different techniques. If we want to understand the basic principle of the port placement, we should understand that port placement depends on the patient anatomy. As you can see, is there any, that laser? So you can see there is a thin, tiny patient where the ports are so clustered. As there is below, there is an obese patient. So definitely your port placement will vary a little bit according to the patient's anatomy. And the targeted organ you are targeting basically for kidney or adrenal, then maybe you are doing an nephrectomy, so there may be minor modification in port placement. For pelvic organ, there may be some other modification. And definitely your preferences as well as your experience, the way you have been trained. I believe the way I have been trained for port placement, I am always comfortable even today. Some modification for the other surgeon, maybe they are comfortable, but I may not be comfortable because the way I have my ergonomics and my mental makeup has been developed over so many years. There are a few basic understanding about the laparoscopic port placement. You have to be very careful so that you can have an adequate space, and a triangulation technique or diamond shape technique with ports at least few more than 10 preferably centimeter away, and the head or tail of the instrument should never cross. This is a basic understanding. So this is known as a crossing shorts. So you should avoid crossing shorts. So as I said, the diamond shape approach is a very popular approach. Right. So here you can see this is a diamond shape approach where the target, this is the target organ, and this is your camera port and left and right hand port. And the additional port can be placed according to your personal preferences. Like I always put additional port for any kind of kidney surgery here, and on the lateral edge of the diamond this side. And sometimes if you need additional port for bowel retraction, or sometimes there's some injuries, you need to use another extra port to tackle with the bleeding and all. So here I can, sometime I put a port. And the additional port sometime for the, when I want to retrieve like after nephrectomy, if I want to remove the kidney, so I, instead of this port, I sometimes use this port and put an incision in this area and remove the organ through the same port holding that specimen by a grasper or so. So there is a philosophy of linear port technique. This is what I said is a diamond shaped triangular technique. There is a philosophy of putting a linear port technique. So in linear port technique, there are certain advantages. The one advantage is that camera is usually canially placed or quarterly placed, depends on the target organ. And the surgeons and the assistant who is holding the camera, they don't clash. So either the camera holding, the cameraman is on the canial side and the surgeon is here. Though I am not very comfortable because my ergonomics always allow me to a better to do my work in a more comfortable way with this technique, but there are surgeons who are comfortable with this technique. Sorry. So how the site, there are certain site difference, like if you are doing on the right side, so for liver retraction I always put an additional port here. That always give me extra comfort, and another extra port here or here depends on the anatomy and the kind of surgery I am doing. So for port placement, this is a very basic diagram that will give you understanding that this is a rectus muscle and this is a mid-clavicular line. All your port should be in this zone. You should not go beyond this mid-clavicular line. Then you will be too close to the organ, target organ, and you will have a difficulty, and your angulation and ergonomics will be bad. So your angle with the horizontal line will be more than 60 degree or 70 degree. That will give you a tiring in your arm. So for pelvic cases, it depends on what kind of approach, robotic versus lab, you have your port placement. Again, various robotic platform has a different port placement like SI and XI. In XI system, the port placement, the life has made lots of, life is easy. You can have a straight line port placement, little curvilinear. But you can see in the SI, there was some triangular technique or some variation, and sometimes it's difficult. Again, if you are using retro and trans, there will be a different port position. You can see in the, this is iliac crest in a retro. So I'll explain it later. So now organ is specific. So like I said, if you can see here, I am using this extra port and I have given an incision. Sometimes I use a grasper to hold the bag, endo cash bag, and I remove through this port. I can use even a hemolock applicator with a this umbilical tape. So hemolock with an tied with umbilical tape. So I put the hemolock on that endo bag and I bring it out with that port, and a small incision I can remove the given kidney and all. So these are my innovative variations in. In this patient I have placed an extra port because patient has sudden bleeding from the renal vein. My resident was doing. So whenever there is a bleeding or something uneventful which was not planned for, you always need a traction, extra port, maybe additional 2 more ports to deal with the situation. So there is a small video here. I was doing a right lap. I don't know how to place this video. So I was doing a right level 3 IVC thrombus with laparoscopy, and you can see I am putting additional port of 12 millimeter on my left side, on the left iliac fossa. So how that will help me, you will understand, because it was a big mass, so I was not able to put a hemolog through on the right side 10 mm port. So this port will help me to, pull the kidney up, and even I am using the hemolog or clip applicator through this port, and that is ergonomically more correct than the right upper port through which conventional hemolog being placed. You can see I am putting an hemolog here, and you can see the quadrate lobe veins and everything was clipped. So that I am not showing the complete video. So you can have some freedom if you can have extra port on the your left arm with a 12 millimeter or port, so that you can use in this kind of scenario. You can get bail with that. So in XI, commonly for kidney surgery, this is the port placement. As we know, this is the rectus abdominis muscle. Here this is the straight line. But we have some variation, and probably some surgeon have some other variation. Normally what I do, I put an, the forearm is little on the iliac fossa curve, like this curve, so that help me use this port for removing of the organ, and sometimes clustering, it prevents the clustering of the arms. If I am doing a distal uretrectomy and bladder cuff with repositioning, sometimes we need to do a repositioning, then this is fine. But if I want to do with XI without repositioning, I think that's fine. Yeah. So you can see there is a very small tummy, and it was difficult to put another port here. I have almost reached at the pubic symphysis level. So I had to put a port here, but I had to reposition the patient. However, if I don't want to reposition the patient, then my port placement for nephrectomy would be like this. So this port will be, the fourth arm will be more medial than lateral. Like here, if you can see on the right side, I am going like this oblique direction instead of this direction in a nephrectomy. Here, I have done a little more modification. The patient was little financially constrained, so I used 3 port techniques. And instead of putting this assistant port here, which is conventionally placed here, this is the head end, the right side. I have placed the assistant port here. That helped me for giving additional traction or putting a hemolog cliff if I require on the bladder side. So now I will come to the bilateral. I don't have any image for bilateral, just I have made a schematic diagram. If you want to do a bilateral partial nephrectomy, I have done with both techniques. I have placed midline port, and with 2 common ports, like assistant ports are common, but the robotic arm ports I have placed in the midline. I felt that is little cumbersome for me and difficult. So I prefer this instead of this. I prefer this. I keep this 2 arm common. However, for right side and left side, I put a different 4 ports. So little extra port, but that gives me a more comfort. So this is a, sometime you get some anatomical variation, like I was doing a lap partial nephrectomy in a left pelvic ectopic kidney, and this was my target organ. So you can see how I have changed my port position for that. So these are some modification according to your need. For robotic retroperitoneoscopic partial nephrectomy, the standard is like, this is the iliac crest, and this is the our technique. Instead of putting a like this straight line, I prefer always a curvilinear port techniques, and I used to put a 4th port more towards the abdomen side, towards the umbilicus, than the lateral side. And you can see the conventionally it is described like 1 centimeter above the iliac crest, but I tend to put this camera port more above, because sometime in XI, especially in the obese patient, if you put too close to the iliac crest, it will having a difficulty in maneuverability, and it will collide with your iliac crest. So I tend to go little higher, and it is midway between the tip of the 12 rib and the iliac crest. Rather than it is too close to the iliac crest. This is a small video. You have various techniques for developing the space in retroperitoneoscopic nephrectomy. So we sharply incise the lumbodorsal fascia. Then after making a space with your finger, you can use there is a port for creating a space. There is a balloon port that is available, but this is sometimes it's not available and it is a costly affair. So we use our innovative hand gloves. I think many of us is using that. So this was just a small video. Again, for lap radical cystectomy, the conventionally this is the camera port is on the high above the umbilicus, and these are your working left, right working port. But I prefer to operate from the right side of the patient. So what I do, I used to put the camera port little on the right side than the midline, and the left hand port more on the right side. So I don't need to change my position. I can do from the right side. That gives me a little more comfort. So for robotic assisted radical cystectomy, you see this is your another port on the left side, the assistant port, that I will put with a 12 mm port of the XI robot, and that helps me to put sometime toggle between these two arms for putting the prographs, and if required I can use this port for my stapler firing. So initially I used to put this 8 mm port as a prographs. Later on I converted this to 12 mm port because sometime I felt that the alignment of the bowel is little different, and sometime I found it difficult to put a stapler with this port. So I can use this port. So I can toggle between this port if I require to fire the stapler. So both port I use 12 mm. You can see this is a 12 mm port and this is a 8 mm port.
Dr. Shureka sir, if you won't mind, we are over with our 8 minutes. If you can wrap it up a bit fast.
You said 10 to 15 minutes. I don't know who said me. So I'm sorry. So there was some little modification again in the prostate, like instead of putting a state port, this is I think for, no, this is for the radical cystectomy. I again showed the 12 mm port we can. And for putting a DJ stent, sometime you can struggle with putting a stent through these ports because of so many clustering of the instrument and robot. I used to put a 5 mm port from here, and I can put the stent through that. So these are various port. I said this is long port, short port. These are important to understand and know. As I said that the 12 mm port on the both left port 12 mm sometimes help me to aligning the bowel. In robotic prostatectomy, I don't have much of the innovation, but I used to put the camera port more higher than the other ports, because this assistant 12 mm port sometimes get blind. I cannot see his instrument is coming, and there was one incident that probably he hit a bowel and it injured. So I put that camera port little higher conventionally than the conventional. This is, I am not going in detail, this is transvesicoscopic multi-port robotic prostatectomy. This is extraperitoneal RPLND, Dr. Ginil's video basically. So probably Dr. Ginil will explain with some of his presentation or something, so I am not going it. Conventionally, there is a video, but because lack of time, I am not going into it. This is a robotic transperitoneal RPLND. This is the way I do. The only modification which I have made over the time, I used to use 12 mm long port than this 8 mm port. That helped me to put a Hemolog applicator if required from this port as well. Well, from the conventional well technique, we have modified to lateral also. Here the tricks which I am using now. Initially there was a clustering of the arms, so I am using all the ports which are long. That is, the conventional port is 16 centimeter and the long port is 21 centimeter. So I am using all the long ports. So to conclude with, you should be well versed with basic understanding of port configuration and standard approach. Ergonomic consideration should include the position of the target organ of interest and body habitus. Innovation and modification should be done as per need and your experience and your expertise. Keep low threshold for use of additional ports. Long ports and 12 mm ports in XI robots often make your life easy. So I would like to thank my SGPJ team, and I have taken some of the images and videos from some other colleagues. I would like to acknowledge them, like Dr. Ginil, I think one image from Dr. Amitabh. So I hope that these tricks and techniques will help you to overcome your worst situation. Thank you.
Thank you, Shureka sir. It was an innovative presentation also. So if you don't mind, we can move on with our OT schedules. So as we have been informed, the robotic adrenalectomy is being started. Laparoscopic adrenalectomy is being started at Fortis Hospital. So if we can have Dr. Gopal Krishna sir. Sir, are you audible from the hall? I'm from Fortis Hospital. Gopal sir, good morning sir. This is Shaptarshi. Sir, I am Anirban Mangu from Fortis Hospital. Okay. So if you can present us with the case and brief up. Sir, presently we are completing the lymphadenectomy of the robotic prostate. Okay. At Fortis Hospital. Okay, so the inputs, any final inputs from your side? Sir, can you take the inputs?
Yeah, so I'm Dr. Ravi. So Dr. Raghunath has gone for a short break. So we have finished the prostatectomy anastomosis and we are just left with the lymph node dissection that will be completing in some time. And I think Dr. Raghunath has demonstrated the prostatectomy steps, and our main highlight was probably the retraction sutures that we took for doing the prostatectomy, where we placed certain sutures on the aspects of prostate so that we can retract, and without the help of the assistant and using only 3 instruments, do prostatectomy with quite ease. So that would be the takeaway from this prostatectomy, I would say.
Dr. Tauru, Dr. Gopal Krishna is supposed to start his adrenal case, so I would want the AV team in Fortis to coordinate with us. Kindly hand over the mic to Dr. Gopal so that we can proceed. Yes, sir.
Meanwhile,
Thanks, Ravi. A couple of points about the presentation, which is happening without, as the live surgery is going on, the presenters are presenting, but we are not able to discuss much of it. Thank you, Dr. Gopichand. So the couple of things I want to mention about the median lobe. Very common problem. Have one technique in your hand to handle it for the newcomers and the beginners. Don't think of 28 different techniques. Inevitably master one, then you can move to the other. Point number 1. Point number 2 is, my teacher Stolzenberg taught me, always stent the patients before you do a median lobe. There are 3 occasions where I do not hesitate to stent. One was median lobe, other is post-ERP, because the ureteric orifice will be all around the place. And third is salvage prostatectomy. So do not hesitate to stent. Thirdly, the suture. It is impossible to have a small bladder neck in a median lobe case. It's just impossible. Not going to happen. So do not hesitate to have a big bladder neck and have a proper suture and lift up the median lobe up so that you can see the posterior plane. And sometimes, as Dr. Gopichan said, you have to incise it on the median lobe and take the bladder with you. Otherwise, you will be cutting so close to the ureteric orifice. So these are things which I wanted to highlight after the presentation. Sadly, we didn't give you time because of live surgery. I'm so sorry. The other thing about the port positioning, Sanjay was talking about it. One thing I really appreciate the innovations that you keep doing. It's very thoughtful because every case you think about it and readjust it. One another additional point for robotic surgery, when you are doing a very posterior tumor, or you are doing a very large renal tumor like 21 centimeter. Recently we did a 21 centimeter adrenal tumor as well. So what you do is you take your ports down quite to the close to the midline. Normally the ports are placed somewhere at the rectus sheath. Don't do that, take it even more. It will be a bit struggling to start with, but once you get going, you'll be fine with it. And when you flip the kidney in a transperitoneal approach, not everybody is gifted like Ginil to do retroperitoneal surgery. I'm so sorry, I'm not gifted. So we will do the transperitoneal, we'll flip the kidney. When you flip the kidney, you need adequate access. Unless you have the ports down, otherwise you'll be working like a watch repair guy with your finger, with your, you have to use the clutch so much to do a suturing. So these are some additional points which I wanted. Thanks.
Thank you, sir, for your inputs. Are we on with the Fortis team?
Sir, the Fortis team is getting ready with the preparations. I think the patient is induced and the ports are being made. Here in Delhi, RGCI team has, I think, completed the cystectomy part. If there are any inputs from their sides.
Can we go to the OT to get a final comment, or are they going to do an intercorporeal? Ileal conduit.
So there is a plan for intracorporeal ileal conduit.
So can we switch over to the RGCI to
Yes, sir.
have
So,
a comment?
audio input from the RGCI team, please. Audio input from Delhi.
Hello. Hello.
Amitabh, you're on.
Can you hear me, Dr.
Yes, sir.
Sudarshan? Okay.
Yes, sir.
So I am finished with cystectomy, and it is hardly 50 ml blood loss.
Yeah, we could see a very dry,
Yeah.
clear field there, yeah.
So you can see very well preserved the non-velar fascia and the neurobundle on the right side. Mainly on the right side, left side it's not too much.
Okay.
So this is the final picture after cystectomy. No bleeding at
One
all.
second, Amitabh, we are not able to get the images.
Audio?
No, audio is quite clear. We don't have the images
The
yet.
full
One second.
screen video images.
Can we have the
Okay.
video stream?
Okay. Now can you see?
1 second, I think it's
Just
from
a
the
second,
AV team here. Yes, now we can see.
Okay. So these are the clips on the pedicle, proximal pedicle, distal, bladder pedicle, the prostatic pedicle clip, same on the right side also. This is the non-velar fascia, lateral fascia on the right side, neuroscleral bundle, the right side.
Yeah.
I think it's interfacial on the left side, but more on intrafascial on the right side.
Okay, probably doesn't matter yet.
Only hardly 50 ml blood loss.
So one thing I noticed with the scissors was there was quite a bit of a fire at the tip of it, which was quite
Exactly. So
enamoring.
now you can see, so with this scissor, you can see a little bit more spark at the tip compared to the Da Vinci.
Okay.
So now they are planning to have a coating on the scissor just to decrease the.
But you have not had any issues with that, right?
No, we didn't have any issue, any bowel injury, any vascular injury because of this spark. So if your sleeve is good enough, it is not torn off, or is there any leak in the plastic sleeve, then there is no issue.
Okay. So what is the plan now? Are you planning on an intracorporeal conduit?
Yeah, so because this patient is thin, so let me try because this is the first time, so let me see. If it goes well, then I will go.
Because now that you have the access of a fifth arm, I think that should be a joy to do.
Yeah, exactly. Let me see first. Okay.
So one comment I have over the port thing was that sir mentioned the use of the long bariatric port. It's a very underused thing, especially of your fourth arm. Because of that elevation of the port, your arm actually moves a little farther away. The chances of clashes is very, very less. So this is something which we don't use often and we forget as well, and then we keep struggling trying to do the patient clearance and stuff like that. But that's something I think, especially in wheel, I have noticed that definitely, at least for the assistant, he doesn't get hit that much, that's for sure.
Yeah. So actually that thing we were doing with the Mantra 2 system, where we had issues because the arms were very thick, so we were using last bariatric port always, whether it was a cystectomy, prostatectomy, whatever. But now once we got this Mantra 3 system, we are not using any bariatric port, and we are putting the ports in straight line as we are putting the X and XI in dovetail, whether it is a partial nephrectomy, radical nephrectomy, whatever. So we have sorted out, actually they have sorted out now, not me, because by thinning the arms, the clashing issue now got resolved.
Great to hear.
It becomes more comfortable and easy for us.
Right. So we just skip over to the other OR to, they're going to start the case, Amitabh, okay?
Yeah, sure, thank you.
So I think we can see the images of the next case being coming up at Fortis. So is Gopal sir Are you audible from the hall? Or anyone from the 40s who can brief up the case for us?
Hello, Saptarshi, can you hear me?
Yes, sir. Good morning, sir.
Good morning, Saptarshi. Our next surgery is a case of a patient with an adrenal tumor. Okay, so in order to save time, we have just done the ports and kept that ready, so we are going to show it. Now, this is a lady who is around 39 years old, and she presented to me with dyspeptic symptoms and very mild back pain. And she is normotensive, fit and well, no other symptoms. She had an upper GI endoscopy for dyspeptic symptoms, and all that was normal. And during the course of investigations, she was found to have this mass in her left adrenal. We have only limited films available because the film taken from another center. You can see here that there is approximately a 12 to 15 centimeter mass in the left adrenal area, and which is placing the spleen, displacing part of the stomach, displacing, abutting on the tail of the pancreas. And there are some more views you will get here.
So it appears to be quite a large mass over here for the beginners especially, not very experienced. From the CT images, how can we actually ascertain the feasibility of laparoscopic surgery in such cases for the beginners? Specific points to look at.
Yes, so if you see CT plates again, this tumor is obviously it is heterogeneous in appearance. It is not, doesn't look capsulated. Unlike typical adrenal myelolipoma, there are suggestion of areas of enhancement and hemorrhage inside it. It is irregular in contour. So we do not know whether this is an adrenocortical carcinoma or this is just another variant of adenoma. If you see the next picture, you will see that it is displaying the thing, and it seems to be pushing kidney down, backwards. Normal adrenal will push the kidney down, but in this tumor seems to be coming in front of the kidney, and therefore it has stretched the pedicle. Unfortunately, these are the limited views that I have. Here is another view. You can see that this tumor is in front of the kidney and has pushed kidney behind. Right. And you see this picture, the urogroup face, the kidney outline looks absolutely normal. So this tumor has actually come in front of the kidney. So we do not know what sort of adrenal tumor it is, but from its look, it may be a malignancy, I do not know. So this is the port position, so this is what we started. If you see, this is the patient's position. The patient is absolutely lying supine, not supine, in his right lateral position, and the table is not flexed. The table is flat, and if you see the position of the upper arm, that is kept parallel to the patient. And this prevents any abduction injuries of the arm. So nowadays we keep the hand absolutely parallel to the patient with a line. This is the umbilicus. And if you see here, normally if I have to make a nephrectomy, this will be the camera position. Right, but then because it's an adrenal, so my port position will move more cranially and upward. So that is the difference between adrenal camera port and kidney camera port. The first step that I'm doing, I'm putting a varus, which is in the spino-umbilical line. It will be mid in the spino-umbilical line because actually you have the circumflex iliac vessel near the anterior iliac spine. Medially you have the inferior epigastric vessels, so we are making the varus port midway between the two. You don't really need to elevate the abdomen too much, just making a puncture is enough. And the first thing that you see here is the pneumo going down and then gradually rising, which means you are in the right position.
So considering the size of the tumor, would you do any modification to your port, or you would stick on to your adrenal position, sir?
Well, I would still stick to the positions because as I can see that the kidney doesn't seem to be involved by the mass, it is pushed by the mass. So I hope that I will not have to do an effect in this situation, although we have taken consent for it. So I'm focused more on the adrenal mass, because I can see that the entire contour of the kidney is pretty norm, so I suspect that it has been pushed rather than infiltrated. There may be some involvement near the vehicle. So once the pneumo is complete, obviously all these landmarks will change to some extent. That is the position of the tip of the 12th rib. And usually the tip of the 12th rib is the indicator for the renal hilum, and that is where our nephrectomy or kidney camera port would be in the parietal line, just about half an inch up the umbilicus in the pararectal line. But in case of adrenal, the ports will more cranially and more laterally. This will be somewhere in the mid-clavicular line. So this is where you can see. This is where the new nostril margin is after pneumo has been created. Generally prefer to create all the port after the pneumo has been created. So it gives you a better idea. That is the position that I would normally do for nephrectomy, and that is the position that I would do for an adrenal. All my ports for the adrenal will be more cranially almost along the costal margin. This is the mid-clavicular line. So this is the line in which our adrenal camera port will be. The pneumo pressure is approximately 14-15. Now we are in a position to make our other ports. These will be two working ports, the left hand and right hand. I am a right hand surgeon. That is going to be my. Some people actually place all three ports in the same line along the costal margin, so that in case you have to open, you can just connect all the three. So after making a pneumo, this is the first, I am using a safety trocar. I keep the valve open so that I can feel the entry to the peritoneal cavity. You see, in case of an adrenalectomy, the colon doesn't need to be mobilized as extensively as in a nephrectomy. That is the reason why the ports are usually placed more cranially. And the second important thing is that this camera actually has to look at the upper pole of the kidney into the adrenal fossa. So I need to place my camera as high as possible so that I can look on the upper part of the kidney, almost like doing an upper-polar nephrectomy. Same will be adrenalectomy. The ports are kept around 4 fingers away from each other at a comfortable distance.
Sir, can you just help you, sir?
Yeah, just in a minute time. They are just setting it up. So these are going to be my two working ports, and then there will be one more port which will be the extends port for suction. The things. This port which you see in right hand, that is a 6 mm port, which will help me to place a green hemlock. And then lastly, I am placing this port, which is again about 4 finger breadths away. So the ports are in a sort of diamond configuration. So this is going to be my 4th port, and this port is going to be 12 mm port. Now, why not a 10 mm port? The advantage of a 12 mm port is that it allows introduction of gauze pieces very easily into the abdomen. Gauze pieces can be taken out from the abdomen very easily.
So your typical right arm port is the 6 mm port?
6 mm port.
6 mm port.
So it's a 6 mm port which helps me to place a 5 mm green hemlock.
Right, sir.
It's always best to have a 5 mm working port because your tremor at the end of the instrument is less in a 5 mm port. Whereas if you introduce a 5 mm instrument through a 10 or 10 mm port, at the tip of your instrument there is going to be a little bit of shake, however steady you are. So
Exactly. I'm absolutely right. In this case, as you can see, the lower port, the 12 mm port, the port through which my assistant will be assisting me, and if necessary, he will also place the purple hemlock, he will place wet clips, so the assistant is going to be an active assistant. So this is the configuration. Now, I think they've set up the internal view. So we are starting with 4 ports. If we were to right adrenalectomy, then there will be a 5th port which will be for liver retraction, and as you know, liver retraction needs to be very extensive. Here, just as you would do a liver retraction extensively on right side, here the spleen needs to be mobilized as much as possible, and that is one of the main steps of adrenalectomy. So the spleen will need to be mobilized extensively, and if you remember from our days of surgery, there used to be a term called planoportal roll, where the spleen, tail, pancreas, the stomach, everything gets rolled over to the opposite side, and that is exactly what you need to do in laparoscopic surgery as well. There has been a little pneumoperitoneum or a pneumo into the retrocolic space, which isn't very good because it has done some sort of dissection. This is the tumor, I think so, which is bulging through.
looks like.
Number one, it seems to be in a slightly unusual location in that it is a little lower down than a normal adrenal tumor would be.
It could be a sarcoma.
I do not know.
So from the CT images, it actually looked, it completely overlapped the kidney.
Yes, yes. The tumor is pulsating, which, there is a bit of tachycardia.
So the preoperative investigations specifically
were all normal, and this patient is normotensive. There is no history of any preo symptoms at all in the form of headaches, palpitations, fainting, etc. So I really do not know what tumor is. Also, my first glance, it doesn't appear to be in a typical position of an adrenal, because an adrenal would be much higher up in this area where I am now reviewing the spleen. So as you can see here, this incision of the full avascular line of the spleen needs to be done very extensively, and as we need to go north as far as the cross of the diaphragm, and that is the most important step which will enable you to roll the spleen away.
The lieno-renal colic ligament.
Exactly, yes. That is an avascular line, and it is important to keep a little peritoneal leaf on the spleen, which will help protect the spleen from injuries. The spleen is a very fragile organ. In fact, it is more fragile than the liver. You may make hole in the liver, you may puncture the liver with your instrument, and that will stop. But if any of that happens to the spleen, then that will never stop. So I'm really very careful about spleen, especially with my left hand and right hand instruments, that they don't hit the spleen by any way. So here I am gradually removing the colon downwards. The tumor is bulging into my view, but if you see, the adrenal fossa seems to be empty. So I'm not really sure what this is. It has been reported as an adrenal tumor.
So as you told, unlike in the other adrenal cases, we don't need to extensively mobilize the colon, but here it seems a bit unlikely.
I may have to mobilize the colon. The important thing is, in case of in case of an adrenal tumor, all you have to do is mobilize colon until you see the upper pole of the kidney, because your main target is just the renal vein, the upper border of the renal vein. You don't need to mobilize the colon very extensively in case of a typical adrenal. I think I may have to mobilize a little bit more.
Right, sir.
So this seems to be coming down quite well.
Your choice of energy source is always an harmonic, or do you prefer the?
Yes, you see, the harmonic is a very versatile instrument. In the days when the harmonic was not available, we used to use a hook. But now with the harmonic coming in, the harmonic is a good instrument in the sense it is also a grasper, it is a dissector, and it is also an extremely good cutter. So I find the harmonic to be a very versatile instrument, and it is very safe. Contrary to what we may think, that the harmonic has got some sort of lateral energy effect. If you are careful about it, then it usually will not cause any harm. I use it very extensively near the all pedicles. The important is that once take your foot off pedal, the energy in the harmonic or the heat in the harmonic remains for another 2 or 3 seconds. So in those 2 or 3 seconds, do not touch any vital organ. So I usually use it to just push some non-vital organ away, like I'm doing here. And I think if that little safeguard, once you build it into your memory, will ensure that you don't do any injury. Saying that I have had one injury many years ago, about 15 years ago when I started using the harmonic, there was a little, by mistake I touched the sigmoid colon and there was a little hole in it, and that patient had a sigmoid perforation presenting about 48 hours post-op. So since then I've been very careful. So here the colon is gradually coming down and moving upwards. So far there doesn't need to be any malignant adhesions of the colon. It seems to be more like a vascular tumor.
So the planes are quite well maintained.
Yeah, that's right. Planes are well maintained, which makes me slightly confident that this tumor may come out eventually. One good thing is that in the history, this patient presented with dyspeptic symptoms, not much of a back pain. Back pain is a worrying feature. It suggests that there is infiltration of the psoas, infiltration of the nerves, which is causing pain. So this patient presented more with dyspeptic symptoms. So that is, for me, a little good sign that this tumor is probably, that's the tail of the pancreas that's now coming up. So all this is part of the extensive splenoportal role that one would do, mobilizing the spleen and the tail of the pancreas. In the CT report, they had said that the spleen and the tail of the pancreas are abutting upon the lesion. So that was a bit worrying for me. I had kept the option of splenectomy in mind. I had told the patient that this patient, if splenectomy is done, will need post-operative vaccines. All that was arranged, but so far it seems that she may avoid a splenectomy. As you know, that patients who have a splenectomy need 3 vaccines: pneumovirus, hemophilus, and meningococcal.
So sir, lifelong. This sort of cases truly counseling is very important, be it with nephrectomy and splenectomy.
Yeah. So there, so far the tail of the pancreas seems to be peeling off quite well. As you can see, I am just following the woolly area. I am just looking for the woolly planes. The woolly planes are actually the right plane. So these are, say, whenever you pull 2 tissues away from each other, you see certain woolly tissues, and that's the right plane to go through. So that's the vascular plane. So this is the advantage of the harmonic. As you can see, it is also a retractor, it is a dissector, which a hook will not do. Yes, you can use a scissors. So there the final attachments of the peritoneal reflection are being divided so that the spleen completely falls away. It is important that the spleen should fall away, and along with it, it will pull the colon or the splenic flexure of the colon, so the entire thing will fall away from your view. So these are the final attachments. You can see the fundus of the stomach there in the distance. Mobilization needs to be done until you can see the psoas. I can barely see the psoas in the far ground, which means that that is the point of the dissection. This is probably the splenic vein coming along with the tail of the pancreas. We need to be careful about this. Splenic vein is a very, very thin vein, and if you injure a splenic vein, then it means doing a splenectomy. You cannot repair it. So that is the psoas seen in the far ground. That's the final attachment that I cut. So the spleen has actually fallen out completely. So this completing the splenoportal roll. The pancreas is also falling away along with it. So as they say in adrenectomy, you remove the patient from the adrenal. So I'm basically removing all these structures away from the adrenal, leaving it as it is. So far the planes seem well maintained.
Gopal sir?
Yes.
We are at a very interesting juncture truly, but because of time constraints, we will be watching you. But in the meantime, we will be having an academic discussion.
Go ahead.
So we will be coming back to you.
Okay, go ahead.
Thank you, sir. So if we can have our next crisp presentation on the tips and tricks pertaining to small bowel anastomosis for intracorporeal diversion by Dr. Srikanth Atluri.
Good afternoon, everyone. Thank you, SOGO, for providing me opportunity. So I'll be talking on tips and tricks pertaining to small bowel anastomosis for intracorporeal diversion. Dr. Amitabh has already finished a cystectomy and lymph node dissections, and he has taken the left ureter also, and he plans to do intracorporeal diversion. I think it will be an ileal conduit for him, and he's doing this on Mantra system, the 3rd generation. I have done a intracorporeal ileal conduit on the 2nd generation Mantra system, which I will be presenting in West Zone this year. So here I will be mainly showing the tips and tricks for small bowel anastomosis on Da Vinci system. So once you are done with cystectomy and you are ready, the first and foremost important tip is to reduce the Trendelenburg position, because cystectomy is usually done with a steep Trendelenburg position. We want the Trendelenburg to come down to 12 to 14 degrees, so that it has two main functions. It will ease the bowel to come into the pelvis where our working area will be, and it will also help in the ventilation of the patient, because cystectomies are usually a longer procedures. So once the Trendelenburg is done, now we try to identify the ileocecal junction. This is the omentum, which was coming in the way, so we just took it out and try to find out the ileocecal junction. So here we can see the cecum is there, and try to find out the exact ileocecal junctional wall, because we want to be absolutely sure that we are preserving the distal 15 to 20 centimeters of the ileum. So this is the ileocecal junction which you have seen now. The other thing is we look for the tinea of the cecum and confirm the cecal wall, and also look for the appendix if possible. So this is the appendix which I am holding now, and confirming the ileocecal wall. So once we have confirmed the ileocecal junction, we want to prepare the conduit. So the conduit is usually 15 to 20 centimeters.
Ask you just show
proximal to the ICD.
These pictures and followed by focus on these two pictures. Is better to wait.
So once we need to make the loop of the ileum, so that we make a C loop, so that we have a good length which we can form the conduit using. I usually measure with the scale. Some people use feeding tube, some can use umbilical tape or vessel loop, which is usually cut into the 15 centimeters. So we with this scale, I measure it along the mesenteric border of the ileum, without any stretching, so that the actual length of the bowel is maintained. So this will be the probable site of the first cut, which will be the distal cut. So I am holding it with two of the graspers. I usually use Cadier on the right side and the fenestrated bipolar on the left side, because these will be the traumatic ones, and try to hold the mesenteric fat rather than the bowel wall. So the staplers which we can use will be, can be Echelon from the Ethicon, or from Covidian. You can use Signa, or you can use Sureform stapler also. The Sureform stapler, when you are using the robotic one, you have to use it from the left arm port. So once you put the stapler, here the trick is you have to fire it to make it in such a way that it is perpendicular to the bowel length, so that you maintain the vascularity and it is not devascularized. And once you do that, you also look for that you are nothing hold from below, any bowel is coming inside. So after all that, and once you make sure that the staple is held perpendicular to the bowel length, the stapler is fired. Once the stapler is fired, you look for hemostasis along the staple line, and this is the distal end. If you want to cut it more, you can use harmonic or ligature, whichever energy device is, because sometimes distal end may not come. This is what I am trying to achieve it, how it will be coming it. I try to take the distal end of the conduit and try to reach at the abdominal wall. So if it reaches easily, so I feel that okay, then you don't need to cut more. So once we are done with the distal cut, now we go to the more proximal cut. We again align the bowel so that we measure it properly, and we have a good space to have a next cut with the stapler. Again, take a length of around 15 centimeter. The length of the conduit depends upon the body habitus. 15 to 20 centimeter is the usual length which we use for conduit. Here I am demonstrating for conduit. Similar thing in the neobladders, you have to take more length, but the tricks for bowel anastomosis remains the same, whether you are doing ileal conduit or the neobladder. So we may have measured the conduit length, which is around 15 centimeter, and again try to align the staple in such a way that it is perpendicular to the bowel length, and we have a good amount of mesenteric supply, so that the base is slightly broader, so that we have a good vascular supply and we are not compromising on the vascularity. And again we check from below, we are not holding any other bowel tissue or something in the stapler line. So once we are okay, then we fire the staple for the proximal cut. The choice of stapler depends mainly upon whatever you are used to. The main factor now, I think, comes to the cost. With the Sureform, I think it is slightly lesser costlier than the Covidian or Ethicon. With the Covidian and Ethicon, when you are using this, you get an extra hand to maneuver the bowel, but when you are using Sureform, it is slightly difficult because you are using your robotic arms only. So now this is the conduit which we will be making. So make sure that the conduit is placed below. Take the bowel end. Sometimes you can mark to usually identify. Initially in the learning curve, it helps in really identifying the bowel lobes. But once you are okay, then it's not necessary. So we take out the scale and then we start preparing for the bowel anastomosis. So we take a cut with the scissor on the antimesenteric border of both the loops of the bowel. Here I typically use a Barcelona tackling, so which is an end to side to side anastomosis of the bowel. And we use two staplers, Echelon 60 for the bowel anastomosis, and then I will use one stapler across at the end, which is the transverse one. So once both the loops are cut, Then I'll try and engage the echelon 60 into these both the loops. So here it becomes a little bit difficult while maneuvering with the assistant. So you make sure that the larger end of the stapler, you make a big hole and dilate the bowel so that the stapler goes in easily. So now we have cut both the ends. We will align both the ends so that along the line of the staple, and we'll make sure that the mesentery is also aligned and it doesn't come in the line of the way. You can take a stitch here also to align the bowel along the anti-mesenteric board. So now I'm putting the bigger end first, and while doing this, I try to align in such a way that the mesentery not be involved in the staple line, so that the mesentery is on the sides. So this is the bigger end of the staple going in and making sure that the mesentery is also aligned well. And then we'll go with the other side, which is slightly easier because it's a smaller one. But the other, again, make sure that the mesentery is aligned on the side and there is no mesentery coming in the staple line, because it will cause devascularization and later on leaks, and healing with the anastomosis will be difficult. So once you are done with this, make sure that close the staple. Again, make sure nothing has been caught from below. So we make sure we see again, and there is nothing there, and then confirm the lie and both the bowels. The conduit is also free, and now we fire the stapler. So this is the first fire 60 which is going in.
Sir, it's been a very good video session. If you can just, we are on a very strict time schedule, sir.
So once we are done with that, so you do fire the second one also, aligning the bowel length, so that we have a good length, because we will be firing a transverse staple also, which will cause decrease in the length of the anastomosis. Usually it is said that 2.5 to 3 centimeter of a good anastomosis is good for the bowel anastomosis. This is the final staple. Here sometimes you may you may not be able to cut the whole bowel with the staple, so you may have to use one extra stapler like I have to use it here, or you can simply cut it and run it with the sutures. Once the anastomosis is done, we again check for the conduit, all okay, it's coming all well till the abdominal wall without any tension, and some people prefer to do the rescue stitch, which is usually done at the end of the staple line, which is, I think, nowadays not necessary. Many people don't do it. Mesenteric window also can be closed. Many people avoid it and they are not seeing any complications. So this is how there are some of the tips and tricks for the bowel anastomosis. This is the end stoma, which is a well-pouted and healthy stoma. Thank you.
Thank you, sir. A wonderful video demonstration. Thank you, sir.
My only comment is that you need a wonderful assistant at the bedside to do this. And second, whenever we fire a stapler almost near the abdominal wall and then fire it so that the mesentery is lifted up, you don't get any of the edges in between.
So quickly, if we can move on to the adrenal surgery video.
Dr. Ginil Kumar is starting his surgery in Apollo, so we are shifting to his screen. They will introduce the case and proceeds. Apollo, yes. Dr. Jindal and Dr. Kumar, please introduce the case. And
am I audible?
Turunda?
Am I audible? Dr. Dinesh here. Hello?
Yes.
Am I audible?
Yes, you are audible.
So, Tarun promised me that he will, reserve a very simple case for me. And last week he told that patient accident turned up. So I got another case. I'll just show the PT here. So this is actually a 51-year-old incidentally presented on evaluation found to have a mass in the left kidney, mid-thorax. So this is the coronal pictures. Can you see the CT?
Need a little bit more.
Yeah, just can you focus on to here? Can you focus on to here? just go through the pictures here. There is 7.1 centimeter. Creatinine is around 1 milligram percentage, and there is a midpolar mass. We can focus on to here. Actually, is midpolar going into the hilum. We can see that there are some enhancement here close to the hilum, and is more towards the lower side, midpolar extending to a lower pole, which is intending the bulvical system. I hope that is not infiltrating that. At any point I feel that it is not safe to keep the tumor, I will plan for a radical. The hilum seems to be very, the vessel seems to be very close. If there is any hilar involvement in the main vessel involvement, I may go for any bleeding or significant bleeding, I may go for a radical in this case. That is what we planned, what parent planned for that patient and discuss with the patient. So, any points you want to, or any discussion on the case required?
No, sir, I completely agree with you that it looks like more close to the hilum, and you should keep an open mind while planning for this. But if it is not involving the major vessels, you would hope to complete a partial, I believe.
Yeah, well, plan. Okay. So our plan will be slightly obese, just getting the patient ready. So our plan will be can you just tilt the patient a bit? That's it. Just fall into this side. So classical position, we usually put 2 ports, one for suction and is left side tumor. So just above the umbilicus and another port for acetylens, and for parallel, usually I just keep the lowermost port a bit lateral from the classical description of the XI port placement. So 1, 2, 3 and 4th will be slightly lateral like in the curvature. That is the usual thing how I put the ports. So shall proceed with the port placement. By that time you can enjoy the excellent surgery by Dr. Bhavesh. There is actually a drill is going on well, I can see from here.
This is the case for retroperitoneal, sir?
There is anterior tumor. So I prefer for trans only if the tumor is behind the pelvical system, I usually go for retro. So in that case, I need not completely overturn the kidney. So those cases where the tumor is anterior pelvical system or anterior vessel plane, I go for anterior or transperitoneal approach.
Okay, sir.
Okay, thank you.
Meanwhile, can we move on to 4 days and have Gopal sir with us? Can we request the AV team to move on to 4 days and connect Gopal sir with us?
Hello, am I audible?
Yes, sir, you are audible.
While you were away, what I did was,
so we are not having the video of the case.
Not having a video?
We are not having the video. We can hear you.
See, until now, were you able to see the video?
Yes, sir. We were watching.
Now can you see the video?
No, sir.
I'll just take a moment here. We have concluded the second session of the surgical workshop. I would like to thank Dr. Kullan Sharkar sir, Shaptur Shida and Dr. Srivastav sir to chair and moderate the sessions. Thank you so much, sir. I would like to invite the next set of people to the stage.
Can you see me now? Can you see the screen?
Dr. Mane Suryavamshi,
Can you see the screen?
and Dr. Shujo Gupta could you please take the stage? Dr. Shobik Chatterjee and Dr. Mallu.
Yes, sir, we can see your screen.
I would request you
see
to
the screen?
moderate the follow-up sessions.
You can.
Okay. So while you were away, what I did was, I went step by step. So first thing was I removed the spleen, tail of pancreas out of the way. Then I dropped the colon completely so that anteriorly the tumor is completely free. So once that is done, now I went behind and I saw the upper pole of the kidney and then sequentially started taking it from the upper pole of the kidney. So this is the kidney, as you can see here, that's the upper pole. And the plan is to gradually move upwards, gently trying to separate it from the kidney. In the process, I expect that I will see the renal pedicle at some point of time, and there I should be able to see the vessels supply the tumor. One additional thing in the upper part, I found the inferior phrenic supply, which I clipped and divided. You may have seen it at the northern end of the specimen. This is probably the adrenal vein, which is stretched, as you can see here. I will not clip it now because I need to see the main renal vein first before clip any veins. So this tumor is bossulated. It's not looking like a typical adrenal, and I don't see adrenal tissue in it. There doesn't appear to be a clear-cut capsule in it. So I'm just taking this fat as a protective layer and moving ahead. Because you know that adrenal tumors can be soft and they can sometimes rupture under pressure.
Good afternoon, Dr. Gopal. There is a change of guard here in the audience. Hello?
Yeah.
So, as you were saying, this is a large tumor, maybe tumor, also adrenocortical carcinoma. But going by the well circumscribed nature of the tumor and minimal vascularity around it, what do you think? This is more likely to be a benign now?
I mean, I have a feeling that it may be benign because it is peeling off from the kidney quite well. In fact, there is a reason why I did not tell them about the prospect of a nephrectomy, although that was something that was on the cards. But here, looking at the CT pictures, it seemed to be pushing the kidney rather than infiltrating it.
Yeah.
As you can see, so far it is peeling away from the kidney quite well. So the appearance may not be as sinister as what we thought it would be. So far I haven't found any malignant infiltration. These are all just fatty tissues and they are good areas to work in. These are, as I told you, the target is always look at woolly tissues, because woolly tissues mean they are plain. So far it is peeled away from the anterior surface of the kidney. I think we are now gradually in a process of coming close to the medial aspect of the kidney, which is the hilum.
So for the beginners in such large tumors where the chance is always high that it may be a malignant, what do you suggest as a cutoff limit to try with the laparoscopic approach rather than the open?
I mean, I am not telling this to sound very brave or sound foolish, but I think one should attempt all tumors laparoscopically. Yes, there will be a point where you have to give up and then you convert to open. But at least part of your laparoscopic learning would have been completed. Whereas if you give up at the beginning itself, then you just feel that you cannot do it laparoscopically. So it may so happier that at the end of the day you might be able to just do the entire case laparoscopically, and that is how I have trained myself. I would say whether it's a big kidney tumor, whether it's a big adrenal tumor, please start laparoscopically. You have your safe limits that you will do it up to a point where you find that you are not progressing any further, or you find that you have taken a long time, and at that point of time, you convert. So that it helps build up your laparoscopic learning curve. It gives you the courage to go ahead. And this is the way I have gone ahead and with all renal tumor. I mean, I wouldn't say this again to sound very foolish or brave, but we have done tumors as large as 15, 16, 20 centimeters, and you will be surprised that it's actually possible to do it. Of course, you need good assistance. That's very, very important. And the other thing is for heavy tumors, please use as many ports as you want. Often in laparoscopic surgery, we have reluctance to increase the number of ports. I think one should just use as many ports as you want. As they say, if you remember the words of Richard Gaston, who is actually the guru, he said that the number of ports should be equal to the number of hands of surgeon and assistant, which means that you should actually have 4 working ports. If you do this, you will actually find that your job becomes a lot easier. Sometimes a large renal in 5 ports. So the assistant is actually using 1 suction and 1 retractor. So that is the way I have always been able to complete my surgeries, and that gives you immense satisfaction and immense confidence. So I think the key is to just do it. If you do it, you will find most of the time you will be successful. But of course you should be safe. And always have good assistance. The same assistant who assists you will be a good guy. If necessary, you can have a general surgical colleague to assist you. So here we are seeing some bits of vein. I do not know which is the renal vein. So I'm just trying to stay away from it. This part seems to be okay. So let us divide this and see. I'm not dividing the cranial part, attachments of the adrenal, because I don't want it to flip and fall over. So I'm keeping cranial attachments as they are, because then that will distort the tumor and it may just tear some pedicles. So keep the cranial attachment always intact. The other thing you see, before I harmonize anything, I always pinch it and see what it is. That pinching gives you a sense of tactile feel to know what it is. This is a large envelope which has been applied by my assistant from the lower port. So the assistant is an active assistant. He is not just showing the camera, he is also retracting, sucking, putting in ports, putting in instruments. So even your assistant gets training by using 2 hands. And I think that's the best way to train your assistant to be a laparoscopic surgeon. He participates in your procedure rather than simply showing the camera.
So Dr. Gopal, in case you ever need to convert, what is the incision of choice that you would like to take?
Well, it will be a subcostal incision. And as I said, we would just join the ports, make a subcostal incision.
Same position.
Same position. You see the advantage, as we all discussed earlier, that in laparoscopy, even if you find the pedicle to be difficult, at least do the easier parts and keep the specimen reasonably mobile, so that ultimately when you open up, the incision may not be that big and you just have the pedicle to deal with. That is how I used to do the nephrectomies in the past. I used to mobilize them from all sides and leave the pedicle as it is tackled by open surgery. Because in those days, in 2008 and 9, we did not have hemlock clips, and all the usual Liga clips used to slip. So I used to have bleeding from the renal vein. So only when hemlock clips came about, that's when I started being able to do nephrectomy better, because the Liga clips actually always slip. So this tumor is more or less mobile from all sides except here. So this is where probably there are the feeder veins or the draining veins. There is a vein coming about. Before I ligate any of these veins, I want to make sure that I am seeing the renal vein and then I will tackle these.
So do you have an approach wherein, when is it then that you decide to do your adrenal vein, at the beginning, in the mid, at the end? Do you follow some kind of a protocol, or you just go ahead whenever it is visualized?
Whenever it is visualized. I mean, as they say, in case of open surgery, we've always learned that tackle the vein first and then do the rest. But here in laparoscopic surgery, actually it is easier to do everywhere else and then come to the pedicle, and I think the laparoscopic pressure prevents any hemodynamic fluctuations. And the second thing is that in case of open surgery, we probably manipulate the adrenal a lot more. In laparoscopic surgery, the manipulation is a lot less. So maybe that's another reason why it allows us to tackle the vein at the end. In case of the right side, if you see the vein first, you tackle it. But here, as you can see here, it was not possible to see the vein at all from the beginning. So we had to mobilize the tumor from all around until we get to the vein. And as I said, this patient is normotensive. There are no signs of any BP fluctuation so far. So I probably think that this is a non-functional tumor, whatever it is. So that gives us a little bit more confidence. However, because this tumor is big, I suspect that the adrenal vein will also be bigger than what it is. And that's the reason why I want to see the renal vein first before I actually aid the adrenal vein, because we don't want to end up in a catastrophe. There is a large vein coming up. It is likely to be the adrenal vein because it is going to the specimen.
Can we just shift for a minute to RGCI? The next OT, Rajiv Gandhi. It's to the cameraman. Can we shift audio to the RGCI?
Hello.
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 Good afternoon, Dr. Amitabh.
Hello.
Hello, Dr. Amitabh.
Yes, sir. Good afternoon, sir.
Rishi here.
Yes, sir. Good afternoon, sir.
So, you are doing the
Sir, I'm trying to do intracorporeal with the same mantra. So I am doing some difficulty with the instruments, but till now actually I have been able to do this bowel division, proximal and distal. So this is basically I am stitching the serosa to side stapler anastomosis, and this is the conduit you can see, which is down below the ileal anastomosis.
So, Amitabh, Manav here, what exactly is it that you find, good afternoon, what exactly is it that you find different from the Da Vinci when you are operating on this robot while doing an intracorporeal?
So actually this is for the first time, so what I am facing, because when instruments are away in the upper part of the abdomen, so the controls is good, I can do, there is no tremor, you can see very well, but I need to do extra work to control them, although there is no tremor. And because I have been doing it first time, so I need to learn also with SSI mantra how to manipulate.
So you were talking about the port tremors, if I'm not mistaken, because that's a query.
So yes, sir. So I have.
Please explain. Please elaborate onto that.
So I haven't faced any tremor of the instrument. Now you can see. So what happened? So initially, when we had mantra 2, SI mantra 2. So when we used to operate in per part of abdomen, when the most part of the instrument is outside the abdomen, then we used to have slight tremors, but in mantra 3 not having these tremors. So this is a big improvement actually I can see. But I need to do some extra effort to manipulate these instruments. And there are actually some issues with some software also, so they are trying to solve it. So sometimes actually they are intermittently stopping me, but somehow I have been able to do this bowel division, mesentery division, and just taking the serosal sutures, and probably I would be able to do the anastomosis also, side to side vestibular anastomosis.
So for benefit of all of us, because not many are very well versed with the way mantra works, what exactly is the issue with tremors and how exactly have you been able to control it now?
So now the engineers, they have made the actuator very small.
So actuator basically where the instrument home, the base of instrument homes. So we call it actuator. So initially the size of the actuator was big. So because of the weight they used to have a tremor. But now they may have, they have made it very small. So now the tremor issue has gone. So they call it, these engineers, they call it a cantilever effect. Just like in lab, sir. If you are doing lap nephrectomy, suppose your instrument is completely inside the abdomen. Then outside the abdomen, if you move almost like 2 centimeter, then it will move 4 centimeter. So it's the fulcrum issue, I can say. So just you need to have a very good weight on the both side of the fulcrum to balance the movement of the instrument. So now they have balanced it very well. So they made it very small outside the actuator. They reduced the weight. So now not having any tremor. If like the most length of the instrument outside the abdomen, when I am operating in the up part of the abdomen. So if operating into the pelvis, then there is no issue.
So this seems more of a scaling issue rather than the tremor issue per se. The scaling of the motion at the actuator end, that can be probably more fine-tuned in the version 3 of the robot.
So they have improved it, sir, in this version, version 3. So now I've been able to manage this thing in the upper part of abdomen. Otherwise, initially it would have been very difficult for me.
So do you find any issue of redundancy over here? If there is an issue of scaling, then there might be a small time difference between what you are doing and what the instrument is actually doing.
No sir, no sir, no sir. So just like Da Vinci, we have provided different scales of movement, 4:1, 3:1. Depends on how you prefer. So I am working right now on 3:1 scale. But no, actually lag. Whatever movement I am doing at the surgeon consoles, it is immediately getting translated at the patient side.
Is it possible to have an external view of your OT also?
Exactly, sir. Sure. यार वो दिखाना भाई लेकर के आ जाओ. इसमें मुझे निडल ऑर्डर दे दो. हॉट शेप पर. Can you see, sir? Outside of the patient?
Yes, we can.
Yes.
So do you, in this case, also do some undocking and reduce the Trendelenburg, or there is no such issue? You just go ahead in whatever position you are?
No, sir. After ILL, I will redock the board. I will decrease the Trendelenburg.
Okay. So
after ILL.
Okay.
आ गए, अंदर आ जाओ. आ जाओ, आराम से आराम से आराम से आराम से. जेली लगाई थी?
I think we can go back to your intra-op view again once you just start with your...
Okay, sir.
And till that time we'll go to other OT in adrenal and come back with you in a few moments, okay? Thank you.
Sure, sir. Sure.
So can we shift to the adrenal OT?
Dr. Gopal?
Hello, can you hear me?
Can you hear me? Yeah, we can hear you, sir. We're almost completing the case.
Almost complete. As you can see, the kidney surface looks good, which means that the kidney vasculature has been maintained. The tumor is sort of separated and it is out.
We missed actually the adrenal vein part. We were focusing on the other theater. So can you just show us the anatomy there?
So you can see that part. So there you can see the surface looks quite good. Vasculature is maintained. There's the clip on the adrenal vein.
The rest of the adrenal?
Yes. That's right.
Okay. And the renal vein?
That's the renal vein there. You can see the renal vein in the background, which is going there. So once I ensured that you can see the renal vein going into the retroperitoneum there. Here you can see the renal vein going into the retroperitoneum.
Okay.
And the adrenal taking off laterally. So my main concern is the renal vein, that it is filling and emptying well, which means that the renal artery is also good.
So how do you plan to remove the sample now?
Yeah, the sample, obviously I do not know if it is malignant or not. If it was benign, I would have put it in a bag and morcellated it. But here I am going to put it in a bag and take it out intact, because adrenal tumors can be soft. So for this tumor is almost about, I think, 12-13 centimeters in size. So I'm going to make a bag out of the Romson's Euro bag. So we'll use a Romson's Euro bag and then make a bag out of it, put it inside the abdomen, and then put a specimen into it and then use it to take it out.
So in case you decide to morcellate, what is the kind of bag that you use?
Same thing, I would use a Romson's Euro bag, put the specimen into the Euro bag, and then take out the bag through the 12 mm port, and then use a sponge holder to morcellate the specimen, and then take it out, so that I don't have to make a big incision. So if I knew this tumor was benign, that's what I would have done, whatever be the size.
So with this bag, you have never had an issue with a morcellator piercing it or causing some injury ever?
No, it's mechanical morcellation. We're using a sponge holder.
Okay, I got it. I thought you said...
No. So you take out the mouth of the bag through a 12 mm port.
Okay.
And then you use a sponge holder and a suction to mechanically morcellate it and take it out. So that works quite effectively. Mechanical sort of hand morcellation. So in this case, I'm not going to morcellate it. I'm going to put it in the Romson's bag and then take it out through this is a lady, so we'll take it out through a Fanning Steele's incision. She's had a previous cesarean, so we'll use the same incision to take it out.
So meanwhile, as you bag it, we would just like to shift to the other OR because we are undergoing a stapling right now.
Yes,
please shift to RGCI. Please swap to the other OT. Amitabh, can you hear us?
Yes, sir. I can hear you, sir.
So you have taken what size of the stapler now, and what would you plan? Do you do a double stapling or a single one?
Yeah, double stapling, sir, double stapling. I'll try double stapling.
And what size do you use?
So this is 60.
And the second one would be?
It will be same 60, sir. Because what I feel when we use 60, the effective length is almost 30 to 40 centimeter only.
So how do you ensure the alignment of your incision for the second stapler?
So now what I do, sir, I follow this suture last one. No, and what I try to take this straight suture, I try to take on this surface, lateral surface of the bowel, so that on the medial side, I'll have a extra length of the bowel, so that I can accommodate the stapler medially inside the bowel. Silk Dana?
Yeah, this is an important point of technique actually, to take stay sutures on the bowel which is near the mesentery and bring the two mesenteric ends of the bowel together so that the anti-mesenteric border remains free and comes in the staple. So you take more stays before you fire the second stapler?
Yes, sir, definitely. I'll take 2 or 3 stays again.
And has it ever happened to you that you have gone through the mesentery while stapling?
And then, sir, I have done, sir, I think 7 or 8 intracorporeal and all through Da Vinci, but I didn't face this issue.
So just a question to Dr. Rawal, in case someone ends up going through the mesentery on staplers, what should we do in such a scenario? We need to discard this bowel and go ahead and do it all again? Because someday someone can surely face such an issue while doing intracorporeals.
Yeah, I think there's a practical problem which can occur, especially in the beginning. Though we never encountered that because of the sutures which he is taking now.
But it can happen.
If you have gone on mesentery bowel, I better suggest that you redo it. Because
Open and redo
you can't
problem.
afford a leak in a patient, post-op leak. So it is better to you discard that bowel and use new one. By the way, this is probably his first intracorporeal using mantra. He was trying last, I think last cystectomy we did day before yesterday, but then he was probably tired, so he wanted to show in SOGOCON, so he's doing this. This robot is quite user-friendly, especially in docking. We are doing docking of kidney like we do XI. We put in a single line. And you have seen fifth arm, he has used it. We used it, actually day before yesterday I used it in a cystectomy only. I think that is going to be refined more because the length of harmonic is small. It's a Chinese harmonic, which they are incorporated in this. But once they come with the tri-energy probe, then the things will be different for fifth arm. Where in that case, you can do cystectomy probably in 30-35 minutes without any problem.
So, Amitabh, you are on 5 arms today?
Sir, initially I was on 5 arm, but now I am working on the 3 arm because I had to put a stapler. And stapler has to come from the left side of the abdomen. So I replace that arm.
So whenever you use 5 arms, what is the instrument that you keep? You keep some grasper or traction. What exactly do you use it for?
In 5 arms actually, so 1 camera arm, 3 instruments, scissor, bipolar and a retraction arm, that is progress.
Okay.
And 1 for the harmonic.
Okay, okay.
Yeah.
And once you have done the intracorporeal, do you inspect the stapler line inside, or you just bank on the technology that it would be fine? Because such a long stapler line, I feel, gets difficult to inspect totally inside in the depths. So you can see upper 60-70% of it most of the times. But
Exactly.
honestly,
So, yeah, sir. So what I see for the bleeding. So if I have gone through the mesentery, I will have definitely some like bleeding inside the anosmotic line. So if there is no bleeding in the anosmotic line, then you can be very much sure that you had not gone through the mesentery.
and what particular stapler do you use?
So this is, sir, actually we have got this Ethicon Indo-GI stapler. We have got Covidian also. But now mainly in last few cases we use Da Vinci this Sureform. But now today I have used Ethicon.
So in case we just, can someone tell us the thickness of the staples that you use? 3.5, 4.5 millimeters, because that's written on the box.
It is blue cartridge.
The blue one.
Blue one. Blue for bowels, I remember like that only.
And green for gastric.
Yeah,
Okay.
yeah. And white for vascular.
White for vascular.
Yeah. Am I audible? Sir?
Yes, you are audible, sir.
Yeah, now you just turn the patient over. Just wanted to show you the bagging.
So we are with you.
Turn the patient over means,
We made it
tilted the table?
Supine. Patient is now supine.
After bagging? Before bagging
No.
itself?
No, before bagging. So now we made patient supine for the fan and steel incision. So this is the Romson's bag, as you can see. And we've rolled it. And after rolling it, I'm going to smear it with jelly, Vaseline jelly, so that it becomes slippery. And then it will allow me to insert it through the 12 mm port very easily. So I don't have to make another cut. So you keep twisting it, and it will go in. So just smear it with gel, and then the rest of it can be pulled from inside. So this is an easy way to insert because these Romson bags are quite thick and big. And that's the reason why keeping a 12 mm port helps you to push it inside.
So you find a particular advantage in going supine, maybe the specimen keeps lying stable in front of you?
Yeah, that's right. The specimen has been sort of pushed inside, and now it helps you to just bag specimen inside.
Manav, why this vision from RGCI is better than vision from here, from Fortis?
So that I'll have to ask the cameraman. So can you just tell us why is the vision from RGCI better than vision from here? Do we have some relay issue? Some frequency issue?
I think the RGCI, they are using Zoom because whenever we do the surgery, SSI, they come with the Zoom connection and all. I don't know, but it's pretty good.
But it actually is seeming like an HD, very ultra.
But the other from Fortis is not that good.
Maybe, is your camera smeared, Dr. Gopal? Can you just check your lens? I think it is smeared maybe with some fluid or something.
And which endovision he is using from Gopal, can you ask?
Dr. Gopal, can you hear us? Hello?
We are using Stor's Rubina system.
Okay, and is your lens smeared? Because we somehow had a feeling that the vision suddenly went a little down.
Yeah, now it's better.
Because
So we are just
in
about-
Mantra, they are using Olympus.
They are using a
Olympus camera. 3D Olympus flexible. 4K.
Rubina is 4K.
But this is HD.
No, Rubina
Rubina is 4K.
This is 3 in 4K, yes.
Yeah, 3D, 4K.
So there was probably a smearing
Probably
issue of
the lens was
with-
smeared.
Yeah, so
Yes.
now
The
it
lens was
seems
smeared
quite
with some
clear.
fluid.
I think in SSI Mantra 3 they are using Rubina system.
No, not Rubina. They are using Olympus flexible HD.
Flexible HD.
Yeah.
So you see, this bag is quite robust and it will not tear. So it allows you to, and it also allows you to take out bigger specimens. So if you have a big kidney or a big adrenal, then the standard handmade plastic bag is quite thin. Sometimes you often also find that the bag is weak on the other side, so the specimen sort of drops into the abdomen when you are trying to take it out. So that's why these have a big specimen. This Romson bag is quite good. Whenever you remove this adrenal, always hold it on a peritoneal leaf, not on the adrenal itself, to be able to push it inside.
Sir, so my question is to Dr. Raval. Would you bag kidney specimens which are RCC also every time before taking out, or only TCC specimens?
No, RCC for radical nephrectomy I never bag, but for partial we always bag. And TCC, if it is well contained, there is no need. Many times we remove from the incision lower down. And sometimes we do with the robotic, sometimes we do with open to take the lower bladder cup.
Because we are also not routinely bagging our kidney specimens for tumors actually.
Become a bit cumbersome, especially in the laparoscopy, as you can see. But partial, the small specimen, so you can do.
Even for RCCs, we do have cases, even after a partial nephrectomy, where we have unfortunately got port site recurrences, particularly in patients who are type 2 papillary carcinomas. In those patients, we do not know preoperatively what it is going to turn out. So therefore, we generally do bag even RCC cases, including partial or radical cases. Although these cases are anecdotal only, one can't recommend a policy based on this, but the same goes for TCC also. The risk of port site recurrences is just about maybe 1%, 1 to 2% for TCC, and RCC even lower.
हेलो इस पर तो रोड करो कोई कनेक्ट कर रहा है क्या नहीं पानी किसने मारना है
Hello. So Apollo has started its case. Can we shift to the Apollo Theatre?
Please connect us to Apollo. The case is
It's a partial nephrectomy, sir.
with Dr. Ginil.
Yes, sir.
Before we move on, maybe we can give our applause for the adrenalectomy case done by Dr. Gopalakrishnan. He probably held the fort for pure laparoscopy among all the robotic surgeons today. So well done, Dr. Gopal.
And thank you for such a beautiful demonstration and explaining us all the fundamentals of adrenal. Dr. Gopal, can you hear us?
Yes, I can hear you.
Thank you so much. It has been an exquisite display. We will be shifting to the next hour with your due permission. Thank you.
Thank you very much.
Let's please shift to Apollo.
Excellent demonstration of adrenal hello?
Yeah, Dr.
Can you hear? Yeah.
Yes, we.
So we just put forth and getting ready. So the issues are, I may feel my plan will be just to go to the hilum and do some hilar dissection before I proceed with the tumor. So that will be my plan.
So, can someone,
these are the port placement.
Can someone zoom onto your port placements?
Yeah, port placement. So this is actually the transfer placement, and I put two ports for suction. One is just above umbilicus. Can you, Solomon?
What is the size of the assistant ports that you are using and location of your assistant ports?
Just above the umbilicus has a large port that will accommodate hemlock. You should put 12 mm or 11 mm. Then there is a Farman port at the midway between the camera and the upper, the second port of the port just posterior to that. Top and the middle port just above the camera port.
Okay.
The middle aspect.
Yes, that is clear. That is clear to us. Thank you.
Yeah. So one more port. This is a bit these guys, so we put midline, we put slightly to the left side.
Okay. So you are planning for the partial nephrectomy?
Yeah, partial nephrectomy. If there is any difficulty, I will proceed because 7.1 centimeter mass going into the hilum. If I feel that any bleeding from the inside the hilum or any difficulty, I will proceed with the radical. That is my.
Yeah.
So do you intend to do an on clamp or an off clamp? Dr. Ginil.
Yes.
Do you intend to do an on clamp or an off clamp surgery?
So actually what I do is I usually go for on clamp only. I don't believe in off clamp. What I do off clamp is when there is a multiple tumor to reduce the ischemic. And here also I do a bit of hilar dissection and if possible get the main vessel to the tumor so that if dissecting the hilum and going from the anterior aspect, tackling bleeders in the hilum will be from the duct will be easier. So that's one advantage of going into the hilum immediately.
Okay.
Like in the hilar dissection. But even if I am doing in the hilar, I don't completely avoiding clamping. Whenever there is a bleeding, I just proceed with clamping, or I will clamp and proceed with the dissection.
Okay, thank you. So the decision with regards to radical versus partial, you will basically decide upon the hilar dissection if you are able to achieve it or not.
Sir, we could invite some closing comments from Dr. Amitabh Singh. He was finishing off his case.
So we can surely please shift to RGCI. Amitabh, can you hear us? Dr. Amitabh?
Yes, sir. Can you hear me, sir?
Yes, we can. Please go ahead. We want to listen what you are doing.
Actually, sir, I wanted to show you that lumen of bowel. So it is quite deep.
Okay.
But at that time you were busy with some other
that's
OT.
okay. Just the point was, what exactly do you do to ensure that the staple line is not bleeding inside? That was the point.
Yeah, so I retracted the bowel and with the help of suction, I went too deep
Okay.
to see that stapler line is healthy and it's not bleeding.
Okay.
So after that, I just did this side and stapler firing to take out the end of bowel, and just I am overrunning this end for 2 or 3 intermittent sutures at it. After that, I will just decrease the Trendelenburg of the patient and we start with the
So one thing, you have a staple line, so why do you wish to take interrupted? Is that a mark of your protocol?
Okay, no, so it's our protocol actually. So sometimes now, because there are case reports that this line that got dehiscent.
Okay.
So just prevent this dehiscence, stapler dehiscence, we take at least 4 or 5 intermittent sutures. So it all came through the GI surgeons, because when we started doing this stapler intracorporeal, we took help from GI surgeon. So they told us it is always better to be safe and always take some intermittent suture on the stapler line, at least in
So your GI surgeon is training you so that you never call them, huh?
No sir, we don't call them.
No, he's training you, you never call him even on a bad day, there is no complication.
No sir. Hello, हो गया.
So once Amitabh, you are undocking and redocking it, we would not mind having an external view and seeing how one of the ports is docked.
Okay, sir.
In case that is possible by showing on the camera over there at your place.
Yes, sure, sir. So after undocking, I will just show the external view.
Yes, yes, we would be happy seeing that.
Yes, sir. Sure, sir.
So you don't take any markers on the harvested ileum?
That's why I am seeing, sir. So I am trying to mark the distal and proximal thing. So I was looking for a suture, because I have got the suture on the thin. So I'll just take out suture.
Okay.
Yeah. ये वाला कट कर दो, distal वाला.
Because I thought a marker is a great idea. At times you just don't realize what has happened to the mesentery and what exactly is the end.
Exactly, sir. Exactly. Well, it is very advisable that you must have some marking sutures, whether you change the length, make it short, long, or take different color of sutures like Vicryl, Proline, whatever.
What is your preference of anastomosis, Wallace or a Bricker?
Sir, Bricker.
And any particular reason for that?
Because when I am doing Bricker, and whenever I did intracorporeal, I was doing Bricker. So, and there is like possibility of like a reflux also in Wallace. You get too much reflux on Wallace also. One second. थोड़ा dictation गलत है.
We are totally with you as you do this case.
Yes, sir. One second. ये अनडॉक करके
Sir, so the only historical evidence against Brickers is a slightly higher rate of stenosis compared to Wallace. Even there.
So now we use ICT and all also.
So how does ICG help you? You would discard some part of the ureter in case you feel you're not. I know,
Just the name of all the people who are involved, like staff members.
So Dr. Ginnell, we are with you, and your instruments are.
Start, yeah. Battery is not connected.
So what exactly are the instruments that you have taken, Dr. Ginnell?
Yeah, I would illustrated in one hand. And we can show the copy.
Hello.
Yes, Dr. Gopal. Meanwhile, we'll be with Dr. Gopal. Dr. Gopal, we can see the beautiful specimen. You can let us know the size, because I see a scale lying by its side, but I can't make the calibrations.
Just to show that the specimen can come out intact, the little rim of golden that you see at the northern end is probably the non-grinnell.
Yes, we can appreciate that.
Yeah. Anyway, thank you very much.
Thank you so
After
much.
this, we will be starting with a lab partial in a little.
We'll be surely be back with you then. Meanwhile, we'll go to the partial OT, and can someone just stop this crosstalk going on the mics? There's some problem with the audio.
Transmission.
Hello?
A question for Dr. Raval. While you were looking at breaker anastomosis, you were getting a lesser and lesser number of strictures nowadays, while you were doing a wide spatulation for this. So, what used to be the previous scenario when you were getting strictures? Were those possible with guidelines from below or from upwards, or they had to be again re-explored and redone?
कॉल कर रहा है ऑर्डर कॉल करते यार उसको बार दिखा
Third screen Delhi, RGCL.
Now we use ICG and all, we are seeing it less and less. So these are the few things. Another thing which I suggest you, guys are here, I have learned it in a hard way when you never ever try to use too much when you are taking the picture, and always take the urinary bottom of the ureter side. Don't take peri-urinary sheath, because that has the blood supply. Once you take the peri-urinary sheath, that process occurs. I had the few things in my practice in the beginning. Then I realized after that, all the juniors in our center, only juniors are doing very better and your better. You don't find any leak in the required analysis. So there are few tips and tricks where you can avoid the strictures and the leak.
So do you do continuous suturing or interrupted suturing at your continuous? There is no issue. And any particular preference for a suture material that you use? PDS, okay. So can we be with Dr. Amitabh in RGCI for some time now? Because he's showing us the external view.
Yes, sir.
Amitabh, can you hear us?
Yes, sir. I can hear you, sir.
We would be happy if you can just show us one doc on one port at least.
Yes, sir. Can you see the external view of the abdomen?
We can see, can you please enlarge the screen to the maximum one? Please please enlarge the RGCI screen? Can you please make this, yes. So please, Amitabh, please proceed and let us know what exactly are you doing now.
So this is head end of the patient. This is the feet end of the patient.
Okay.
So I have decreased the tendering down, so it now is almost 10 to 15 degree tendering down only. So this is the port placement of the patient. So it is center camera arm, and we have kept these two ports on the right side of the patient and the left side of the patient. So on the left side of the patient, we have used bipolar fenestrated and the progress for the retraction, and on the right,
Your mic is getting muffled. Your mic is getting muffled, Amitabh. We want it to be clearer. Amitabh, your mic is not audible. It is getting muffled.
Now can you hear, sir?
Yes, we can. We can now.
So on the right side, I have kept two ports. So one for monopole scissor and another for the harmony.
Okay.
So now I am not use harmony. So now I will be just using 3 ports and 1 camera port
Okay.
for this patient. And the beauty of this Mantra 3 is now, because we have got the sticker arms, all the ports are in the straight line. Otherwise, previously we staggered the port. We used to make either W or M port configuration to avoid the clashing.
So we would be happy seeing at least one port being docked to the arm, robotic arm. Someone can just come in and focus on the place.
Yeah.
Please show us the latching system. Please show us the latching system and the way you move. Yes, yes.
So this is latching system.
It's nicely visible now.
Yeah.
So it's that simple. It's
very simple, sir.
It's like a magnetic thing in the Da Vinci.
Yes.
Okay.
So once the alignment perfect, it doesn't take too much time.
Okay.
Yes, sir.
So is there anything different from the XI, or is it same as that only?
Almost same, sir.
Almost same now. Okay.
Almost same, sir.
Please proceed. So can we just now shift to the Dr. Ginnell's OT, the robotic partial? Can we have both the screens now? To the cameraman, please, can we have both the screens? Yes, thank you. Dr. Ginnell, we are with you.
Yes. So just most important thing is to have the even plane between the Gerata and the vowel, and first target is to get the dissection and get the vessel. I would need to have the progress at that time, this time. Yeah, progress.
So we're using a fenestrated, a hot shears and a pro grasp. Is that correct?
Yeah, progress, yeah.
Okay.
Initially till I reach the lower part of the direction, I just avoid progress because there can be some clash. So after that lower part is adequately dissected, then you can connect the progress.
Coming progress.
So Dr. Rishi has a comment to make that it looks like it's only a tumor. You still intend to go ahead with partial?
I will see if it's only tumor, I will just try this particle.
CT seems to have underestimated it by somewhat.
Regularly if you do, sometimes you would have just discussed about but it's only 7.1 cm, just a bit above the cut-off we use. So you see, if this I feel that it is doable. Depends on the height of if that is coming up.
you ever feel that your right arm is limited to go up the upper pole, or do you make some specific adjustments for that, or is
Actually, progress I put a bit flat than the midline.
Okay.
Because when I clash, usually the scissors will be clashing with the progress. So that will help to get the upper pole.
because somehow though the company says it's always a straight line, but I believe our patients, maybe they have a smaller body habitus or something, you sometimes need to lateralize the port. It is not necessarily a straight line always.
Progress I lies a bit. Listening to Sanjay's presentation, his innovations and all. Actually, we should not do everything. We should also innovate, then only science will progress. The progress, progressing, the thought placement, everything, sometimes we may have to change. So, if you are dissecting a bit extra, the ball will fall down here. So that I will get needle access better. So I am dissecting a bit extra in the upper pole, so the bowel will be falling.
So regarding the port placement, one issue that was raised was that, not a issue but rather an innovation, that we could use a longer port, the bariatric one. My reservation for that, using that longer port, is actually the fulcrum of the port is actually 5 centimeter behind. So the fulcrum actually stays outside the patient's body, and the contact where the port is having on the patient's skin and musculature, that actually moves when you are moving your port. So although it improves the maneuverability of the external arm, but on the internal side, there is a chance that one may overstretch a little bit at the port site, and we may have complications in some patients in terms of port site hematoma and all. So do you use bariatric ports for the lateral most or the lower most?
Actually, we are using lower port, especially when the patient is bit bulky. We are using bariatric ports.
Yeah, in bulky patients that's fine, because the fulcrum then shifts into the patient's external abdominal wall. But for the thinner patient, just to gain the external maneuverability, it does add to the risk of maybe stretch at the port side.
Okay.
Tend to use the fulcrum point. So whenever you tend to put the longer one on the arm that you don't use a lot, which is the port arm, and you almost put inside only the length that you need. I totally put the fulcrum for the port arm.
Yeah, that is what I am saying. We tend to ignore the fulcrum there, and it is fine from the maneuvering point of view. But then that there is a stretch, maybe 1 centimeter, 2 centimeter. The exact point where the port is entering the abdominal wall, that gets stretched to either side.
Yes, I use the same part to take the specimen. So in a way it helps me when I'm taking the specimen.
Dr. Ginnell, what exactly has been the kidney position? Is it perpendicular to the table, or is it slightly 30 degrees?
Actually, it's not exactly perpendicular, slight deviation, comfortable deviation, so that the ports are not looking down towards the table. Just either it has to be horizontal, as filtered lightly to the above, so that the assistant need not bend too much.
I also felt maybe in this kind of a tumor, when it is on the hilum, maybe an extra 10 degrees may just have helped
at that level we have tilted.
not falling it onto the hilum.
So, another thing what we can use two suction devices is like, one is like assisting port where we can retract and setback is required.
Do you have a question, Dr. Sanjay? Okay, so.
Hello? In between the OTs, we should proceed with the surgical technique videos. And we have a talk on the rhinography techniques by Dr. Sivartsan. May I request him to come? Thank you, sir.
The size. Very good afternoon to all. So the topic given to me today was rhinography technique. It's not an easy topic to this thing, so my video is not going to be that long, so to be short, but the theory part of it is very important, especially in this case. I hope it will be fruitful to see the rhinography of Dr. Giril sir after my talk, little bit of understanding. So the concept of rhinography or renal reconstruction is avoid bleeding, avoid leakage of urine from the collecting system, at the same time preserve as much renal parenchyma as possible. The problem that we all face and why we are talking about is it's technically difficult. It's not as easy as it sounds, and there are a lot of confounding factors including surgeon, kidney, tumor, and so many other things as well. So this is the final goals that we have to ensure while we are thinking about rhinography, and there should not be any indirect trauma. That is, more than you reconstructing the kidney, doing more damage and more vascular injury to the kidney is something that we need to avoid. Now, depending on the rhinography technique, it depends on a lot of factors, as I said. The tumor size, the tumor depth, the tumor location, the resection technique that you are using, whether it's enucleation, resection, or giving a good width of the tissue, as well as the location to the central system as well as the collecting system as well. Now, what are the points to ponder whilst you are planning for a rhinography in a partial nephrectomy? Should you do a single or a double or even a triple layer suture control? Do you do a separate suturing of a vessel? PCS closure has to be done along with your rhinography, or should it be done separately? What kind of a suture material should we prefer? Should it be a barb versus non-barb? Should you do a continuous suturing or an interrupted suturing? And finally, the very classic sliding clip rhinography, which has now become the standard of surgery. Now, the evolution of the rhinography, if you see, this is how we used to do with the bolster. And that's what I used to see as a postgraduate, how they used to, cut a bit of muscle from everything and then put it on the sides of the kidney parenchyma so that the suture holds. From there, we have gone on to a sliding clip rhinography, which is now, I think, whatever has been replicated in the open lap and whatever surgery that we do for partial as well. Now, this is one of the things that first started. Dr. Jihad was telling that in one of the earliest conferences that I visited, is that he would prefer a suture that goes from everything, from the cortex, medulla, to the internal, the PCS system, and then come out as a en masse closure. Do we do that now? Generally, we have stopped doing that now. So, it all started with this Washington University technique of sliding clip rhinography. I think all of us practice this sliding clip, and this has made our job easier, definitely reduced the warm ischemia time. Now, before, why did this come into place? This was the paper which said it all. I'm just going to tell you the brief. What is the closing pressure at the tensile forces that acts when you do a slide? If you see, sliding clip technique has the maximum tensile this thing. Whereas if you see the tight suture, where you are actually, it cuts through the kidney and actually loses the pressure, you don't get that much amount of tension. So that is why this has now become the gold standard. Before we go to the technique of rhinography, we should really understand the architecture of the kidney, where you are cutting and where you are stitching and what you are taking in your needle. That is the most important thing. So we have the cortex, we have the medulla. I will show it in the intraoperative
video as well. So we have the interlobular arteries, the spurious vasa recta, and finally the true vasa recta. If you're going to injure the deeper vessel, there's no point of doing a reconstruction because that part of the kidney is going to lose the vascularity per se. It should be preserved. Hopefully the spurious vasa recta as well has to be preserved. That is the best way. The only problem in the cortical part is that cortex actually has the filtering part of the nephron. So that also has to be taken into account. So if you see here, the technique of suturing should be parallel to the medullary part rather than perpendicular, where you are going to take a bite in the vessel as well and going to cause more damage. And this is how this is to be done. If you see the pyramidal structure, there, again it has to go parallel to it rather than cutting across it, thereby tearing it. Because you're going to apply pressure, it's going to tear that area, especially the barb suture, and you're going to land up in more worsening of the issue than actually preventing it. So, coming to the actual technique per se, so there are various techniques as we know. One is the cortical suture. You just take a cortical suture, compress it, and it's done. Then you take a corticomedullary suture, which is actually the double layer that we talk about. And finally, you close a dedicated suture with the PCS for the vasculature, and then do a double layer suture, which is the triple layer suture that we know of. Now, the single layer suture is basically for an exophytic mass, which is not too deep into the kidney, or a big hilar mass where you take a deeper bite, you are going to land up in a vascular injury. Now, this is also important. You just can't ignore saying that it's a cortical stitch, so it's easy. So you just take a 2-bite and compress it, it's done. But the problem is, as I said, the nephrons are residing in the cortex, and that is where if you take too many bites as well, you are going to lose as many nephrons as possible. So that is the concept of, even the continuous versus the interrupted, where they generally say that probably interrupted is slightly better because the interrupted doesn't crush it across through the entire suture line, whereas that has never been proved, and for the warm ischemia time and the surgical ease, actually continuous is preferred generally. When you do a double layer, especially for a deeper renal tumor which goes into the medullary area of the kidney, so you see the vessel that is actually coming out, the blood supply, the interlobar arteries, and you can either do it separately or you can do it in your running suture or the inner layer that you do, and thereby you take care of this thing. Again, the most important thing is when you are doing this medullary suture, you cannot take too deep a suture every time you run it. It has to be actually quite superficial so that you do not injure the underlying vessel. For example, if you see this cut edge of this was quite a bigger tumor, so this is the classification of the anatomy that we need to know. You have the cortex, you have the corticomedullary junction, you have the medulla and the renal sinus. Now you should know the corticomedullary as the ones usually have the small thing, but if you can see here, this was one of the laparoscopic things that I did. So you can see the vessel actually there. Can you see that? So actually you can take a bite and seal that vessel. This is actually, according to me, as well as theoretically, maybe probably one of the best method to take control of the vessel without, putting a traction from either end of the kidney as well. So this is one way of tackling the blood vessel. You can see how clearly the artery and the vein branches are seen, and you can tie it separately with either a absorbable suture, probably non-absorbable is not preferred, but you can do this kind of a control of the vessels, and you can take it individually as well. The problem with that, it does increase the warm ischemia time, especially in laparoscopy.
In the camera.
Now going on to the double layer. So this is the classic technique that I have been taught as a fellow and that I used to practice as well. So you can see the pelvic calyceal system there. We en masse take the entire pelvic calyceal, the blood vessels and everything, and this would be the classic inner layer that we take. We usually use a barb statafix to take care of this layer, and you can see how nicely and closely we can actually pack it up. But the pressure on either side is slightly more than what you would take individually. So you can do that. That would be the outer layer, and then obviously the outer layer with the V-lock or any vicryl or something. So this is the continuous method where we put hemolocks on either side and compress the corticomedullary layer between the sutures. But there is also another way of doing it. As I said, you can just do an interrupted layer of the outer. No need to take a continuous bite where you are actually crushing the outer border of the kidney. You just take individual sutures of the vicryl and then compress between the hemolocks. So this is another way of doing that. I think both are equally valid. Each has its proponents and schools of thought. Probably none better than the other. So it's all how you would like to do as well. Now coming to the data that is there, this is possibly the only paper, or rather the paper which is best quoted for every technique of partial nephrectomy rhinography that comes into play. You can see if it comes to the single layer versus the double layer, that single layer trumps the double layer in most of the situations. If you come to the running suture versus the interrupted, running suture was actually better in terms of operating time, blood losses, ischemia, bleeding later as well. And when you come to the suture type, barb trumped the normal suture in reducing the complication post-operative. So this is the paper which is actually a very good meta-analysis of all the papers that has been published till now. And finally, when it comes to the HLR, it's a bit tricky. You can't do this kind of a double layer and all those things. So this was the VHS technique that was described, where you do not actually compress the vessel that is there, and you just take like a VY plasty that we would do, make it into a Y-shaped thing, and then you close the cortex. So finally, so the dissection technique, rhinography, whichever choice, but I would suggest probably a double layer if it is a deeper resection where you have almost reached the renal sinus fat, and if it is a superficial, probably only the inner layer with a barb suture, and that should take. I have stopped closing the cortical part of the kidney, especially in superficial tumors. So the take-home message being, be selective, respect the vessel, be careful while taking the cortex, lot of nephrons, you are going to lose the renal function, save the interlobar arteries while suturing the medulla, pay attention while closing the UCS defect. Single layer could be the most probably if you ask me only one thing, that could be the one thing I would say. And use of hemostatic agents as you please. There is no data on it whether it's going to better you, but why not? It's not going to affect adversely FLR, though there are certain hemostatic which could perceive later as a recurrence or something, but usually it's not. And finally, to end my talk, why suture at all? That could be probably the next talk, and this is the non-sutureless device that has come, which you can just plug it into that defect that is there, and that will reform itself to that and seal the bleeders as well. Probably this talk would be a void in the next session as well. Thank you.
So what is the suture that you use in your sliding clip rhinography?
The inner is mostly a Statafix, and the outer either a V-lock or a Vicryl, depending on this thing, but usually
because the one that you used over there and you had not clipped in the beginning, I saw you took 4 throws.
The inner, the vessel suture?
No, the outer one. So there were 4 throws, and I thought you would take the clips and save time together on all 4.
Yeah, and I take it and then clip it.
That was sliding very nicely.
That is V-lock.
Was that a V-lock?
That was V-lock.
Thank you.
So, do you now use early declamping and
inner layer and early unclamping?
Always.
So that if you have any
secondary layer is not required, you can just omit that.
So recently, I take only an inner rhinography, declamp it. If only you feel there is a overhanging part or a corticomedullary bleed, I take an outer layer. Otherwise, many of my cases, unless it's quite a deep defect and you have an overhanging parenchyma, I don't take an outer layer at all.
Not required. Yes.
Always. That is my lucky charm. That's it.
Any other questions or comments? Please. Thank you.
Thank you, sir.
Thank you, sir.
Just sir,
Srivatsan, sir, please.
Do you have tissue glues in your armamentarium?
Sir?
Either T-cell or
not
Procel?
glue. We use Surgicel, Tachycel and all those things.
Okay.
But because very rarely we use it.
Because I have heard from Dr. Prakat Dasgupta that, and Ben Shalakam as well, that whatever you do, flow seal or T-cell is not going to work. If it is an artery open, it is open.
Yeah.
You have to seal it, you have to suture it.
Agree. So, as I said, the role of hemostatic agents has never been proved that it is beneficial. But there is nothing wrong in using it in an additive value, but not as a singular value.
So you only use it when you see that the fossa is clean.
Yeah, that is just a lucky chance, sir. That's it.
Can I make a comment, Manav?
Sure, sir, please.
No, it's good to see using V-lock and, Statafix. We did use Statafix in the beginning for inner layer and later on and for outer Vicryl, but later on we switched over to completely for 3-0 monocryl. versus smoothly running and it's a monofilament, so we are very comfortable. We do
And absorbable as well, so.
Absorbable, it's absorbable.
I would use a PDS. It
PDS
serves the
also
same
you can
function.
do, but this monocryl has a bigger needle, so it, you can take a big chunk.
So do you get the dyed monocryl or is it the golden monocryl? Because I was citing.
We get, I think not, the color is blue.
Yes, sir, dyed
So
monocryl.
I actually have the golden one.
With a black needle.
I get it. Okay.
Yeah, with the black needle. Same thing I use for suturing DVC in open surgery. Yes, yes. Sir.
The advantage in the 3-0 monocryl is that you can tighten it from both sides.
Yeah.
So that's what I've always done with the 3-0 monocryl. Only one other additional point that I would make is, once I've done the radiography, I always ask them to check the color of the urine. Occasionally, when the collective, you might turn one of the arteries inside, and then post-op, you will see that they are closing out.
So what would you do, sir, if you see the color red? You would undo the,
Then you would just, the 3-0 monocryl, you would just tighten on both sides, just to see whether if you have
Stop.
already taken the artery.
you just have to tighten them.
Last clip on monocryl, either on either side, it has to be taken on the corner. If you take in the middle, it can slip. When
Or you have to do double, sir.
Yeah. So it is better to take at the corner where the clock is.
Because they would say, if it slides down this way.
It can slide the other way as well.
So you have to lock it basically in the terminal jaw. Thank you so much.
Thank you, sir.
Maybe can we just go to RGCI's OT for some time and talk to Dr. Amitabh? Amitabh, we are with you. Can you hear us? Dr. Amitabh. RG Delhi. So are we connected to them or not? So meanwhile, can we go to Dr. Ginil in Apollo? Dr. Ginil, can you hear us? Please get the connectivity to RGCI. We would like to proceed to Apollo's OT. Dr. Ginil, can you hear us? I think there is some issue with the audio.
Usually do a two-window like, hello?
Can we are with you? Can you just explain what you are doing?
I think Rajiv Gandhi is on.
No, we want one OT.
मैंने कोई ब्लड थिनर वगैरह नहीं है, एनेस्थीसिया फिट में जाएगी तो हो जाएगा.
अरे वो Amitabh.
हाँ, सेम डे होगी, सुबह बुलाना.
Amitabh, you are online. Don't worry for the next case. Do this one. Amitabh.
हाँ sir, can you hear me, sir?
Yes, we can hear you very well, and we are hearing that you are planning the next case also. But tell us about this case first.
नहीं sir, I have to pick my foot also.
Yeah, just this one.
So what exactly have you done? You have done one wall and you are putting in a double J stent, right?
Exactly, sir. So I started with the left ureter. I have completed one side of this anastomosis. Now I kept this DJ stent. So usually routinely we put in fan fitting tube, but because it becomes very like for intracorporeal thing, it becomes very you can say troublesome to manipulate the fan fitting tube coming through conduit. So that's why I opted for the DJ stent.
So now you will use a flexi cystoscope to remove it in the OPD when the patient comes later on.
And most of the time I have seen they come out by its own, sir.
Okay. And so that's another advantage of Wallace. Probably you can use infant feeding tubes with that. Would you agree?
I couldn't hear you, sir.
So with the Wallace, you can actually put in infant feeding tubes.
Infant feeding tube.
With this one.
Hello, sir.
Yes, yes. I said.
Yeah, but the problem is if you are intracorporeal, now then it becomes very difficult to take out the infant feeding tube through the conduit. And you need to ask assistant to put the bowel grasper or some like needle holder to hold the infant feeding tube and then take it out from the distal end of the conduit. So sometimes it becomes very cumbersome, very difficult to manipulate.
Okay. So can we be with Dr. Genil for some time?
Tarun, you have a faucet here or?
Dr. Genil, please tell us what are we doing
Yes,
right now?
actually there is a lympho of the hilum. When I find the lymph I usually give for 1,000, just inquiring Tarun whether there is a provision for that. So, if it is possible, just give a frozen before this dissect and so there is a lymph here of the hilum.
So you want to send it for frozen?
Yeah, you usually send it for frozen.
In case it turns out to be positive, it would simplify our
Still
decision.
prefer a radical so if it is possible, I know that even if you are doing it partial, there will not be much different than our outcome. But if the lymph node I expect a very aggressive tumor, and I may go for a radical if it's possible to be a frozen. Just have a quickly person click here. Better for metal.
So,
no, metal is metal.
In case it turns out to be positive, would you like to do a lymphadenectomy template?
Actually, information template is possible. I just lymph node, if one is positive, then the treatment protocol changes, prognosis changes, the extending the lymph node and removing the supplemental nodes may not change the outcome.
Okay.
So that I will not go. Yeah. Whatever enlarged lymph I use a classical template, limited template on the close to hilum. Because obvious lymph nodes are there, then I will go for a bit more extensive. So because the lymph node in renal tumor is not standardized and protocols are not standardized, I don't go for whatever enlarged I remove at the drainage areas, like what I am seeing here, I'm just removing, just to see if there is any positive nodes. Because majority of the nodes in the whatever prospect ties, we know that they are negative. The chance of getting a positive is low, and if there is a positive, yeah, just put a clip here. Yeah, take it here. The issue with extensive lymphadenectomy lymphoid that can happen, and is it worth for? This will help me in the HALA district. That is why just careful about the action. Okay, just put a clip there. Yeah. But yeah, okay, yeah. Just put one more again back. I think there is something on the camera now. Be careful about the vein. Yeah. Yeah. Don't the restaurant know pretty grasped for taking the report. Yeah. Take out the report. Is through the panel, you know. Camera is not clear, I think.
I'll leave it out there.
Yeah.
Good evening, Good evening.
Can we shift the audio to Rajiv Gandhi, Delhi? Dr. Amitabh? Hello, Dr. Amitabh? Hello? Audio. Hello? Dr. Amitabh, can you hear us? Are you connected to the theatre? Hello? Dr. Ginil?
Yes.
Yeah, so okay.
So I am behind the artery now.
Okay, yeah, we can see that.
So what I do is I just link two planes above and below, and then I just connect it behind. So why? Because sometimes if I'm not making this plane properly, the clamp can shoot and just get some tissue across and may not occlude properly. So it's better to have a plane above and below properly and then put the clamp.
So in this large tumor and with a CT which seemed to be inadequate with only 6 cuts or 8 cuts, there is a chance we may miss additional artery.
So that is why I just dissect above also, dissecting so seems to be one vessel is there.
Yeah, it seems like a quite large vessel.
One second, is not actually, there is some tissue behind.
You are using 30 down?
Yeah, 30 down only, but it's very difficult to do 30 up.
Okay. Meanwhile, can we have the audio shifted to the other theatre? Rajiv Gandhi, Delhi. Hello.
Hello.
Dr. Amitabh.
Sir,
Yeah,
so I am
yes.
done with the opposite side of the anastomosis as well. Can you see this thing?
Can you reorient us to the anatomy of the ureter from where it is coming?
Yeah.
From where it seems as if it is coming from above.
Yeah, so this is left ureter coming below from this sigmoid mesentery.
Okay, okay.
Okay.
Yeah, thank
So
you.
this is aorta bifurcation, right common iliac, left common iliac.
Yes.
So I am just holding the ureter, retracting it. So I completed this anastomosis on the opposite wall.
Now you are using only 3 arms.
Yes, sir. Right now I am using only 3 arms. So I will just leave some of the ureter just to hold it, so that I should not hold the viable part of the ureter, which I will use into the anastomosis.
Amitabh,
Yes, sir.
I was wondering if you would have used fourth arm to negotiate your infant feeding tube across the anastomosis.
Sir, actually now I tried to use all the arms, but because of some software issue now,
Okay.
one arm is not working.
Okay, that
So it's
is
not
different.
allowing me.
In future, we can do that. Use
exactly.
fourth arm for negotiating the infant feeding tube or something, so that
exactly.
we can replicate open completely.
I initially tried to retract the conduit.
Don't be in a hurry.
Exactly, sir. Actually, as a point of technique, we also do it that way. What we do is from the right hand port, we put a suction cannula and take it through and through the ileal conduit, and through that put 2 guide wires simultaneously, and one by one, we through those guide wire, we just slide the stent into each of the ureters separately.
Yeah, but here actually things will be in surgeon's hand if he uses fifth arm. So it will be the surgeon who will be negotiating. So that's what I was wondering.
I
But
mean,
it's not working right now.
With free arms, even with the robotic arms, it becomes difficult to travel through the conduit throughout. With a suction cannula, what happens is we can actually move through the conduit in a easier fashion, and then through that suction cannula, both guide wires can be passed simultaneously and retrieved through the proximal opening where the Bricker's anastomosis is to be done. So we are using this technique for about a year now. So Dr. Amitabh, you said you have kept the opening. Any reason for that? Closing it now?
This opening, sir?
Yeah, this one.
So I will close it now.
Okay.
So I'll just try to have some extra adventitia also for reinforcement of the anastomosis.
You are using which suture, Vicryl?
Yes, sir, Vicryl, because it is barbed suture, so it stays whenever you tight it, it stays, so it just reduces your effort.
So this is straight off it?
Yeah. Needle holder, छोटा वाला.
So Amitabh, this is Stratafix or is it Vicryl now that you have
No,
used?
sir, this is Vicryl, sir.
Vicryl.
So we use Vicryl here at our institute for intracorporeal ureteroileal anastomosis, sir.
30 or 40?
This is 40, sir.
40. Okay.
Advance.
He actually meant polyfilament.
Can we shift back to the other theatre? Dr. Ginil?
Yes.
Yeah, so what's the plan as of now?
And decide after just seeing the tumor, I can see a lot of collaterals in the area.
Do you think intraoperative ultrasound could help in?
Yeah, we are planning for intraoperative ultrasound.
Okay.
It will be business, sir. It will be like facility.
Yeah. Clean the camera.
May I request Dr. Ashish Khanna to present his video on ERAS and minimal invasive uro-oncological surgery.
So good afternoon everybody, and my talk is actually not going to be a video, it's going to be a little bit of a didactic type of lecture. Yes sir. Yes sir, I am playing it here. आप छोड़ दीजिए. So the concept of enhanced recovery after surgery is not new. It was introduced in the year 1973, and with minimally invasive uro-oncology, it is like Sone Pe Suhaga. So we know that surgery generates an intense physiological stress that leads to a reduction in the functional capacity of the patient, and it is secondary to the pain, the inflammation, the immunosuppression, the rapid depletion of the liver glycogen, negative nitrogen balance, and the insulin resistance, that we see that there is reduction in this functional capacity, which takes almost few weeks to months for the patient to return back to his baseline. For oncological patients such as those undergoing surgery, the next step is return to the intended oncological treatment, which is RIOT, RIOT. The enhanced recovery after surgery therefore aims at accelerating this functional recovery, thereby reducing complications, so that we can return back to the baseline as soon as possible. Enhanced recovery after surgery is a multidisciplinary collaborative effort, also known as enhanced recovery programs or fast track protocols. As I said, it is an evidence-based collaborative perioperative care pathway which is aimed at improving recovery after major surgical procedures by maintaining the preoperative organ function and reducing the body's stress to surgery. It was primarily introduced for colorectal surgeries and has thereby been adopted by urological surgery, and at present most commonly it is being used for radical cystectomy, because this surgery is associated with higher rates of postoperative IES because of deperitonealization of the pelvis during extended periods of pelvic lymph node dissection, longer operative times, older patient population, and high smoking rate. There was also always a conception in the mind that overnight fasting has led the patient to be in volume deficit. Added to it, the long surgery, one started pumping them with loads and loads of fluid. However, with the advent of ERAS, we have evidence-based medicine which has shed light on the previous misconceptions. And the guidelines of the ERAS Society for the Radical Cystectomy were published in 2013, and they have tried to prove each and every component of the ERAS protocol. So in this ERAS protocol, we have primarily preoperative, intraoperative, and postoperative measures. And in the elaborated protocol, there are almost 22 components that are there. For positive time, I am going to discuss only a few important components, such as preoperative mechanical bowel preparation. So currently the recommendations are that safe omission of preoperative mechanical bowel preparation can be done, as it is seen that it does not have any bearing on the first bowel movement, the morbidity, or the length of hospital stay of our patients. Coming to an important component that we can practice in our day-to-day lives is carbohydrate loading of the patient. Earlier, it used to be prolonged periods of fasting along with depletion of the glycogen reserves of the patient during this fasting period. It has now been seen that clear liquids can be allowed up to 2 hours prior to surgery, and preoperative carbohydrate loading, especially in non-diabetics, helps in reducing thirst, insulin resistance, helps maintain lean body mass and muscle strength. Multiple studies across various specialties have shown that it leads to decreased length of stay with no increased incidence of aspiration pneumonitis or other complications. Coming on to thromboembolic prophylaxis, pelvic surgery for oncological causes itself is associated with high incidences of deep vein thrombosis and subsequent pulmonary thromboembolism. In this study, it was proved that not only during hospital admission, prolonged enoxaparin administration up to 28 days led to significant reduction in the incidences of venous thromboembolic episodes from 12% to 5%. So therefore, both mechanical and pharmacological prophylaxis are recommended for our patients, and the pharmacotherapy should continue for at least 28 days after the surgery. Ileus is an important problem that all of us face, specifically for patients undergoing radical cystectomy. And albumin is a molecule, although it is not available in India. It was introduced because most of these patients were receiving opioids for their pain control. So the opioid agent acts on the bowel as well as on the central nervous system. In the central nervous system, it produces pain relief, but on the intestine, it led to the ileus. So this mu opioid receptor antagonist has peripheral action, and it blocks the activity of the opioids and therefore reduces the incidence of ileus. It has to be started preoperatively, and then it is continued in the postoperative period. In the absence of this molecule, we at Rajiv Gandhi are now routinely using what Studer has described in their previous papers on ERAS protocol, which is neostigmine 0.5 milligrams subcutaneously given at 5 to 6 hourly intervals, and it helps in early recovery of the ileus. Intraoperative measures are critical because besides surgery, the parts that play an important role are actually in the hands of the anesthetist. And Studer has clearly shown in this paper that restricted fluids with preemptive norepinephrine infusions during surgery leads to significantly lower complications, gastrointestinal as well as cardiac, as compared to liberal fluid replacement during surgery. And therefore, the aim is to maintain zero balance, and normovolemia is paramount. Molecular studies have shown that in addition to the endothelium, it is the glycocalyx which acts as a barrier and prevents damage from overhydration. During periods of overhydration, it is seen that this glycocalyx layer is destroyed, and because of the interstitial edema, there is hypoxia of the peripheral tissue. And this leads to the complications that are associated with overhydration in the form of cardiovascular problems as well as bowel edema and bowel complications. Finally, coming on to the post-operative factors, simple maneuvers such as early removal of the nasogastric tube, prevention of post-operative nausea, vomiting, simple aids such as gum chewing enhance the recovery of the post-operative ileus. Always use multimodal analgesia in the form of epidural analgesia, which has to be placed in the thoracic region for radical cystectomy. We always try to mobilize the patient early, start oral diet as soon as possible. And one important aspect of ERAS protocol is to audit for compliance and outcomes. Because of these 22 factors, it has been seen that the compliance for so many factors, depending on so many disciplines, is less than 75%. And it has been seen that with increasing compliance to these factors, there is incremental benefit to our patients with early recovery and early discharge from the hospital. So with this, I would like to end my talk on ERAS and minimally invasive uro-oncology.
What do you give for glucose loading?
Sir, we use carbolode, which has maltodextrin. There are studies that they have shown that at least 12.5% of maltodextrin or a glucose containing drink, which is easily absorbed, like Gatorade can also be given to these patients, which is rich in electrolytes as well as glucose. At our institution, we give carbolode.
And when do you give it?
Sir, so we give 100 grams is given at 10 p.m. before the night.
Sorry, 100 grams.
100 grams. 100 grams, that is 2 sachets of carbolode, are to be given in 400 ml of water at 10 p.m. that is prior to the surgery, and in the morning at 4 a.m. we give with 200 ml a single sachet of 50 grams in non-diabetics.
And in diabetics?
In diabetics, we actually don't give the carbohydrate loading. There are studies, while reviewing the literature, there are studies where they say that carbohydrate loading can be given to diabetics as well, but there has to be monitoring of their blood sugar level and may require administration of insulin. And for that purpose, because the staff is not available, the doctors or the people to manage the hyperglycemia are not there at that time, 4 a.m. or so, we don't give the carbohydrate loading in diabetics.
That's the struggle, because half of our Indian population are diabetic.
That's true.
And
Moreover that, you encounter more ileus in diabetic patients.
That's true, because of the neuropathy component and
Because of the autonomic
susceptibility
neuropathic
to infection,
component, yes.
wound healing, yes.
Yeah, so it has become very, although ERAS protocol has been doing well for last few years, but the group of patients where it is most needed, I don't know whether it works or not. What do you give in your, do you use epidural analgesia?
Yes, sir. Sir, there is one point I would like to make. Most of our patients are actually not optimized for their comorbidity prior to surgery. So if we see in the pre-operative period, there is the second point is pre-operative medical optimization. So blaming diabetes for the complication is not actually the reason. If we give them proper time with exercise as well as their control, and we optimize, these patients definitely do better than those who are not optimized.
And how much time do you take for optimization?
Sir, so actually none of us can give that much.
So if it is a muscle invasive cancer, you cannot wait for a 4 months, 5 months period.
Sir, actually we can, because now the dictum is to give them neoadjuvant chemotherapy, and that gives you 3 months to 4 months to optimize all of this. And that is why there is also the proponents of ERAS actually suggest that this patient at the time of neoadjuvant chemotherapy has to be told clearly, communicated clearly कि 3 महीने हैं आपके पास अपनी जिंदगी बदलने के लिए, आप अपनी मेहनत करिए, हम अपनी करेंगे, जैसा होगा देखा जाएगा. Smoking cessation, alcohol abstinence, all of this, it actually gives you a lot of time to rehabilitate these patients so that they can do better before the surgery.
Very well said.
I have a question. Thank you very much for a very nice presentation.
Thank you, sir.
For those who perform a lot of radical cystectomies, with all this background, this ideal, we have a lot of problem with postoperative paralytic ileus. Early oral feeding we also try, but have you seen in your practice that certain modifications have improved this?
So as I said, I joined Rajiv Gandhi in 2020. At that time, the protocol used to be perinorm and lazurite given to these patients. The rice tube was kept for prolonged periods. We also experienced prolonged periods of paralytic ileus, and then we introduced neostigmine, as I said, because albumin was not available. And believe me, sir, most of our patients do quite well, and our median hospital stay for radical cystectomy is almost 4 days only, which is equivalent to what these ERAS protocol people are advocating. Although there is a section of patients who do not respond to neostigmine as well, in those patients, as all of us practice, therapeutic gastrografin can be given, which is the dye that we give for the contrast CT, and it has been seen that in these patients who do not respond to neostigmine, some of these patients can get away from re-exploration with the use of gastrografin itself. Frankly speaking, Riles tube at our institution also, we are still a little apprehensive to remove it early. So although we clamp the Riles tube at the first day, it is removed subsequently on day 2 or day 3 only.
See, the problem with paralytic ileus is usually it is multifactorial. So it is not only the gastric emptying, the sepsis, the tissue handling, the extensive peritoneal dissection, etc. So I just wonder, it's a nice thought. I spoke to Dr. Rawal, we'll try this neostigmine and say, Sanjay, do you have any experience with neostigmine?
I've never heard, so that's the reason I wanted to ask. Is there good evidence basis for it?
So as I said, we had actually not adopted, neostigmine is given for pseudo-obstruction of the colon. It was given intravenous, where bradycardia was the main side effect for intravenous, because of which the patient had to be in the ICU before he administered the neostigmine intravenously. Studer in his protocol has suggested to give it subcutaneously, and multiple studies are there which show that. We have even used this in CAD patients, in patients with asthma, where the cholinergic agent can induce bronchospasm, and in all these patients, none of these patients have actually had side effects of neostigmine. The only common side effect that the patients complain is the injection site is very painful. So most of them do complain of this, but neostigmine as such is very safe.
And the neostigmine is already proved for the pseudo obstruction,
yes,
and it is very much helpful.
Yes, sir. And there are studies for subcutaneous neostigmine also for relief of post-operative obstruction.
But you have to observe the patient.
Sir, so no, that is what I am trying to say.
Not for subcutaneous, for IV.
Yes, sir. For IV we need, but for subcutaneous we give them in the wards as well, without any monitoring, and none of them have had any issues. Even CAD, bronchospasm, COPD, none of them.
You have not encountered any side effect?
No, sir.
And the last one was in UK, we used to give the Clexane for 28 days. much more of a problem in India or much less of a problem in India as well? I haven't seen DVT that very often compared to what we used to see there. So are we trying to just replicate it without evidence? Because DVT is not that significant an issue. At least I haven't seen that very often.
Sir, I remember one of our patients had come to us with massive pulmonary embolism, and because at our institute we don't have a dedicated angiography suite or something there, we had to refer him to some other hospital for that. There are patients who may not even reach the hospital before they can report the DVT when they have massive embolism. So in countries like India, where the medical system for these ERAS protocols, at the time of discharge, they have a staff nurse that is allocated to these patients. Phone calls go to these patients at regular intervals, checking upon them. Fluid is given, around 1 to 2 liters is given almost every day or alternate days. At our setup in India, actually, when the patient leaves, he goes directly back home and there is nobody who is there to check on them. So the true incidence of DVT and embolism, we don't know, because most of them might not come back to us.
So do you now discharge patients on Clexane?
Again, frankly speaking, we don't.
Yeah. Because for the first 1 year I have done it and they were having more problems with it rather than a solution. Because in UK, even for radical nephrectomy, every oncology patient had to have it for 28 days. So I was convinced enough for cystectomy but not for partial nephrectomy and those. So currently I don't do it, so that's the reason I was asking.
According to me, in pelvic surgery, at least for prostates and bladder, where lymph node dissection is done, because lymph node dissection itself is a risk factor for DVT, my personal preference would be, if the patient is educated enough, cost is not an issue, they should get it. Because more often than not, they develop pedal edema because of the lymph node. You get a Doppler done, there is sluggish flow, and eventually they'll end up with a DVT. They do, because recently also we had one doctor patient himself. We had not prescribed, he developed lymph edema, we got a Doppler done, there was sluggish flow, we had told him about it. We started Clexane, he's doing well now, but he did develop DVT. So maybe compliance and follow-up is required to make it a day-to-day practice.
I have tried the oral medication that the orthopedic surgeons tend to do it. It tends to overcorrect. I have had more problems with that. So
Eliquis and all of these agents, yes.
I had more problems. Raghu.
I have quite a few points about this. Sanjay knows that we are a great proponent for a long time, since 2008-7. First and foremost, ERAS principles apply for non-cystectomy as well.
Yes, sir.
We did a study of 302 patients and presented in European Urology 3-4 years ago. Kunal did it. So principles are the same. Most important, the couple of things I want to add upon is, one, no opiates post-surgery. A lot of people give tramadol as a pain relief. That's a very bad idea to do that, and definitely it will prolong the ileus. The second thing is no gastric tube. The gastric tube is removed at point of extubation. No gastric tube. If the patient will develop an ileus, he will develop ileus on day 3 and day 4. You can easily put a ice tube on day 3 or day 4, they will decompress and they will pass the motion the next day. That's the second thing. And third,
Can we pause the session for this? I would like to announce a conclusion of the chairpersons for the coming session. I would invite Dr. Sanjay Anna and Dr. Anand Raja to take the stage and proceed the remaining part of the.
They need to go for the lunch. Thank you very much. Sorry.
Thank you so much.
so whilst the chairpersons are changing, I'll tell a few things which will be important for the juniors here. So no gastric tube, remove gastric tube at the point of extubation. Always ambulate patient on day 0. All our patients are made to walk on day 0. The only patient who doesn't walk on day 0 is a partial nephrectomy. Rest of all the patients walk on day 0 dot. Many patients get discharged on day 0. That includes nephrectomy, nephrouretrectomy, prostatectomy. They all go home by evening. There is no need for them to stay. Fourth, Clexane can be easily given at home. You just tell them, give the syringe, ask them to do it once, they will do it. 7 days to 10 days Clexane can be easily done. I agree with Sanjay. We are not seeing DVT that often in India compared to what we do in UK. Patients can administer, when they can administer insulin,
yes, sir.
They can administer Clexane.
They do.
So it is not a problem. The thing is, more than 7 to 10 days doesn't seem to be of any value. And in spite of Clexane, one of my patients developed DVT, a post-prostatectomy, by the way. So it can happen in spite of Clexane, at least medico-legally will be safe. So administering them at home is quite possible. And lastly, there is a magic drug which I cannot tell in an open scientific forum. My trainees know that very well, but I will tell you when you come in and meet me in the corner there. It is something that you can administer and they reverse the paralytic ileus like a magic. Last point, so Sujay, day three, sepsis is the most important, yeah? Day 3 to day 7, if you can, if you need. So don't escalate the antibiotics. We always give cefsulbactam as baseline and we reserve the meropenem for day 3 escalation. Inevitably, almost 70% of the patients get escalated, but it happens, yeah? And lastly, the longer you operate, the longer they stay in the hospital. So fast operation is very important. Fast means not rapid science operation, but you have to, whenever you are giving this operation to the trainees to do, understand which part they are going to do, which part you are going to do, and the team works seamlessly to make sure that it is all completed. And no epidural. There is no role for epidural at all. You put an infant feeding tube in the abdominal, the rectus sheath, give them, also that is also administered by the patient itself. Epidural stops the patient walking. So no patient of mine has an epidural and they are walking on day 1. Thanks.
There is, sir, I would like to, few of our patients, you try to ambulate them and they have vasovagal on the first day. One of our gynae patients started walking on POD0, had vasovagal, died. So how do you, in patients who are volume depleted, specifically when you are during surgery, you are not giving them adequate fluid, you make them sit, they do okay, you make them stand, they have a vasovagal attack. How do you manage all this?
Your anesthetist is the most important key to the whole process. So the anesthetist, my anesthetist will wait till the point of opening the ureters. The ureters we don't clip at all, except robotic surgery where we clip. In open surgery we put the ureter. I learnt it from Sanjay. You put it into an infant feeding tube outside. Yeah. And then the moment we start anastomosing, they will resuscitate the patient. He does an ABG at that point, resuscitate, and another ABG at the point of extubation. All patients are extubated. They come to surgical HDU, resuscitated in the surgical HDU, and by evening they are sat up in the bed. By about 8 o'clock they are sat out, and about 9 or 10 o'clock, if my resident is good like Dirush, the patient is walking. They usually have to take a video and send it to me. They do.
Okay.
The first time there may be vasovagal, obviously they have to be under supervision, and if there is a vasovagal, you make them sit back again and go back. The idea is to push them. The idea is to not to make them complacent. You have to push them so much that they have to believe that they are fine. Most of this is a mental mindset where the patient believes that they have a long operation and therefore they are sick. You have to convince them that you are not sick.
Thank you.
Why there is a variation of rule in partial nephrectomy?
I'm scared. That's all.
What was the question? Surika sir, what was the question?
He said, why don't you ambulate or discharge on day 0 and partial? I said, I'm just scared, that's all. Nothing more than that. They also go home day 1.
So most of the components of ERAS which we are not following is out of apprehension only.
Yeah.
And so the ERAS society actually designates a center when it takes it under its care, and the whole institute comes under audit, and it is only then when you start following every component and in front of you that this apprehension is going to go.
A few other points which I'm sure all the cystectomy centers will be doing, but juniors, please look out for calcium and magnesium on day 3 to day 5. That is one of the most important component of deficiency which you will miss because of huge massive fluid shits that happen in the patient, and if you are missing that, they inevitably have prolonged ileus.
Because that magnesium deficiency, calcium deficiency is associated with hypokalemia and other abnormalities. So,
thank you guys.
Yes.
Thank you very much. Thank you.
Thank you.
Shall we go to the theatre? Amitabh is finishing and Ginil probably has finished. Shall we go to Ginil's theatre, please? I think that's Apollo.
I have one point for Amitabh. Is Amitabh listening?
He can't be bothered.
He can't be bothered, of course, yeah.
He will listen.
when you are chatting. No, one of the suture techniques, I've seen a lot of people using, taking 2 sutures, putting a knot in the end, and then trying to do the anastomosis in the ureteroileal. the easier and simpler thing is to use a double-ended Stratafix, yeah, because your corner is secure. The most important problem in a ureteroileal is the corner, and the corner is secured without a knot. The knot always causes fibrosis, and therefore the knotted suture always causes lower fibrosis. So you secure your corner, the most crucial corner, with the double-ended suture, and then have the knot somewhere in between, so that you're not cicatrizing the suture. If Amitabh listen, that's the point.
You can raise that point again. We'll just, can we go to theatre, please? Rahul sir wants to.
Careful, bleeding there.
Rahul sir, you can.
Unless there is any benefit.
Yeah. This corner suture actually, we probably have done more than thousands of cystectomies in our sector. We have never seen any problem with it. The problem will occur definitely if you are tightening the sutures too much or you are taking a very acute sheet. This is the most important part. Corner suture taking separately is probably better to avoid the stricture later on rather than sutures and one suture with a double, I don't say I've never done it, we never required it. Other intracorporeal, we are not doing much nowadays, it's just for the workshop we have done. We give it to the juniors, they do almost, every case of our new bladder or technique, the junior guys is doing it, they following the same thing.
You do use two sutures. Oh. Ginil, can you hear?
Yes.
Can you tell us what you're doing?
Actually, when there is a tumor like bipolar, I would prefer to have some sinus dissection so that I will get the mounting very easier. So I'm just attempting with a bit of sinus dissection, and if it attacks the tumor vessel, then the dissection will be easier. So negative until sometimes I may end up in the bleeding. Reasonably I'm sure that this is the tumor vessel where it's going there. But if I am dissecting that in case of either I am sure I will clip it and go, if I am not sure I will dissect the item and go, so that when I am cutting in pipe, I will be having a plane there to just as a marker. So I'm just already located the tumor and I'm just dissecting the hole. So about one vessel here that is going to upper hole, I can preserve that. I know that that is not anyway going to affect the tumor. This is actually going to a lower hole. And I know that majority, but this one is the main feeder to a tumor. I'm reasonably sure because he is going to the area. So from the CT impression. So if I am preserving these two vessels, I can preserve a reasonably good amount of and then the chance of finding your bleeding can be reduced. I can get the feeder vessel control here. That's my plan. Then if I am controlling that, then large tumor action will be a bit more smoother.
Are you not planning to clamp the whole artery? That's one.
Yeah, I am going to clamp the artery, but I will, if I can put it here, the tumor vessel, then even if after unclamping, chance of having a reclamping can be reduced.
Do you want to use the ICG? It seems to be an exciting.
Definitely using an ICG to confirm that I am the entire tumor. But since it's a large cell with we are probably having multiple feeders, I don't want to have a secondary or complete the vessel ischemia in this patient.
No, so I was mainly looking at, let's say that you clamp that artery that you think is the feeder artery, then you see whether the normal part of the kidney is becoming ischemic. If it isn't, then you know that it's only going to the tumor.
Because more than one vessel, because it's a large tumor. Small tumor is fine.
So I don't want to take a chance. And what I understand is if the chance of bleeding is higher, if I'm planning for this severe ischemia, and I will end up in more ischemia than usual.
Thank you. Amitabh is almost finishing. We'll go to RGCA and then come back to you.
Yeah, sure. Yeah.
Thank you.
I thought I will prepare this one better.
Amitabh?
Hi, yes, sir. Good afternoon, sir.
I'm Sanjay Edla, and then Anand Raja sir is also with me. Yeah?
Yes.
The other people were too tired watching you and they felt hungry, so they went for lunch. No, it was brilliant operating. Can you just tell us what you have done and why you have done the way you have done it?
Okay, sir. So I have finished the ureterovalvular anastomosis. So that how I does actually. So there are a lot of other techniques also where they start not from the angle, from the opposite wall, and they complete as a whole anastomosis taking 2 suture. But I am comfortable with this. As I told, I have not done too many cases intracorporeal. I have done 7-9 cases only. So in every cases I did ureterovalvular just same, because I am using this same technique in open surgery. I am pretty comfortable, and I feel that because in my experience I didn't experience any ureterovalvular stricture after intracorporeal anastomosis. So what I feel the basic concept behind having a very good ureterovalvular anastomosis is having a very good validity of the ureter and spatulate it in a very good length, try to have a very wide anastomosis, and try to preserve the vascularity while suturing the ureter with the ileum. So I don't want to have this persisting effect also, just starting from the one end and taking one suture along with. So that's why I always use 2 sutures and go separately on the both wall of the ileum and finish on the opposite of the ureter, so that I don't have any persisting effect. I am having a very well patent wide ureterovalvular anastomosis. So that is my concept. So, and I follow that because I didn't face any issue using this technique. If there is another technique, I'm very well I welcome from the audience if anyone wants to share his experience or his technique.
The staple line for the ileal conduit, is that, have you cut it off or is it still there?
Yes, sir.
Staple line that you used for the separation of the small bowel.
Small bowel, so I have separated it already, sir.
No, do you need to isolate it with any suture or you don't think that's required?
So actually what happened when we started doing intracorporeal anastomosis, we felt that now patients are having too much paralytic ileus compared to open surgery. And even in our open, so it may be controversial also to say that when we used stapled anastomosis in open cases, still we had very high incidence of paralytic ileus. So in open cases, we switched over to in-twin hand-swan anastomosis. And if we are doing this intracorporeal anastomosis, so what?
So Dr. Ashish, I think he wants to know whether you will bury that knot or that end or not, I think.
No, the staple
so that
will be,
no.
You don't need.
So,
okay.
So previously, two-line suture when people thought there will be a leak, now the triple-line suture, so hardly there is a need to bury it.
No, sir, we didn't see any.
That's what it doesn't do anything.
No, sir.
So for neobladders,
pardon, sir?
For neobladders as well, you just leave them there. You're not worried about any stone formation with the staple line.
So in that case, what we do, sir, we take 2 or 3 interrupted sutures.
Yes.
Just behind this stapler line.
But
so what it does, it approximates the mucosa just beyond the staple line, so it doesn't go over there, so it might reduce the chances of stone formation, because we haven't seen any stone formation at the Studer limb.
Yeah. Because I always felt putting the suture is treating the doctor rather than the patient. We are trying to prevent something that might not happen.
Never happen. So, are you also, Dr. Amitabh, are you also planning to now retroperitonealize everything, or is it your usual practice?
So what I do, sir, so that's why I was saying, so instead of retroperitonealization, what I do, I just, this ileal osmosis, I just fix this anastomosis to the lateral wall, here like this. So there is technique, and it has already been published, that high suspension, we call it high suspension. When you stitch this ilioilal anastomosis to the lateral abdominal wall, the chances of paralytic ileus is very less. So there is no need of doing retroperitonalization of this proximal part of the conduit.
So do you, if you do that,
whatever you,
Dr. Amitabh and Dr. Rawal, question to you there. I got it, sir. So question here, now you've anchored this conduit at two places, one where it's
Small bowel
the small bowel anastomosis. Okay, okay.
And the theoretical way of retroperitonalizing what Dr. Anand Raja sir has said of the ileal conduit, that's not required? I've never.
No sir, we don't do it.
Are you also, do you also anchor the conduit to close the lateral pelvic gutter? Do you also do that, or you've given up on
No,
that
sir.
also?
No sir, no sir.
Okay.
Sir, so I am done with the procedure. So can we
Can you just theoretically show us what you will do when you say you fix it?
Okay, so it is very simple, sir. So I do it when I open the abdomen, and while delivering a specimen, I just stitch. I take only 1 or 2 stitches from the conduit and just I fix it a little.
Okay.
Yes sir. Yes sir. एक वो सूचर दे देना.
So you, as Rahul sir has said, you are stopping it from falling in and causing any adhesion and blockage.
Exactly, sir. So I can just show you diagrammatically also in this case. So what happens when patient, after finishing this procedure, what happens when you take out conduit
this falls
through the anterior abdominal wall? What happens? This conduit, this LALL segment goes into the pelvis
and
like this, like this. You are getting my point?
Yes.
So the conduit will be here on lateral side, and on medial side, this ilioilal segment rotates on the mesentery and on the ureter and goes into the pelvis, deep pelvis. It forms the lot of king section because of the fibrinous adhesion, and that's why it causes sub-obstruction and frank obstruction, whatever, depending on the patient fate. So now what we do, we just prevent the falling of ilioilal into the deep pelvis by stitching the proximal part of ilioilal to the lateral abdominal wall. That's it.
And the conduit will be lateral to this.
Yeah, so conduit will be always be lateral to this thing. Yeah.
Thank you very much. Yeah. Thank you very much. Thank you, Amitabh. That was brilliant.
I would like to thank the, yes, sir, I would like to thank the organizer also, officer also, and my whole team, very naughty, for giving me this opportunity and assisting me.
Brilliant. No, to do live surgery on a new equipment for the first time, it's always takes a lot of bravery and skill.
Yes, sir.
Thank you very much.
Yes, thanks, sir. Thanks.
And you look an absolute superstar with those glasses. Just for this reason, I think we should operate on mantra.
Thank you, sir.
Amazing surgery, Amitabh. Amazing. Thank you so much. It's a treat watching it.
Can we? Thank you. Can we go to Fortis, please? They're doing it. Hello.
Hello, can you hear me? Hi.
I can hear you and we can see you probably.
Yeah, okay. This patient has a right-sided renal tumor, which can be classified as a small renal mass because it is just about 3 centimeters in size, so accidentally detected. But although it is classified as a small renal mass, if you see the CT scan pictures, it is posteriorly located at the hilum, and have a look at it. My colleague Dr. Sandeep Prasad will go through the CT pictures with you. What I'm doing meanwhile is releasing the liver as much as possible. Just as on the left side we release the spleen, on the right side as well we need to release the liver, and you can see this is the inferior margin of coronary ligament, superior margin of coronary ligament till you reach the right triangular ligament. So try to release it as much as possible, and that actually will help you. This probably more so in case of adrenal tumors and upper polar tumors. May not be so much necessary here, but I do it as a matter of routine, and it also helps others to sort of learn this. So until you reach the bare area, try to release the liver as much as possible and lift it up. So this will help us to place the 5th port, that is the liver retraction port. Yeah, my colleague will go through the CT scan with you.
Dr. Can it be the other way around, in that because you are mobilizing the liver so much, will it keep on falling onto you? Is there any reason where, let's say, occasionally you will have the liver coming up to the right iliac fossa? In that situation, you should not mobilize the liver then, as you are doing there?
Yeah, because then much of the intraperitoneal liver is already much mobile, then it's not necessary. But here sometimes the attachments just tend to keep the liver being pulled down and keep giving traction on the liver retraction pediport. So let's place the liver retraction port and see how much more we need to release it. Yeah.
We are looking at the CT scans.
CT scans, yeah. Camera kache nahi ja, ekdam. Please stay close by. Zoom in there. Zoom in there, please. Yeah. Liver port. Liver port.
Right up front. Yes, yes. Fine. Over it down. Over it down. No. Knock that. Knock. Camera. Microphone like microphone.
तुम्ही काছে जाओ ना तुम्ही. Go close. Zoom in every picture.
Microphone আছে. Microphone ছাড়া হবে না. এই তো ছিল একটু আগে হবে না.
Hand phone. Mic. Hand mic.
There is a lot of pixelation with that. We can.
Yeah, I'm telling the camera guy to zoom in well.
Maybe on one representative photograph, if he can image that, if he can zoom in, might be better than trying to show multiple pictures.
Yeah.
That's what I'm.
Show us a little picture, please. Yeah. We have a right renal pelvis tumor, medially located. It says zoom in on this pic. Yeah. Yeah, zoom. So we have the pelvis here, and here is the tumor is just impinging on it. So here and here, these two pictures represent. We just shown these two pictures.
That's Ginil. No, when we
lock लगेगा रे.
Ginil.
No, lock लगेगा. Lock लगा देना. So this one.
Most probably that's a Fiji. Ginil?
Come back.
He might hear you without the mic.
Can you hear?
Yeah.
I'm doing microphone marking. I just want to, because what I've done is I've actually tuned
that that must be the vessel, correct, because below that is not ischemic, it is not ischemic. Maybe there is some more feeders that assume that that was a vessel and I palmed that vessel. I have planned the vein because there can be other area maybe draining to that and sometimes it may bulge and can cause recovery. So I haven't planned the vein. So I have planned the artery here, spanning the lower polar and upper polar artery. And now I am just assessing the size of the tumor and margin. So I am using the new BK probe. So I am used to the old system, old BK probe. The thing is, difference is that this is more pliable like the Hitachi one, and this is smaller one, and the mobility is better, and quality also I feel that is slightly better than the old probe. These are advantages. So I repeat ultrasound because one is that is how we learn the ultrasound how to manage. So you can see that the tumor is reaching up to there, and after that the pelvic system is clear. Okay. So in between you must have seen that I have dissected the pelvis also from inside in the vessel. So this actually reduces the chance of and reduce ischemia time also if you are dissecting the column in advance, because all the pelvic as a major we will be able to avoid. So the tumor starts from here. Yeah, this is the tumor is up to here. So I'll be making a plane there, and then to cut, that is my plan after clamping. I will clamp that vessel because I don't want to have a bleeding and extra ischemia time. I'll just put it there.
Dr. Gopal Krishna. Hello?
Yeah, so can you hear me?
Yeah.
So what we are doing now is we've sort of removed the colon out of the way. That is the renal vein, as you can see here.
Okay.
So our first step is to try and to the pedicle. I think my colleague would have shown you the CT image. There is a single artery. The tumor is posteriorly located near the hilum, impinging into the hilum. So our plan will be to, once we hit the pedicle, our plan will be to flip the kidney completely. That's why I have, and because it is posteriorly located near the hilum, we will also have to get the ureter out of the way.
We will be with you for another 15 minutes. After that, we have got semi-live sessions with international faculty, sir.
All right, wonderful. Okay.
Just wanted to ask you a couple of things. So you will go mobilize the lower part of the kidney, lift it up, isn't it? And yes, flip it on.
Yeah, no, first I'm just going to try and see the artery and vein first. Then after that, I'll start mobilizing the tumor.
And currently I can see that you have got a grasper in your left and a harmonic in your right. What all have you tried and have settled with this now?
Pardon? I didn't get you.
What all right and left hand have you tried before this? Because you, even in the other case, you said right hand harmonic is the best thing that anyone can use currently. What all have you tried to settle with your current combination?
Well, in the right hand, it's always the harmonic.
Okay.
As I said, which is both a dissector, grasper, and has multiple uses. It is pretty safe, provided you know the energy transmission and the time up to which that happens. On the left hand, I normally use a non-tooth grasper. Here, we are just looking for a non-tooth grasper. As soon as I get that, I will use it. And the assistant is having a sucker. which he is using for traction as well as for suction. You don't use Pardon?
The question I think was that before you settled on this, did you use any other instrumentation on your right hand? And what advantages do you see to use this one as compared to what you used prior?
Well, before the harmonic came in, I used to use a hook diathermy. The hook is very nice because the transmission rates are extremely minimal, and as soon as you stop, the heat stops. The only problem with the hook is that it tends to get stuck in tissues, and it's often difficult to extricate it, and that wastes a bit of time. Then I also tried the scissors. The scissors, again, sometimes you are unable to diathermy so well. So that's the reason why I ultimately settled down with the harmonic, which I've been using for many years now.
And what about the ligature? It's curved, it's angled.
Yes, I know. We don't have a ligature in our hospital, so I've not used the ligature ever.
Okay.
So the harmonic is what we've been given, and that sort of worked quite well with us all these years.
In your left hand, have you tried bipolar?
No, not bipolar on the left hand. The left hand I've always used rasper. Actually, harmonic does the work of coagulation, cutting, lots of things. So you don't need a bipolar if you have a harmonic in one hand. If you have a scissors in one hand, then sometimes you need bipolar for better coagulation. But if you have a harmonic, then that problem is solved. So you just have one energy device on one hand and then a grasper on the other hand. So we are just moving under the renal vein, trying to look at the pedicle and get to the pedicle first. Usually I don't mobilize the kidney. I mean, I don't go by the lower pole approach. For radical or for anything, I usually go to the pedicle first, get the artery, clamp it if I'm doing a radical nephrectomy, then go to the rest of the kidney. So that's what I'm doing here as well. I'm just trying to work my way and see where the renal artery is so that we can see it and then get control. That gives you a lot of confidence first. So you do the most important step when you are fresh. So I tend to go to the pedicle first always. Sometimes, I mean, I know other people would normally lift up the lower pole and march the way upwards. That is also.
The problem with what you are doing is, in case if you end up in trouble, you haven't mobilized any part of the kidney for you to gain control.
Well, the answer to that is that if you have got a renal artery, then you have taken care of 70% of your problems, especially in case of radical nephrectomy. If you have got control of the renal artery and if you have clipped the renal artery, then the rest of the radical nephrectomy actually becomes much easier, even for larger tumors. And I think that's one of the ways to deal with large renal tumors, where because of this numerous sort of vascularization around the kidney, you cannot even try and mobilize the kidney anywhere because there will be blood vessels all over. So this is the place lateral to the IVC, which will always be clean and avascular, and it will help you to go to the pedicle. So once you've gone to the pedicle and caught hold of the pedicle, then the rest of the job actually becomes a lot easier to do. So I tend not to go to the remaining part of the kidney any time until I have actually got control of the pedicle. So that helps us to deal with large renal tumors as well.
Can we go back?
No,
Yeah.
shall we go to Guinil, or this is what we are?
Yeah, sure, sir. Artery.
So in the interest, because there are also postgraduates here, so in the interest of, I don't think this was discussed today. Dr. Gopal, how frequently would you use, scoring systems? Would you use it always? Would you use it never, sometimes? And document it in your, in case records, case sheets?
Yeah, the scoring system is useful for documentation, but to be very honest, it only tells you the difficulty of doing a partial. It never tells you whether a partial is impossible or not, because as you can see, Dr. Ginnell on the other side, he is attempting a tumor which would have a very high score, but at the end of the day, if he is able to do it, it means he has done it. The nephrometry score doesn't tell you whether it is impossible or not, it only tells you the degree of difficulty.
So would you use it in your usual practice?
Well, yes, we do use it in our practice, we make a documentation of it. But as I said, it only helps you as a matter of documentation, it doesn't ever tell you whether you would be able to do a partial or not. It's only at the end of the day when the surgery gets complete that you decide, yes, oh yes, I was able to do it.
Can we
Do you agree with,
sorry.
do you agree with that, or what is the utility of scoring system in your?
No, I completely agree. I think it's more prognostic than predictive.
Can we go to Dr. Ginnell's theatre, please? Because we'll be cutting off in 8 minutes. Ginnell, can you hear us?
Yeah, we have regular laparoscopic plans and just give me. Okay. Give me some space. Okay. Once more what happened? Give me another 5 mm input. What happened? Atomic clear. It's already sir. Not used to that.
Can you apply them with?
I think I can apply.
Can you? Because they might rotate in your arm. No? Okay, that's good.
I'm used to scanning, so let's see. Yeah, what do you want to? Will you be able to apply with the
Yes, sir. I'm okay with that.
I will be with you, so.
Please.
What happened?
Like this I will be inside, right, sir?
No, actually I will take two statistics like other one on it. We can separate. That is what I. Look, two statistics separate like we look. Yeah.
Ginnell, we will be disconnecting in about 5 minutes. Can you just tell us what you are planning to clamp and how you are going to approach this?
So I'll be clamping the lock, then there will be a picture about this one, or
You won't clamp the renal vein?
I won't clamp the renal vein because that may cause more bleeding often.
Okay. Are you planning to just use one clamp or more than one?
I used to clamp with 2 clamps usually. Not happy for this clamp. Do you have one more clamp actually? So I will put this clamp, second clamp you get ready on that. Okay.
And for approaching the tumor that are in the hilum, would you go medial to lateral or inferior, superior, or which way for this one?
Which one?
For the approaching the tumor excision, Because you have dissected a bit.
I will actually start at the most prominent area where I am sure about the tumor margin. Then I trace the tumor and go around. Like, which is the easiest area, I just start there. In this case, it would be the lower pole calls to island. Then I just make a plane and then go. Can you apply it from outside? Yeah. Okay. I'm not used to this stuff, that's very good. Yes, it's good. No, actually, I'll keep it here. 1 second. I'm used to applying stuff also. 1 second, I'll show you. Little, because we are not used to, no? Because he is more used to that. Yeah. Are you comfortable? Down. Okay, yeah. There is something which is. One second, let me just.
Okay. Ginil, we are watching you, but we are going to have a talk from Dr. Mallikarjun about laparoscopic partial. Okay. So can we go online?
Just take it.
I think Mallikarjun sir is there. Hello sir, good afternoon.
Good afternoon, good morning for me. Very early morning.
You had that morning session with the AEA. Yes.
I just heard that it was all international speakers. Speaker from international site talking, basically.
We have got Dr. Ginil showing us a very difficult robotic partial and Dr. Gopal Krishna doing a laparoscopic partial.
I was just wondering, you will wait my lecture for a little more time so that I can watch. I was watching it across. But anyway, doesn't matter.
We can start, sir.
We can start with your lecture,
Okay,
sir.
thank you.
Yeah.
Thank you. I think, thank you, SOGOCON, for this opportunity. Basically, I'm asked to talk about a seminal surgery on a laparoscopic partial nephrectomy. I can understand there's a beautiful surgeries of 2 laparoscopic partial nephrectomies, 1 lap and 1 robotic happening at that point of time. I think I just add some more few points which possibly may not discussed sometimes in every case at this
So
point.
your slides are not just showing up. They're just trying to format.
Not show?
Your slides are not showing up yet.
Okay.
They're just
Slide
trying to
screen?
change the screens.
Okay.
Yeah, now we are able to.
Now we can see.
I'll let you know the moment we can see them as a full screen, sir.
There, are you able to see me?
We can see you, but not as the full screen.
Okay. I'll wait. It's me. For me, it is a full screen. I think the adjustment has to be done at that point.
Yeah, they are doing it here. That's better.
Got it?
Are we? Okay, yes, sir. Make that bigger.
Okay. Okay, laparoscopic partial nephrectomy. I think radical versus partial, I think this has been a discussed thing at the time. Partial, whenever it is feasible, it's gone up to T2 tumors, like what Ginil is showing, one of the rare indicators of a partial. But anyway, the thing is happening is radical only when partial is not feasible. Then is trying to adjust for the technological and conceptual change and the demand for minimally invasive surgery. So knowing laparoscopic or robotic partial nephrectomy has become mandatory. Gone are those days when we can say that we can get away with the open partial nephrectomy any further. Location versus difficulty in the approach. There was a lot of discussion initially. Anteriorly placed lower polar phase tumors can be managed very well with with transperitoneal, and the posteriorly placed done things to have to be done in a retroperitoneal approach because they are quite challenging for transperitoneal approach. But I disagree with it. It's not necessarily so, because mobilizing and flipping of the kidney accordingly will ease up whether it is posterior or anterior tumors. Anterior tumors are easier in a transperitoneal, but posterior tumors also can manage by mobilizing the kidney and flipping the kidney or rotating the kidney across the ventricle and able to see the posterior surface very well. So I don't think there is a much difference between the way we approach for the anterior or a posterior tumor. The only relevant thing of all the scoring pictures, which I would say the only thing which makes it very, very difficult is going to be the having a sticky fat around the kidney and the amount of fat around the kidney. And possibly this is only one indication, at least in my personal bias, I would say, which one will say, shall I attempt laparoscopically? With the more the fat, I don't really wish to go robotically, which takes longer time to manage. That's the reason why if there is a lot of fat, especially in the case which is seen on the right side, I would definitely think about doing laparoscopically in this patient. Somehow it is easy to manage the sticky fat in laparoscopy rather than robotic. It's my personal feeling. It's nothing specific for that. What is more important here is a no compromise approach. At any point of time, if you have a difficulty, you have to have additional ports. Don't even try to compromise and try to do something without these additional ports, which makes the surgery more complicated and more difficult. It is not worth doing that sort of surgery, which is going to be more difficult, especially in a case where like partial nephrectomy, wherein your ischemia time is going to increase and the actual results, what you are expected to do, are not being delivered. There is a small difference the way we approach robotic versus laparoscopy. Majority of the times in robotic surgery, it's a blood dissection next to the pseudocapsule, leading to some element of enuclear resection, which is more often seen in robotic surgery, whereas in a laparoscopy, it's more of a wedge resection because staying back into that enuclear resection plane may be difficult in some tumors, not necessarily. I have seen people who have started their laparoscopic surgery do a wedge resection more often, and people who have been experienced in laparoscopic surgery have been doing this enuclear resection more often in these patients. So the well encapsulated, go for a nuclear resection. Ill-defined tumor on imaging, go for a wedge resection. I'll give you both the examples of this. Vasculature and suturing. Most of the time we give a lot of relevance to these vessels which are there to the cortex, which doesn't require any attention. So if you look at a tumor like this is a sinus part, which is the pelvic system which is seen, but if you have the real vessels which are going to be seen on red, or at the medullary cortical junction, or in the medulla itself, not or next to the calyx, but not these vessels which are there inside the cortex of the kidney. These are hardly going to be different. So what makes it is more important is these two vessels, or this vessel or interlobar vessel which is going to be there, which is interlobular vessel. So these are the vessels which need to be looked into in detail whenever you plan to do a rhinorrhaphy or control of hemostasis. The second thing in a rhinorrhaphy which I would always say is, if you are looking at a two-layered sutures, the inner part will take care of the medulla and the outer part will take care of the cortex, and take as little cortex as possible, so even this part of the cortex can be ischemic. If you are not able to take, or they are not thinking of taking a inner medullary layer, think about taking it completely in a single go, or taking the whole medulla and cortex completely. In fact, taking a little part of the medulla along with the cortex will give a stability to this always suturing. Only plain cortex suturing is of no use. It gets cut through, and majority of times it fails. Second thing, we need to use a hemolock, whether then we can manage with a single run suture. Yeah, you can manage, but still a tangential transmission is not better when compared to a perpendicular transmission of force. If a hemolock here, there is a perpendicular transmission of the force across the suture. That's the basic reason why at least hemolock is applied in some areas. They apply on both sides, in some places they apply only on one side. At least I'll apply it on one side. That's how it is usually done. closure in layers. The two cat doing a closure in layers don't have zigzag closure. Possibly this may not be relevant if you use a barbed suture on all the cases, but anyway, my feeling is if you have a suture, let it be both are parallel, both inner layer and outer layer be parallel to each other. That will give you a better form of the hemostasis. In barbed sutures, sometimes we can get away without with the both axes of the suture lines may not be the same area. I look at this is a sinus first approach. This is a classical thing what we required to do whenever we thought doing a nuclear resection, but the other one is going to be doing right up to the sinus, especially in patients who don't have a well-defined capsule, so that you don't need to get into the tumor and independently take care of the vessels and then do a renal. For example, this case which I want to show, which doesn't have a pseudocapsule. The advantage of sinus first approach is you don't get into the tumor and you might go directly into the sinus, so you are assured of the margins. This tumor which doesn't have any specified margin, in which case what will you do? You'll end up in isolating and having a vascular control with Satinsky or a bulldog, and then go directly. You excise, get into the suture, just cutting into the cortex and just trying to reach right up to the sinus. Right up to the sinus is identified by having some fat seam which gets exposed the moment you enter the sinus. See that's fat which is made. That means you have reached the area which beyond which the tumor doesn't exist. So that you can readjust your scissors and excise the rest of the tumor and along with the tumor. So sinus first approach most of the time is good in the initial part of your laparoscopy when your ability to move your scissors and move your instruments it's not going to be perfect. And there's a very little nuclear resection. You can see the tumor margin at some places, but majority of the times the tumor is covered by a large chunk of kidney parenchyma. There's a significant loss of nephrons, but we are sure we are getting into the tumor at any point in time. So that's a sinus first approach. But the advantage of it is going to be that's a sinus fat and some tumor surface seen. The advantage of it, the majority of the bleed happens next to the sinus. You see this, all the results, or if there is a calyx which is always next to the sinus. So independent to 2 or 3 sutures which are placed, figurative sutures placed next to the sinus will take care of the majority of the bleeding. And that is going to be adequate. In fact, the second layer of suturing might not be necessary in these patients. So sinus first approach is for all these ill-defined tumors which doesn't have a specified pseudocapsule around it. Rest of the tumors can be managed with a fair nuclear resection. This is an index case of a cystic and solid mass on the medial aspect of the hilum below the hilum. One of the most difficult areas is just next to the hilum in the lower part of the just next to the hilum in inferior margin or superior margin. I would say inferior margin because pelvic system also comes into this place, whereas superior margin it's not a big deal because only vessels come into the place. So. And second thing which I always say, when there is a cystic component, there is always a sticky fat onto the tumor which is attached. So getting onto the surface of the tumor perfectly well onto the surface of the kidney might not be possible. Let us see that what has happened in this patient. This is a live video of around 10 minutes which will explain the whole thing. So this is the control of the vessel. A loop around in an initial stage of life is always better. I still make it a rule in majority of the cases. If I cannot do it, then I can avoid it, but it is always better. Control onto the artery only. I don't wish to have a control on the vein, especially when there is a hilar tumors, because I want the distance of the vein. I made an incision next after an ultrasound guidance, next where the edge of the tumor is there, and try to elevate the kidney margin. I don't do a specified scoring of all around the tumor because I feel that I can grade it as time passes by and I can start doing it as the time passes by. Second, never hold the kidney tissue. So you see that the capsule is getting away from the kidney tissue, especially in this sort of a cases. So your left hand will use itself as retraction of both the edges. Try to get onto the plane next to the capsule. You are able to see, I see the plane. You can see the capsule which is getting elevated. There is a sticky fat on the tumor which with great difficulty I left some fat onto the tumor. It's a very odd position of inferior and which posteriorly placed. See that the vein which got involved and I opened the vein which shows a small tumor projecting into the veins. I could see that here. I'll get back again after a little part of a mobilization. You see that sticky fat around, and it doesn't separate the way it should be around, and you can see the small vessel which is in that part of the kidney, so we can carefully take care of it and gently clip it off and then start ahead with it. So this is a perihilar fat or a perirenal fat only. That's a small vessel which is growing to that area from the hilum. So I take it out. So I created a plane across on some part of the tumor which is stuck to the pelvis. This is the easiest way to get it, because majority of the times it never erodes the pelvis. It is unlikely, haven't seen any time. It erodes into the catheter sometimes, but not into the pelvis. So you can see this which is there. I kept ureteric catheter especially in this case because the pelvis was clearly stuck to the tumor in the image at present. So that is the medial aspect of the tumor which is being enucleated, which is enucleated. At present we have not in the kidney parenchyma except on the superior margin. The rest of the thing it is sinus fat, so it is easily being enucleated away from the sinus fats. This is that exposure into the vein, and this is a vein which is bleeding here. That's the advantage of not clipping the vein, especially in tumors like this. You will see that we get a bleed which identifies the vein clearly. So that's a pelvic wall which is stuck there, and the calyceal wall which is being almost getting infiltrated by the tumor. So I'm trying to excise that calyceal wall along with the tumor. So that's a hilum which got completely, sinus part which got completely exposed. So part of the tumor medial aspect and the superior aspect which is separated. And what you require here is a blood dissection. You hardly see the tumors filtrating into the fat, especially when they are defined very well. So you need to make a decision what sort of surgery you do depending upon imaging and the way the tumor looks like and how it looks like. Avoid holding the tumor at any point of even the fat across the tumor, you will not hold it properly. So try to give a retraction rather than holding the tumor with any of the forceps. So I'm creating a plane next to it, and that is almost a nuclear resection which has completed. You can see the surface of the tumor very clearly, and the capsule which is getting divided. So now after being dividing, have a complete look of the surface of the tumor, and now the renorrhea part has to be planned. Whenever we say the renorrhea is always, you cannot have inner renorrhea like thing here. So the tumor, the most of the blood vessels are going to be next to the pelvic system or calyx which is there. So I started making a suture all along the medulla, next to the pelvis. So you see these multiple vessels which are there, which you get sutured and with a continuous suture. With a 3-arrow V-lock which is being done. There is a ureteric catheter which is placed temporarily during the surgery to protect the pelvis, identify and protect the pelvis, which is taken out immediately after the surgery is over. I don't wish to keep it at any point of time because reflux in the postoperative period is one of the reasons for urinary leaks in these patients. And then that is a suture which is being placed, which is gone on the posterior aspect of the pelvis, now coming towards the anterior aspect of the pelvis. And that is a closure, and I take that medulla. See that medullary part which takes, this is actual, I would say this is the thing that really matters regarding the hemostasis is concerned. So take the medulla and the pelvic and medulla and the tissue next to the medulla. You don't need to take a deep bite, you need to take a fairly decent bite which takes care of the vessels which are coming out in that area. You know that there is a vein which is opened here, which is having that projection of the tumor inside, which was in the surface of the tumor. So I need to be careful and close that vein also. Advantage of not having venous clamp in this sort of the patients is to see the back bleed of the vein, which we will never be able to see if the vein is clamped. So whenever you are suspecting, whenever going into the hilum, you better not have a clamp. That's my routine all these days, and that is a small bite around that vein. See that you are going through the pelvis. You just take the peri tissue, one, and the next bite will take care of the vein. So there completes the renorrhea, I would say. That takes care of the vessels which have been coming into the vein, coming to the artery. I've made a clip of the small artery which is coming into the tumor, and this is a vein which is opening into the tumor. Both have been taken care of. So now comes is going to be outer renorrhea. Take the bite near to the hilum, but not very close to the hilum. Because I try to tell you, if you take deep bite here, the very likely chance that the major vessels underneath in the hilum may be taken. So whenever you drive the needle across, it should be more into the cortex, and when it comes to the mid, a part of the medulla only has to be taken, so that the deeper vessels are not taken care of. So the edge of the other side has to be taken. Most of the time, the anterior edge is going to be very evidently seen superiorly, but the posterior edge is receded backwards, so be careful that you are taking it. And at this point of time, having the first suture be done towards the hilum, because if you start from above or downwards, at the time of hilum, you may not be able to see what exactly you are taking. So take the suture when the visibility at the hilum, when the visibility is very clearly seen. Manipulating the needle inside is going to be of difficulty, especially in laparoscopy now, because you hold the needle and turn the needle in such a fashion that you are able to see the inner part of it very well. So having done this, you will be able to reconstruct the hilum. Number one. Number two, you should be able to take only the cortex, possibly a millimeter of the medulla, to give the strength to the suture is most of the time taken, but the actual medullary suturing has happened in the previous layer itself, and holding and trying to get needle exactly in this and taking the cortex completely is going to be a little difficulty, especially in the right lower polar tumor for a right-hander, and the similar thing for a left-hander and the left lower polar tumors. So having done this, with this completely sutured, I will put Imolox on one side, which will be, as I said, there is a perpendicular compression rather than a tangent compression which happens. And now open the clamp, you just take out the bulldog. I usually put only one bulldog, that's been taken away, and now you can see that the hemostasis is perfect. We take the same suture to the perinephric fat so that it doesn't wobble. Anyway, so this kidney has never been mobilized completely, so it is stuck in the upper, so the question of valvular or the rotation of the kidney doesn't happen. Thank you so much.
Thank you very much, sir. Thank you very much.
Thank you very much, sir. I think it was a wonderful exposition and demonstration of two difficult cases and techniques to counter that. Before we go on, can we go to the Ginil for a minute? Yes. Before we go on to the next speaker, Dr. Ashutosh Tiwari, can you just go to Dr. Ginil's theater, and Dr. Ginil, could you just tell us what is it that you're doing right now? Where are you?
Hello. Can you see what? Hello?
Yes, we can hear you.
Yeah, so I can see that I'm reasonably through. They have to be what is the time taken to now? Okay, God.
Do we have Dr. Tiwari online? Can we go to Dr. Gopal Krishna's theater, please?
Yeah, hello, can you hear me?
Yes, sir, we can.
Okay, so we got the artery at the upper border of the renal vein, not from below. So I'll show you in a minute. Here is the renal vein. So we searched all below and we could not see anything here. So then we went above the renal vein, and there is the renal artery there.
Yeah.
There is the renal artery.
Okay.
Before it's branching. So now that we've done that, now we have proceeded to mobilize the kidney all round. The tumor is here, but if you can see, there's a lot of edematous tissue. The perinephric fat in the lower pole is extremely edematous, and I was cutting it, there was sort of water being liberated. So this desmoplastic reaction here around the tumor, as you can see here. This is the ureter and the gonadal next to it. That's here. So now we are in the process of flipping kidney down, but this tissue, I don't do this. It's a lot of blubbery tissue, this perinephric fat all around this lower pole. The upper pole is fine. In fact, in the lower pole here, it was sort of getting into the muscle as well here. So there was a little bleed there from the muscle, so that we've taken out. Now we are mobilizing the kidney all around. We have detached it from the adrenal, and we are now going to what is known as double flip, that is to flip the kidney above, below, and sideways as well. So after that, we will be in a better position to look at the tumor and then decide what to do about it. Since the tumor is going well inside the hilum, I have told them about the prospect for nephrectomy if required, although the tumor doesn't look very big, but these appearances are slightly sinister. I don't know whether desmoplastic reaction is a good sign, this edema is a good sign or a bad sign. Picha. Camera clean. So we'll keep mobilizing the kidney, and then once we are complete, then we'll administer mannitol, although I don't know what's the utility of giving mannitol in warm ischemia. This is all warm ischemia. So anyway, we do give mannitol as a custom, and then we will proceed to enucleate the tumor and see what happens. So this is mainly going to be nuclear resection.
Thank you very much. Dr. Ginil has excised the mass and he is trying to do the remoraphy. So we'll go across. Ginil, can you just tell us what you plan to do? Then we'll
remoraphy, I just do all the vessels, because I don't believe in the second lung alone, second housing, because we have to see that the inside is completely the blood vessels are packed, there can be large blood vessels. So what I will do is I will just, since the vein is unclamped, I am not very much worried about the free radical injury. I will just in between, I will just stop and see if there is any bleeders. Then I will confirm there is no major bleeding, because I feel that bleeding after septic, if at all I am going to put, will be difficult to manage. So I want multiple sutures. You can just read the thing that has got a midline to it. Yeah.
Is that just a 3-0 monochrome suture or is it a Stratafix? Bob suture?
Yeah, Stratafix actually. I usually follow peel out. Yeah, give me the next one. One is also okay. On that, which this one? Okay, yeah. That also can be taken. Section just showing here. Let's try showing here.
That's a very please. I'll just close it and just butterfly on that. This one we will keep. Just address you can just cut it so that you. I'm not expecting only one ball is gone.
So we are going to have a video from Dr. Nikhil Vasde about continence improving maneuvers in RARP.
Section here. Multiple times this happening when you are pushing the LM button, it's coming onto my camera. So, can we? Yeah, just let me. Yeah, please. You come close to abdomen wall and then come inside. Okay. Yeah, next the camera is again now. I'm losing time because of that. Because when
He's trying to close the paper.
clean the camera fast.
Ginil, we'll come back to you. We're watching you. Yeah? Thank you. We just got a talk for 15 minutes.
Well, thank you very much, ladies and gentlemen. Good afternoon.
Just the hub so that
it's a great pleasure to be invited by Dr. Ghosh and the organizing team at SOGOCon being hosted in Calcutta. Unfortunately, I cannot be there in person, but it's a real honor to present to you a talk today on continence improving maneuvers during a robotic radical prostatectomy. What I'll be sharing with you is some of the tips and tricks that we do in our center at the Lister Hospital in Stevenage, which is the 4th highest volume center for robotic prostatectomy in the UK, and also what we've done with our data and our audits to really get it improved. I won't say get it completely perfectionized because there's so much which is ongoing with research and data, but I hopefully by the end of this talk over the next 15 minutes will be able to showcase to you some of the very latest developments and research plus our data that we've just published 3 weeks ago in the long-term NeuroSafe Lister technique in the BJUI, looking at oncological follow-up too, so a fairly comprehensive series. And this really pushes us to look at our outcomes. You can see when a patient is looking for a provider, say for robotic prostatectomy, they want to look at the data quality, what we do, and certainly with presentation, because as you're aware, a lot of patients now do see radiation oncologists, and the option of having a 5-day treatment with SABR seems to be fairly attractive. But still, our robotic prostatectomy is going from strength to strength. In our center, we do anywhere between 10 to 15 robotic prostates a week between 4 consultants. The submission for the National Prostate Cancer Audit, once it's submitted, really looks more importantly now at something called outcomes. So, we're looking at outcomes of continence, sexual dysfunction, genitourinary toxicity. So this is all in the public domain, so it's very interesting to see how patients choose what they tend to choose as far as surgery is concerned when they want to come to a high volume unit. So we completed 2,500 robotic prostates about 2 months ago, and I did the 2,500 case, so that's Justin Daniels, my medical director, who obviously was able to be there to celebrate this achievement of hitting this number in sort of 1.5 years of service, and there was a lot of rejoice, but I think the real rejoice comes from data presentation and outcomes, because we publish regularly. This was a paper that we published on patients who had nerve-sparing robotic prostatectomy, and I'll show you a video capture of what we do in our center. But in the UK, the reason why we tend to have so many robots on expansion is very largely down to an important parameter, which is the positive surgical margin rate. So when we look at the HES data, when we look at the Health Technology Assessment Board, which comprehends and looks into seeing how the cost of robots, the NHS can be implemented in a successful manner, is really down to the fact that the need for adjuvant treatments such as radiotherapy is lessened with robotic prostatectomy. So this gives you the added edge of providing a superior service, also reducing the margin rate status for patients who are undergoing surgery. So this is a big important aspect that we look at with our data presentation, because we want to ensure that our patients do well, of course, from the continence point of view, and my topic today is on continence, but also, most importantly, from the oncological point of view, because this is looked at very closely from the health economic aspect. So some of the robotic research that I'm doing at the moment, I thought I'll showcase to you. So this is a large trial called the PAIR 2 trial that I'm leading, and I'm the chief investigator for the UK for this. It started in March 2021. This is using AI and surgical planning to look at neurosafe margin status intraoperatively. So these are the sort of pictures and demographics we get during the operation to predict when neurovascular bundle enrollment may be. So you may need not involve a pathologist, although we do tend to, and I'll show you some videos of how we tend to do my cases. A lot of low pressure surgery, so I operate at a pressure of 6, and so do the other surgeons in my unit. We believe low pressure has a strong role to play, and certainly my research at the University of Hertfordshire with ConMed Surgical led on to protocolization of a lot of the protocols we done during COVID. And with Professor Dasgupta, I'm working very closely. We just published this in the Journal of Robotic Surgery on something called mixed gas pneumoperitoneum, looking at not only carbon dioxide as a standard insufflator, but also throwing in a mix of oxygen and nitrous to probably look to reduce the acidic environment intraperitoneally, which could potentially prevent nerve necrosis or damage, and fibrosis, of course, which is a big sequelae of transabdominal surgery. So lots of excitement, lots of research, AI, low pressure, and the mix thrown in. The main aim of a patient having a robotic prostatectomy is actually to ensure that we cure them from the perspective of their cancer, to ensure that we give them continence, and I'll show you some 6-week data of our series, and obviously erectile function. I won't sort of delve in too much into the nerve-based anatomy, because on the program, of course, we have Professor Tiwari, who was talking about neurosafe, who was talking about the nerve anatomy in patients undergoing a robotic prostatectomy. So I think it's important that we really understand that certain parameters of performing techniques, such as a high nerve release during a robotic prostatectomy, as described by Walsh and Donker, a number of studies have been performed, but really, a high nerve release is important to consider in patients who are undergoing a nerve-sparing prostatectomy, because really these nerves do hug the procedural aspect of the seminal vesicles, and using athermal techniques, and I'll show you a video very shortly, to really develop a very comprehensive way of operating in which you preserve as much neurovascular bundle tissue as you can, whilst also ensuring that you attain a negative margin in patients undergoing surgery. Now, the nerve distribution around the capsule is really important to understand too, because about 30% of the nerves are found in the anterolateral aspect of the prostate, and I'll show you why I'm describing this right now before I start my video presentation off. And again, looking at the proximal aspect of where the membranous urethra and the prostate sits, you want to really ensure that these structures are not interfered with too much as far as your continence is concerned. Now, there's a lot of talk about anterior versus spare. We started this off in our unit, but it is a good technique. Certain early continence has been very promising, and it's safe to do to transit. And if you're good at it, then why not? Keep going with it. But we really haven't really taken to this like a duck to water, because our positive surgical margin rates anteriorly were high, and having a 3.2% margin rate and going up to about 35% really did knock us and draw a bit of caution. But yes, it's associated with very good superior continence outcomes in early data coming through. But again, this is something which requires a bit more long-term evaluation. Now, the listed neurosafe technique is what I'm going to describe to you, but I wanted to spend a few minutes to tell you what we tend to do when we do our nerve sparing technique. So this is bladder neck preservation. Certainly very, very cautious on the high nerve release, and I'll demonstrate that to you shortly in a video. The preservation of the maximum urethral length, and this can be done really very, very nicely looking at the pre-operative membranous urethral length, which is associated with post-operative continence and time to recovery. There's no doubt about it. Using a cold cut dorsal venous ligation and anterior versus spare, I demonstrated this in Lucknow a couple of weeks ago when I was operating at the SGPGI, and certainly doing our nerve sparing analysis of the specimen live during surgery, and most importantly also looking to see the Rocco stitch that we tend to use. So this is a patient of mine who's 45. He's obviously come across to have a robotic prostatectomy with me. I use the anterior approach, so I don't tend to sort of divide the urachus, and I use minimally just the vas deferens just being divided. I'll just hurry this video along for the sake of time. So the vas on the right side is being divided, and I just sort of developed the spleen. The anterior prostatic fat is now being cleared out. As you're aware, that this is sent across separately for histological analysis and is a separate sort of prognostic marker from the perspective of when the margins stay slow. And I'm operating the pressure of 6, so we do tend to see a little bit of more ooze in patients who have low pressure surgery. And this is not an edited video. This is the speed of operating. The time is exactly what my hands are moving at with a scaling of 1 to 3 during the operation. The next step that I'll work towards is developing the bladder neck preservation. Obviously, you can do this whether you do the posterior approach or anterior approach. I feel that the anterior approach is slightly more friendly to develop a nice plane. My cautery settings on the XI console are at 3 whilst operating. I slowly develop this plane. This is the space of Ramin being created laterally with slow movements. And sort of now I'm probably going to work towards a bit more athermal dissection. On my fellows, we have 2 Royal College of Surgeons of England fellows who work with us. So during this time, we actually take the diathermy cables off when we're training our fellows to work towards the establishment of a fellowship program. I think an important good move at this stage is to use a suture. Once the posterior bladder neck has been dissected, I get onto the tip of the SVs at the back, and very gently using an athermal dissection plane, I will be in a position to peel the neurovascular bundle off, and you can see very minimal traction, a little bit of hydrodissection, just moving and peeling tissue off. And this patient's got T3A disease on the left side, so we just sort of moving that forward. Now the DVC has been divided, cold, and I'm just sort of oversewing with DVC. Now this is the specimen which has been removed intraoperatively, evaluating the margin analysis on the left and the right. So the right is painted with the red paint, and the left is painted with blue. And this specimen is sent off to the pathologist. So in an average day, we will do 2 neurosafes, so we'll do 3 wide local excisions on our operating list. Because this takes about 20-30 30 minutes longer with the cryostat and the analysis which takes place. So specimen's painted and is sent down to pathology. Whilst waiting, we will do the lymph node dissection for patients. And I think, a big game changer in certainly my practice has been the Rocco suture, so slightly modified technique of picking up the posterior genital fascia and using a V-lock. So this is a 3 or V-lock suture that's being used. And you can see that, I do use some snow on the level of the neurovascular bundles because there's no few clips which I might do a cystogram. So this is suture on the right. Again, reinforcing the posterior layer of the urethra. We'll do a small anterior tennis racket because I don't want to parachute the whole thing down and have a bit of a mismatch despite the bladder neck preservation which has taken place, because and I'll show you exactly why I do what I do with the procedure. So by this time on the communication systems in theatre, the pathologist is sort of feeding back to us on the status of the nerve bundle analysis that we have sent down. So, the left and the right margin, etc., being analyzed. And I think the V-lock's a very, very good suture to pull right down, reinforce the strength of your anastomosis. Clearly, you don't want to make it too ischemic. Per se, sometimes with big median lobes, I will also put some robotic stents in JJ stents in, because you can still preserve the bladder neck very nicely with the median lobe. But what ends up happening is that you end up being quite close to the ureteric orifices sometimes. So this is a crossover suture which is done backhand one anterior tennis racket, and you can see putting this across very gently to lock the upper part of the anastomosis. And by this time, I've got a clearance, and obviously the erectile function comes back pretty quickly too, at about 8 weeks to 12 weeks with the aid of a PDE5 inhibitor and a vacuum device. So we have a PVAL rehab program. So thanks very much for the opportunity to present. I will close my talk, and I hope your conference goes well, and I'm very grateful to Dr. Ghosh and the organizing team for the invitation. Thanks very much.
Nikhil, it's Sanjay Egla here. Hope you are doing well. Can you hear me? He's not on. Sorry, it was a video.
Hi, Dr. Adler. Are you talking to me?
Sorry, who is on?
Hello, are you talking to me?
No, sir.
Okay.
No, okay, we can ask you the question because you are more intelligent than me. Dr. Nikhil Vasdev was saying that he operates at 6 centimeters of 6 mm of HG intra-abdominal. What would be a reason for that, for doing a prostate?
No, I didn't get you there.
No issue, sir. You go ahead with your operation. I just had a question for him. So as I wasn't there, I was planning to ask you.
Okay.
Can you explain what you are doing?
Well, we have mobilized tumor all around, and if you saw CT scan, it seemed to be abutting of the renal pelvis. So here we have gone into the sinus here and have got the renal pelvis out of the way. There's the ureter and there's the renal pelvis from which we have taken it out. So there seems to be some normal parenchyma here. This is the tumor margin which is coming up to this point, and we've gone all around it here. Come down. As I told you, this tissue around it very edematous. I don't know the reason for it. Now, and here we have got the pedicle as well, which we are going to clamp in a moment before we see if we are able to take it off as a partial. And we have completely flipped the kidney all around, both above and below. So it is basically hanging from the pedicle. There it is. The renal artery was above the vein.
Okay.
We've disconnected it from the adrenal gland as well. So that's what constitutes the flip for younger surgeons. So now we are going to put 2 clamps on the renal artery. And then guarding the vein, we'll see how it goes. And then take it from, yeah, clamp please.
Sanjay, comment to the 6 millimeters of mercury. If you reduce the pneumo, the bowel ischemia would be relatively less. Sorry? Bowel ischemia will be relatively less, so recovery of bowel function would be faster.
No, I understand that for a cystectomy, but for a prostate or a partial.
No, Alex Motre for partial nephrectomy, he does at 6 millimeters of mercury. So this is the reason given by experts.
Okay.
नीचे बसा आइटो घोड़ा हाँ क्या आइटो चिका कर आइटो चौड़ा कर बड़ा कर एक्शन में सब टिश्यू को नहीं है हाँ बसा हाँ गुड
Gopal Krishna sir, we'll just watch you. It's already a pressure-filled situation. You don't need to talk to us. We'll just watch you.
Okay. Moment of truth.
Thank you. Ginil? Can we connect to Ginil?
Yeah, go on, sir.
Hello. Ginil, can you tell us what you did? And are you happy with what you have done?
First I ask you, are you happy? The pelvic system, I just want to recheck. What I do is I'll just put a butterfly, put some methylene blue after puncturing that. If there is something is there, I'll just
So I said I was very happy, but Raval sir saying he is not happy with it.
He is not happy.
No. It was an extremely difficult one. The closure was a bit more difficult just because you are right on the hilum.
Yeah. I just, whatever calyx were off and I separately closed because I will not be able to approximate that the paradigm over that. So I'm not attempting to because it will be some area.
Just for us, can you put ICG just for us to see which part of the kidney lights up, if you have?
You want to assess the vascularity or?
Yeah, vascularity, and probably you can see any leakage as well, isn't it?
Okay. Yeah, can I just put some ICG and see? Just a flush here and see if there is any ocean. One more laser. ICG, the dilution was done. Usually terminal dilution then 6, that is what. Okay, yeah, we'll remove it later. Just given.
It looks like old Bollywood movie.
Khurshid, can you hear us?
Good morning.
Good morning, good morning. Good evening from here. Khurshid, we can't see you.
Let me see
start
if
the
I
video.
can.
Yes.
Let me see.
See.
Okay, let me see.
Yes, we can see you. I'm going to hand it over to Dr. Sanjay Adla, who's going to coordinate this session for you.
Good evening, sir. Good morning to you. I'm Dr. Sanjay Adla, working in India. We are eagerly waiting to learn the tips and tricks of robotic radical cystectomy. We have seen one being done by Indian-made robo in the morning, so we would like to see how experts do it as well, sir.
Well, thank you for the invitation, and what I was invited to show was a neobladder intracorporeal.
Yes, sir.
So, because I think the cystectomy was shown in the morning.
Yes.
So I will try to present, and I know this is a very nice case going on, so for the sake of
everybody else. Thank you so much for the invitation, Amit. I really, really appreciate it. I am trying to see if I can also share my screen so that, let me see if, do you guys see anything or no?
We can only see you, so we can't see your video.
Let me see for a second. I am trying to basically make sure that Microsoft Teams, okay, hold on, desktop. Well, it's just we don't use a lot of Zoom. We use some other technology, so I'm trying to figure this out. Do you see any of my video?
No, we don't. But are they able to see? Are they able to see?
Are you able to see there?
Any of the screen?
Where is Abhishek? Abhishek, please coordinate this. Dr. Guru is trying to...
If you want to go back to your video and let me coordinate this with Abhishek. Do you see me? Your screen?
We can see you, yes. We can see you. There is a blank screen there, yeah.
Okay, perfect. Okay, all right. Well, Amit, thank you for the invitation. I'm going to try to play this and see if we can. It looks like, can you see anything?
Yes. Now we can.
Okay, perfect. So this is the right time where basically the cystectomy and lymph node dissection has been performed, and I use something which is very simple. We use the catheter to basically hold the right spot for the bowel, and once that bowel is held for a neobladder, because I do the W neobladder, I do use the Peter Wickland technique or studio modified technique of first hooking the urethra, because I permanently don't like to hook it, and if you see, I make a temporary kind of connection to the Foley and create the W configuration. And once you create the W configuration, you also put these little tagging stitches, which kind of are silk stitches, and you kind of hold your bowel in place. Once your bowel is held in place, technically you have two troughs, right trough, left trough, and they are these kind of ends which you basically just open the right side of the bowel, and you can see this in the image here. There is a right side of the bowel which basically has been opened, right limb and a portion of the middle limb, and then these two are joined to form the trough. And you can see I don't open the left side. Why? Because this gets confusing for people who are just doing it. So if you open these separately, one at a time, and you can see here, once the two troughs have been opened, and this is now the left trough. And I have already created the right trough, and I'm creating the left trough. It is very simple technique. The only thing is it's obviously tedious to suture because it's in your bladder. And you can see here, once the two troughs in the right and left have been created, we join them in the middle, which is the central trough. And if you see central trough, I am sutured from top down versus from bottom up. And once that is sutured, you reach the bottom. This is how the neobladder should look like. And at this point, you focus on the anastomosis. The key here is also, if you remember, we had attached the neobladder to the Foley, and that little traction of the Foley suture is basically helping you keep the neobladder in place and not falling back into the abdomen. So you can see here, the posterior plate is created with a V-lock suture, and you nicely create the posterior plate, a running suture and anastomosis. Sometimes you have to give some interrupted sutures, but V-lock really works very well. And you can almost run a continuous suture around nicely, and that becomes your traction suture or holding suture. And Foley catheter is just help to guide. I do almost 1/3 of this running up the bowel anteriorly, and then I stop. At this point, I basically cut the bowel ends and disconnect kind of GI continuity because I don't want stool to be sitting there, so I leave the GI continuity till the end. And once the limbs are identified, I don't transfer the left ureter to the right side. I basically bring them down straight. You can see this is a spatulation with the clip held there. And once that spatulation has happened, I take the staple line off that distal end, which I'm suturing right now, and basically connect it to the ureter. So you can see this is connected to the ureter, very straightforward anastomosis. When I developed this kind of modification to the W neobladder, I kept in mind that you want to make it simple. The more complicated you make it, the less reproducible the technique gets. And when it's less reproducible, and if I'm the only guy doing it, it's a problem. So it's easily reproducible. Here we bring a wide hematuria catheter and a stent through there and pass it along the limb into the ureter. Now, this video is about a year and a half back, and I don't anymore leave any stents. I have 0 stents in the neobladder or in the conduit. We stopped doing this because the stricture is kind of lowered. So you can see, if you can see well and you can do nice anastomosis without any edema, it works out fairly simply well. And then you see in this case, if you want to put the stents, you leave the stents a little longer and do single J stents and tie them to the Foley catheter so that you don't even have cysto the patient when you're doing this. Once you have done both the ureters, you close this neobladder in something called as a kind of a cigarette box configuration. This I had learned from Professor Ghanem's and Abulanim group when I was a fellow there in 2002. And this you can see here, this configuration helps reduce that kind of pressure, low pressure and high volume neobladder. And we see this regularly in our urodynamic studies that this works out very, very well. And here you can see this is connected. If you remember anteriorly, I had closed this reverse Mercedes sign and the upper part of it, and now just attach this to it, and it kind of creates the neobladder. A lot of people think this is a 7-minute video, but if you look at it carefully, you kind of pay attention to detail, it is a very simplified method versus other methods which have been described in the literature. It kind of clearly leaves the bowel in the right space and the ureter in the right place. After you have done that, then you pay attention. I still put a suprapubic port. Why? Because I like the Pantaleon technique, which kind of I have always appreciated, because the bowel comes in straight into the stapler, so you don't have any injury to bowel or you don't have to stretch it. And the transfer 60 size comes across, and you kind of get bowel done. Once that is done, you want to make sure that there is a omental gap between the bowel anastomosis and the neobladder. Why? Because bowel anastomosis has staples that can get stuck to your V-lock and you could have fistulization. So you nicely bring the omentum, and that basically is it. So I kind of wanted to show a quick, Amit wanted me to show something sweet and something simple. Here it is. I leave it for next 2 to 3 minutes for questions. I was given 10 minutes. I hope I stay in time.
Thank you, Khurshid. This is exactly what we wanted. Short, sweet, and you see from the applause, this is the great applause for the last 5 hours that we've noticed. It's fantastic. This is exactly what we wanted. We'll open the house to any questions. Sudhir Rawal wants to ask you a question.
Well, Professor Rawal, I'm honored. Sudhir is a mentor, a friend. So, he asked me a question. I have to stand up now. No, Sudhir, Baisab, good to see you firstly. But the thing is, as you know, I trained with Professor Ghanem and then Hassan, and then worked with Professor Hartman to mentor me. So I really focused on this. My biggest problem with student was the folding. Robotically, the folding configuration never works out, and this has been verified even by student, which Peter kind of argues back and forth that that is not true. And I have seen a bunch of patients in follow-up long-term where you have an hourglass stenosis kind of if you don't fold it right. And sometimes in bulky patients, it's very difficult to fold it, Sudhir. So that is why kind of people don't appreciate it. And I have always been a believer, even in my technique of spaces for cystectomy, if you don't have the technique simple and you are the only one doing it, you have a problem because it should be reproducible. Yes. Dr. I have done this, but I'll tell you, the only master of anti-reflux obviously is Hassan, and he has done a great job with it. But scientific papers have not panned out that what is the advantage of it versus the stricture issue. As you know very well, the stricture issue is a big, you've been doing this for a long time. Stricture issue is a big issue. In fact, that is the reason I abandoned the stents. That irritation of urine as well as a foreign body is what causes the strictures. And I'll tell you, we just published our data on conduits. Despite our technique being very meticulous and very, very fine, we had strictures, and now our stricture rate has dropped dramatically. And I'm willing to live with a leak, but I'm not willing to live with a smaller leak, sorry. I'm not willing to live with strictures which happen often. जी भाई साहब, it's my pleasure. If I knew Amit was going to tell me कि आपका दीदार होगा, तो I would have shown up myself in Kolkata.
We all depend on Sudhi to give us the passport for invitations.
ये कभी कभी दीदार दिखाते हैं, लेकिन मेरे से भागते हैं. अब क्या करूं मैं तो छोटा आदमी हूं, लेकिन इनके पीछे चलता रहता हूं.
Thank you so much.
You guys take care. Be well. Thank you.
Sorry to have disturbed your sleep if we have, but it was a real pleasure.
No. I'm honored, and it's a pleasure to be here. Especially सुबह एक कुछ अच्छे लोगों का दीदार हो गया. That's more than enough for me.
Thank you.
Thank you.
Thank you. We'll catch up.
Be well and be safe.
Thank you. Thank you.
Ginil, you have got the sling still there. I know you are able to see it better than me, but just because, in case you forget, we have to wind down. Ginil, can you hear us? Yeah, that was a very difficult one, and you made it look easy, especially the excision bit. Thank you very much. Thank you. And can we go to Gopal Krishna sir's theatre once? Yeah, hello. Hello, sir. Can you summarize what you have done?
While the lecture was going on, we managed to scope out the tumor. As I said, it was an innate resection because it was basically going deep inside. So with scissors, we just dissected it out, peeled it away, and then taken it out and show the tumor. There was one place where I thought there might be some breach in this area, if you see here. Yes, in this place. So here, that was exactly here, come here, in this place. So here we have taken out more tissue, cut out a slice and sent it for biopsy. So now it looks okay.
Thank you very much, sir. It was a pleasure watching you operate. Thank you. And thank you, Ginil. We need to go down. We are going to log off, sir. Thank you. Okay, thank you.
Hello. So it's 5 o'clock in the evening, 5 and 4, so 9 hours straight of surgery, live, semi-live, all mixed. Hope we were able to touch upon topics of importance regarding uro-oncology. There were trainees, there were experienced surgeons, I, being a junior person in this field, I was quite enlightened and entertained by today's surgical show. So it's time we wrap it up and we enter into the next phase of today's program. First, we will have the industry-sponsored sessions, followed by the cultural evening. We have today Toshali with us. She will guide us through the rest of the evening regarding moderation of the show. Handing over to Toshali. Thank you. And the surgical videos we can cut off from here. Thanks all to all the surgeons who have participated and performed. Thank you all again. And thank you, Dr. Adla, and thank you, sir.
Thank you so much for this wonderful live session. We move on to the next session, that is a industry-sponsored session. First of all, we'll be starting with metastatic carcinoma prostate management. And I would like to invite Dr. Deepak Dabkara, sir, to please come on the dais and take over the session. This is being sponsored by Zydus. Big round of applause. We are starting the industry-sponsored session. Thank you so much.
Minutes.
This is just a small announcement before sir starts. Snacks are already being served outside. You can enjoy it also. Sir, over to you.
Okay, thank you. So we go for the straight to the topic, recent advances in management of metastatic prostate cancer. The incidence of prostate cancer, metastatic prostate cancer is increasing, and androgen deprivation therapy is the mainstay of treatment for so many years. In 1966, Charles Huggins received Nobel Prize for this, and for next 56 years, this was the only treatment available. Hormone-sensitive metastatic prostate cancer, all patients who are receiving androgen deprivation therapy, they will develop CRPC at some point. And we will be discussing two types of patients, patients who progress on ADT only and patients who progress on combination treatment like docetaxel, abiraterone. So in all the phase 3 trials, conventional imaging has been used. PSMA PET has not been used in any of the phase 3 trials. PSMA PET can lead to upstage, over-treatment and lot of false positive. Now we come to the clinical trial endpoints. There are various phase 3 trials, they have taken different endpoints. The most common endpoint most of the trials they have taken is overall survival, radiographic PFS, PSA response, pain response, SRE, time to next therapy, time to CRPC and quality of life. There is no head-to-head comparison among these trials, and these trials have taken different population, different patient population. Some have taken de novo patients, some have taken metachronous mets also. And disease has been divided into low volume and high volume, and low risk and high risk. So patients can be divided into de novo high volume disease, which has the worst prognosis, about 50 months with the currently available treatment, de novo low volume disease, metachronous high volume disease, and metachronous low volume disease. Metachronous low volume disease has the best prognosis, about 90 to 100 months survival. So before 2015, there was one treatment for all metastatic prostate cancer patients. It was androgen deprivation therapy, and all patients will at some point develop CRPC. Treatment after 2015 changed. Doublets and triplets came into the picture. So first trial was ADT with docetaxel, charted trial. With this trial, things changed. Then androgen deprivation therapy with abiraterone, ADT with enzalutamide, AD with apalutamide, and recently PEACE trial, which shows ADT with docetaxel with abiraterone prednisolone and ADT with docetaxel with darolutamide. So treatment paradigm changed from 2015 onward. Charted trial, Latitude trial, Stampede trial, Archies, Enzamet, and triplet with PEACE-1 and Erasmus trial. And as of now, ADT alone is not a standard of treatment for any patient. Androgen deprivation therapy can be in different forms like bilateral orchiectomy, LHRH agonist, LHRH antagonist. Recent addition is LHRH antagonist, oral molecule, Lugolix, which has shown in phase 3 trial that cardiovascular toxicity is less. It cannot be proven in that trial, but there is a recent phase 3 study published in NEJM some 4-5 years back, which shows that major cardiovascular events are less with relugolix. This is oral LHRH antagonist, phase 3 trial, which has compared leuprolide versus relugolix. The primary endpoint was sustained castration level for 1 year, showing a significant difference of 7.9% points, and the superiority was proven over leuprolide. And the secondary endpoint was incidence of major cardiovascular events, which was significantly lower with relugolix. Come to charted trial. This is the first trial which has shown the importance of volume of disease, high volume, low volume. And this trial was about 700 patients were there, de novo metastatic patients 72%, high volume disease 65%. High volume was defined by 4 or more bony mets. One of them should be outside the pelvis and spine. This trial showed an overall survival difference of 17 months, 51 months versus 34 months in high volume disease. Among the solid tumors, this is the only trial which has shown so much of significant survival difference in metastatic disease. Normally with other cancers like lung cancer, breast cancer, the difference in survival with any new molecule is about 3 to 4 months. Another trial is STEMPE trial. It included metastatic disease as well as locally advanced disease. This trial also showed that overall survival was better in patients who were receiving ADT with abiraterone, and it also showed that overall survival was also better in patients who were low volume as well as high volume. So charted trial only high volume disease. STEMPE trial shows low volume with high volume. This is another trial, GETAC trial. It was before charted trial. It was ADT with docetaxel for 9 cycles. This trial showed no advantage of addition of docetaxel. And after this, there was a meta-analysis of all these trials, which showed that docetaxel appears to improve the PFS and overall survival for all men, except in those with low volume metachronous disease. Now we come to androgen deprivation with abiraterone prednisolone, Latitude trial, which was published in NEJM 1 year after the charted trial. It included high-risk population only. High-risk population they defined as 2 of the criteria should be present, either with presence of visceral mets or 3 or more bony mets, and Gleason score of 8 or more. This trial showed that the 5-year survival difference was 5-year overall survival was 60% versus 41%, and the post-hoc analysis showed that it benefited both in low volume as well as high volume. Then came the trials of enzalutamide. There were 2 trials, Enzymet trial and Archie's trial. They both showed that there was improvement in overall survival with the addition of enzalutamide to androgen deprivation therapy. This is another molecule, ADT with apalutamide, Titan trial. This also showed that median survival was better with addition of androgen deprivation therapy with apalutamide. So now there are various combination chemotherapy, docetaxel, and these abiraterone, enzalutamide, apalutamide. So which doublet to choose? So there is no phase 3 trial which has compared head to head. So ADT with docetaxel has not been compared with ADT with abiraterone. ADT docetaxel versus ADT enzalutamide, there is no trial. There was a meta-analysis of all these studies, and they concluded that with indirect comparison, these apalutamide, enzalutamide, abiraterone, they all give equal benefit. So how to choose among these agents? So patient characteristics, volume of disease, as well as synchronous versus metachronous disease, toxicity, patient preference, and cost. This will decide. Docetaxel has shorter duration of treatment, but more toxicity at least during the period in which docetaxel is given. Abiraterone prednisolone is associated with hypertension, cardiac toxicity, hypokalemia, derangement in LFT, and side effect of prednisolone. Enzalutamide is associated with fatigue and seizures. Apalutamide is associated with ischemic heart disease, fall, fracture, fatigue, rash, and hypertension. The latest addition is triplet therapy, androgen deprivation therapy with abiraterone prednisolone with docetaxel. This is PEACE-1 trial, de novo patients only taken. The addition of abiraterone prednisolone to ADT and docetaxel significantly improves the radiographic PFS and OS. The median PFS is 4.4 versus 2 years, and the median overall survival in patients with high volume disease, it is 16 months difference, so 3.5 years versus 5.5 years. So with the available treatment in the most dangerous type of prostate cancer, that is high volume disease, synchronous METs, that shows a survival of 5.1 year. And there is no trial to compare ADT with docetaxel with abiraterone versus ADT with abiraterone. This is the recent trial, ADT with darolutamide with docetaxel, Erasmus trial. It included 86% de novo patients, and darolutamide with ADT with docetaxel improves the overall survival. It is effective in both high volume disease as well as low volume disease. So there was a systemic review and meta-analysis of these two trials that showed that triplet is more effective than ADT with docetaxel, at least for high volume disease and de novo disease. So how to choose among doublets and triplets and between two triplets? So ADT with docetaxel with abiraterone versus ADT with docetaxel darolutamide, there is no phase 3 trial. Selection is based on the inclusion criteria, toxicity, and patients who are PS of 0 or 1 and de novo disease only, high volume disease. So the conclusion is ADT alone is not a standard treatment for metastatic hormone sensitive prostate cancer. ADT with docetaxel is effective in high volume disease. ADT with abiraterone prednisolone in both high volume, high risk and low risk. ADT with enzalutamide in low risk and less effective in high risk. ADT with apalutamide for both low risk as well as high risk. And this triplet combination, these are for de novo disease, high volume disease. There is the role of local radiotherapy in metastatic hormone sensitive prostate cancer. There are two studies. One is STAMPEDE, another is HORA trial. Both of these showed that patients with low volume disease, when they are given local radiotherapy to the prostate, there is a survival difference of about 7 to 8%. This is only for low volume disease patients. 3-year survival of 73% versus 81%. There are ongoing trials, lutetium PSM in first line, PARP inhibitors in first line, immunotherapy in first line. There are many unanswered questions. Management of oligometastatic disease, we don't know exactly. And there is the role of P10 mutate, P10 loss, retinoblastoma gene mutation, TP53, PIK3 signaling and AKT. So all these molecular markers, they are coming in the first line treatment, and they will decide the next course, what more to add or what, in what form treatment has to be given. This is the future of metastatic hormone sensitive prostate cancer. So patients who have optimal response like 0.02 Ng per ml at 3 months or 6 months, they do better as compared to those who have not achieved this level. So whether we can de-escalate the therapy, we don't know. The presence of SPOP mutation, the addition means with the presence of this mutation, ADT with abiraterone shows a better outcome, but ADT with docetaxel doesn't show the same outcome. So there are other like HRR mutation in first line, triple negative like P10 loss, RB loss, TP53. If TP53 loss is there, the response to treatment is poor. So lot of things are coming in the future. Role of bone modifying agents in metastatic hormone sensitive prostate cancer. Most of the clinicians, they give zoledronic acid or denosumab, seeing that patient has bone mets in hormone sensitive, but that is not indicated. You have to check for osteoporosis and osteopenia, and if that is there, then you have to give zoledronic acid either once a year or denosumab 60 mg 6 monthly. So patients who have progressed on first line ADT only, means if you see 10 years back, this was the only treatment available. So patients, and now we will have patients who are progressing on ADT with docetaxel with abiraterone. So there will be choice difference. Those who have received only ADT, their treatment will be, these are the options of the treatment: docetaxel, cabazitaxel, abiraterone, enzalutamide, radium-223, PARP inhibitor, lutetium, immunotherapy. But if the patient has already received docetaxel and abiraterone or docetaxel with apalutamide, then the choice will be different. I am not discussing these trials in detail because these are outdated trials and they will not have much significance in the today's time when ADT alone is not a standard treatment. So there were 2 phase 3 trials, both of them showed OS advantage of 2 to 2.4 months. The unanswered questions for timing of docetaxel, number of cycles. Abiraterone tested in both phase 3 trials in pre-docetaxel and post-docetaxel setting. They showed 3 to 4 months of difference. Same with enzalutamide. If you have used one AR targeted therapy, like you have used abiraterone, then there is no point in using enzalutamide in the upon disease progression. Radium-223 is approved for patients with symptomatic bony metastasis in CRPC patients. So PARP inhibitors have been tested in phase 3 trials and phase 2 trials. They show OS advantage. Recent trials are PROPEL study and magnitude trial. They show that the patients on PARP inhibitor will benefit only if the patient is BRCA positive or HRR positive. Lutetium PSMA therapy, there are recent 3 trials: therapy trial, vision trial, and PSMA4 trial. All of these show that patients who have progressed on docetaxel or progressed on abiraterone or progressed on both, there is some advantage. Immunotherapy, limited success with the available studies. And in CRPC, bone modifying agents you have to use either 3 monthly ZA or monthly denosumab, 120 mg. The conclusion is Metastatic prostate cancer is a heterogeneous disease. One size doesn't fit to all. Survival has improved significantly in last 10 years. Sequencing of therapy after first-line use of doublets and triplets needs to be defined, and molecular markers to guide the selection of therapy are underway. Thank you.
Thank you so much. We move forward to the next session. We'd like to invite Dr. Somnath Roy to please come on the dais. Novel taxane formulation in prostate cancer, sponsored session by Intas Pharma. Big round of applause, please.
So very good afternoon and good evening at least. And thanks the organizer for giving this opportunity. This session is sponsored by Intas and the slide deck is also given by the Intas. So I am talking about in short the nanosomal formulation of docetaxel in the prostate cancer. Basically the taxane is a novel formulation. If we know that incidence of prostate cancer is an remarkable zone, most commonly in the males after 50 years, and there is high risks of the disease also. So SOGOCON data, it is an 12 most common cancer and 37,000 new cases each year diagnosed, and 5-year prevalence rate is around 76,000. So the SOGOCON data project in the Indian scenario that rate of prostate cancer changes rapidly from 2022 to 2045, and the trend is rising. The population is large and expectancy is improving, which means the absolute number of older age are rising. So the polysorbate 80 hypersensitivity reaction, that is a novel formulation that I am talking about, that the docetaxel, all of us know that docetaxel is used in the cornerstone of therapy in metastatic hormone sensitive prostate cancer as well as in CRPC. So the docetaxel, the conventional form to, there are several disadvantages, now changes to the conventional to nanosomal formulation, that is novel formulation. In the past decades, reports of hypersensitivity reaction with docetaxel have been increasingly seen. 30% of patients who do not receive pre-medication, and the reported case of docetaxel hypersensitivity range from 8% to 13%. This study showed that the awareness of adverse effect with prophylactic steroids, the suggested adverse effect associated with steroid use should be recognized, and optimal management of steroid-induced hyperglycemia is recommended, and further studies are required. So the main concern is, one is hypersensitivity, one is infection, one is neuropathy, and the lung injury kind of things, and fluid retention, the class effect of docetaxel. So the nano aqualip technology formulation is a novel newer formulation of the nano formulation, like other taxanes and like other derivatives of the field of chemotherapy. So lipid suspension platform technology is used in these settings. The advantage is complete aqueous based system. So free of hazardous organic solvents, particles are nano sized, 100 nanometer, and all these are used in naturally occurring lipids. So the difference between conventional and nanosomal formulation, organic solvent, that is in conventional formulation, whereas in nanosomal the complete aqueous based system is used. So PVC bags, IV said, is not a concern. Hypersensitivity grade 3, grade 4 is not a major concern. Neurotoxicity is an initial data suggests is less incidence, and adverse effect with steroid pre-medication also less. These are the common advantage of nanosomal formulation, aqualip formulation than the compared to the conventional one. So this is the structure for less vascular, leaky vasculature, sorry, enables 100 nanometer these particle size to enter into the tumor tissue, better penetration, and they enter the tumor microenvironment for the better cell killing. If we look at the original docetaxel, that is taxotere in conventional form, the pharmacokinetics value is almost similar, and the PK profile is almost similar. The ratio is almost higher systemic availability of docetaxel in plasma component,
And this is the open label randomized multicentric study where nanosomal docetaxel liquid suspension is tested in the breast cancer population. Advanced metastatic breast cancer, 6 cycles of nanosomal docetaxel versus conventional taxotere is used, and no pre-medication was used. This study showed that the overall response rate is almost similar, like better, and the toxicity is also almost negligible in nanosomal formulation, like vomiting, nausea, alopecia, diarrhea, neutropenia, and febrile neutropenia. So all are basically comparable. The adverse effects, serious allergic reactions like bronchospasm, swelling of the face not observed, whereas the conventional docetaxel 2 cases are bronchospasm reported in the literature. No clinically significant changes are observed in hepatology and biochemistry and hematological malignancy. Neutropenia is inconsistent with those. So the ASCO 2018, the abstract showed that the solid tumors over more than 18 months there is an use in the breast cancer, head and neck, cervix, prostate, esophagus, and other malignancies where docetaxel is indicated, and we can easily use these molecules in the safest hand with a durable efficacy and safety and tolerability. So the expert opinion of the dossier-colib, the formulation from the Intas Pharma, that 13 oncology experts deliberated the slides of 35 National Oncology Conference that showed that its effective majority of the expert believes that this formulation convincing with the safety profile, and those who patient with steroids needs to be avoided in the metastatic settings, and the breast cancer is we have already randomized controlled trial that has proved efficacy. Another phase 4 trial of this novel formulation in CRPC completed data. Result is awaited. The DCGI is approved, and the hormone refractory prostate cancer docetaxel lipid suspension dossier-colib. There is a real world some data, multicentric retrospective study of efficacy of dossier-colib in metastatic CRPC. If we look at the 24 patient with CRPC was administered 2-weekly regimen, and baseline characteristics is almost similar. So the treatment delivery is in 2-weekly versus 3-weekly regimen. And if we look at the PSA response of this formulation, there is significant PSA response rate with this nanosomal formulation. The efficacy wise, the PSA declining rate is also high, more than 50% PSA declining rate is 2 weeks is 77%. The median treatment free response is around 200 days. So the concern, the toxicity, basically grade 3 and above toxicity is mainly hematological toxicity like anemia, lymphopenia, thrombocytopenia, whereas non-hematological toxicity is quite insignificant. So nanosomal docetaxel lipid suspension 2-weekly and 3-weekly regimen are effective and well tolerated in managing patient with CRPC. Now the bi-weekly docetaxel dossier-colib in CRPC, we have a case series report, and that showed that this bi-weekly regimen of this drug formulation is also effective with those who are metastatic CRPC and progressed on the abiraterone or in the pre-chemotherapy settings. So management and outcome, this NSDL formulation in lower doses also 45 milligram in 3 bi-weekly dose is also tolerable and acceptable, and the time to treatment failure is 14, 18 and 20 months in these patients. Although it is a case series, but bi-weekly dossier-colib more than 20 cycles was effective and well tolerated in CRPC. So the conclusions, serious adverse effects like hypersensitivity are common with docetaxel, paclitaxel, and to avoid them we need to use corticosteroid as a pre-medication. Steroids can worsen hyperglycemia and increase risk of infection. Novel formulation like dossier-colib is free from solvents and can be administered without steroid pre-medication. No grade 3 or grade 4 hypersensitivity reactions are observed despite no steroid pre-medications. So thank you.
Thank you so much. We move on to the next session and the last session before the inaugural session. bone modifying agent in prostate cancer. As panelists, would like to invite on the dais Dr. Vivek Agarwala, Dr. Sudeep Das, Dr. Shashank Das, Dr. Devopriya Mondol, Dr. Amit Sharma. Moderator of this particular session, Dr. Arnob Bhattacharya, and this entire session has been sponsored by Indus Pharma. Would also like to invite Dr. Deepak Dhapkara on the dais to please join as panelists. Big round of applause for our panelists, everybody. Thank you so much.
Hello, good evening. So I think Dr. Sudeep and Dr. Deepak is there. So I think the rest of the persons has not joined because of the duty. May I invite Dr. Somnath also if he wants to join? Somnath, please. So without further delay, we will start. So it will be some discussion about the literature. So the topic is bone modifying agent in prostate cancer. So we know that advanced metastatic prostate cancer develop bone mets around 70% to 80% cases. And in a placebo-controlled trial, it has been shown that around 50% patients with prostate cancer and bone mets developed bone-related complications. So this is the study from US has shown that prostate cancer has the maximum incidence of prostate cancer. The bone mets have majority was the prostate cancer, and different other studies also have support of this. And in prostate cancer, out of all metastatic site, bone is the most common site. So, so now we will start the discussion. So, Sudeep, welcome Dr. Amit also. So we will start with Dr. Amit then. So in your experience, so what is the incidence of bone mets in prostate cancer? In your all clinical scenario together.
Maybe at metachronous. Rest maybe 30% maybe metachronous.
Deepak sir, your experience, I think you have the maximum experience in this hall.
So there will be difference if you ask the question from medical oncologist versus a surgical oncologist, urologist.
No, we are discussing about the cohorts as a medical oncologist we are getting.
So I get all patients who are metastatic. I get patients only who are metastatic.
Okay. And regarding how many of them develops as a symptomatic bone mets? Shuribda, your experience?
So disclaimer is I'm a medical oncologist. So just like what Deepak Dhapkara sir was telling, all the patients they come to us, most of the patients, 90% come with bone mets, and symptomatic, the patients with bone metastasis, 60 to 70% will be symptomatic. Only patients who have very limited bone metastasis, who were picked up, we picked up bone metastasis on PSMA PET CT scan because of high PSA. Incidentally, they were noted to have limited volume bone metastasis. Except those, almost 60 to 70% patient will complain of pain.
Okay, and Somnath, your experience?
Yeah, I am also same experience with as my panelists Dr. Deepak and Dr. Sudeep mentioned. No more further these things.
Okay, so again coming back to Dr. Amit, so suppose the patients who are getting in hormone sensitive prostate cancer, so how frequently you do the DEXA scan or you check with the CT or? Yeah, sure. Yeah.
I will rephrase the question in a different way. Have you seen any change in the stage of presentation in the last 7 years? That's how long I've been. There is a stage migration that is happening. 7 years ago, 70% of the patients who come with metastasis. Now 30% of them come with metastasis. So we do seem to pick up cancers, especially prostate cancers, a bit early. Do you agree, sir? Or no? Because they only come to you when they have metastasis.
Yeah, it is difficult to answer for me because patients are referred to us only when they are having bony metastasis.
Okay, thank you, Deepak sir. So coming back to Amit, so how frequently do you do the DEXA scan, or you are comfortable with the CT images of the metastatic workup we are doing?
At the starting, at the time of diagnosis, we do one DEXA scan, and especially when we are starting ADT, we do the DEXA scan, and then thereafter, if patient has complaints, otherwise yearly.
So for all 100% patients, you normally advise DEXA scan?
Not 100% of the patients who are on ADT and who are actually in hormones sensitive patients.
HSPC only we are
HSPC
discussing.
only. So generally patients who are actually prone to have osteoporotic complications, osteoporosis, and the patients who are planning to go for ADT therapy. So these patients.
Okay. Deepak sir?
Ideally, it should be done in all patients, all hormone-sensitive metastatic prostate cancer before starting treatment. But sometimes, because of cost of DEXA scan, nearly 2,000–3,000 rupees, I rather give zoledronic acid, which is once a year for hormone-sensitive disease. So ideally, it should be done for all patients.
Okay, and Shudhita, your experience about how frequently you get osteoporotic complications during treatment, like we have done DEXA or not done, but during the treatment, the patient develops complication purely because of the osteoporosis.
Yeah, ideally we should test for DEXA scan for all patients before ADT, but practically I'll say in my practice DEXA scan is being done in less than 10% cases. That is the practice. And even not all patients are getting bisphosphonate, zoledronic acid 6 monthly or yearly for osteoporotic complications. Only when patients they become symptomatic, complain of bone pain, and then we do DEXA scan and check vitamin D and calcium level.
Okay, points well taken. Shomnatha, your point?
Yes, almost same as Dr. Sudeep and Dr. Deepak has mentioned. Bone scan we are doing very infrequently, less than 10% of the population.
Okay, so we have differences in opinion. However, we'll move forward. So these are the commonly used bone targeted agents, the bisphosphonates and denosumab, and we know that all are to decrease the SRD. So these are spinal cord compression or the bone complications which require surgery or radiotherapy or pathological fracture, and I think we can skip. Yeah, so there are some comparison for zoledronic acid, the most commonly used agent, versus the newer era denosumab. So we know that zoledronic acid is a bisphosphonate and denosumab is a monoclonal antibody against RAC ligand. There are different dose schedule. Denosumab mostly we use the monthly, zoledronic monthly or 3 monthly. Half-life of zoledronic acid is lower, and both are indicated for prevention of the SRD and as well as to treat the bone mets. Again, so coming back to Ashish, what is your choice of using when cost is not a factor? Denosumab versus bisphosphonates?
I think it's more or less depends upon the logistics in my private OPD. I mean, if patient has no issues regarding logistics, then probably I will go for denosumab. The fact is we don't have to worry about the renal functions in that case, and it is subcutaneous injection, so comparatively easier for patient as well. So I generally choose denosumab.
Deepak sir, you will give choice for all patient denosumab first, or still you prefer zoledronic acid for some of the patients?
If cost is not an issue, then denosumab.
Okay. Shudipta?
Yes, same.
Shomnatha?
Denosumab.
Okay. So another question, suppose we are giving docetaxel based chemotherapy which are giving 3 weekly and you want to start the bone target agent in CRPC setting. So how we will incorporate that denosumab into your practice? So I will start with again Dr. Amit.
Exactly, I'm not getting your question. I mean,
So the patients, you are getting a CRPC patients, which you are starting docetaxel, and along with that denosumab. So docetaxel is 3 weekly, denosumab is 4 weekly. So the patient have logistic issue. So how we will incorporate the logistic reason?
Okay, in that case, probably I can give docetaxel 3 weekly, and every alternate cycle I will give zoledronic acid or maybe denosumab. That's how I do in practical. I don't know.
Deepak sir?
Docetaxel 3 weekly and denosumab 4 weekly. I will not change the.
So that is ideal, but most of our patients might not follow this thing because of logistic issue. So is there any modification we can do, like alternate cycle or maybe cycle 1, cycle 2 give, cycle 3 gap? Because there are variation in the practice also. So I just wanted to get
Actually, if it is zoledronic acid, we have the data of 3 monthly.
Yes.
For denosumab, 3 monthly data is yet to come.
Yes.
1 monthly data is there. Yes. But again, your question is very much practical. And in practically, patient asks us how he will come after 1 week. Yes. And sometimes what I do is I tell them to take denosumab at a local place after 1 week. I mean, this is something I generally do.
Okay, Sudipta, your experience or any data to support?
There are 2 aspects. One is the patient logistics, how he has to visit clinic again, and sometimes the patient, they have access of Mediclaim facility. So they want that the denosumab should be covered within Mediclaim facility when they got admitted for chemotherapy in daycare. So that's why practically what I do in alternate cycle I give denosumab.
Okay, points well taken. Shomnatha?
Ideally, it should be done in monthly basis, but if patient logistic issue is there, then we have to change as per the patient wish.
Okay. So coming back to the literature evidence, the superiority of denosumab versus zoledronic acid. So it is a meta-analysis of 3 randomized phase 3 trial. So one was on all solid tumors except the breast and prostate cancer, and multiple myeloma was also included. The second RCT was with the breast and third was with the prostate. So this is the result of the meta-analysis. This denosumab was compared with the zoledronic acid. Both for 4 weekly regimen was used, and almost each paper has almost nearly 2,000 patients. So that has shown that this is the primary endpoint and secondary endpoint. So the primary endpoint, that is median time to first bone related complications, were very much significant for the denosumab arm, as well as the secondary SRE and first and second SRE, both were significantly better. And if you see the superiority, so there was some further analysis in the secondary endpoint. The superior result also got for the breast as well as the prostate, the paper. So these are other evidences. So there are actually multiple evidences by which we can get the denosumab currently as of now is the better choice. So I think we can skip. So regarding adverse events, so grade 3 or 4 adverse events are also there for denosumab, it is there. So yeah, this paper, denosumab versus zoledronic acid for prostate cancer. So it was a phase 3 patients with non-metastatic CRPC were taken. If we see the result of the first bone related, first skeletal related adverse event, so it was denosumab better than the zoledronic acid. And yeah, regarding safety profile, so the adverse event like anemia, nausea, vomiting, all these things are more or less common in both the subgroups, with particular side effects like osteoradionecrosis 2% versus 1%, and hypocalcemia 13% versus 6%. So grade 3 or more adverse event were little more common for the denosumab arm in these 2 side effects. Rest of the side effects are more or less similar. So these were the real world study from Germany. So here this paper has shown that 12-month use persistence of use of denosumab, it was more for the denosumab. The primary, the median time to discontinuation was longer with denosumab. So again, coming to some point. So any preference for logistics of zoledronic acid versus denosumab apart from the cost, subcutaneous versus IV? Amit?
I think subcutaneous is, I think most of the patient, if I ask them, they generally prefer subcutaneous form. And only thing is the logistics probably. Some people will ask for, zoledronic is a cheaper version. And it can also be given in 3 monthly time. In some prophylactic way, it can also be given for 6 monthly time. Okay. So in that way, it is okay. Otherwise, most of the patient choose actually denosumab. If their logistics are not an issue.
Okay. Deepak sir, any experience of using any adverse event of subcutaneous denosumab, the skin site reaction or anything?
It is hypocalcemia.
Hypocalcemia, yeah.
Hypocalcemia, particularly in patients who have creatinine clearance of less than 30. It is mentioned in the literature that if creatinine clearance is less than 30, then the risk of severe hypocalcemia is there with denosumab.
Yes. And any subcutaneous reaction for the denosumab?
No.
Anybody from the panel have any experience?
I think I have seen a few patients. One patient actually developed abscess somehow. He took denosumab outside at a local place and developed some abscess, and we have to drain it and send for the culture, and then we treat with the antibiotics.
Okay, so good evening, Dr. Shashank. So one last question from you. So for renal, we know that zoledronic acid has renal clearance, and we modify the dose or omit for the if the patient have renal impairment. So for denosumab, any renal safety data?
As per my knowledge, denosumab doesn't have any renal contraindication.
Yes.
So you can give.
Yes. Okay, so I think we have come to the last slide. So as per the NCCN and ESMO, the denosumab and bisphosphonate both are choice. NCCN, the category 1 recommendation is for denosumab. So this is the summary slide, same thing. So I think we can stop here. So thank you very much to all the wonderful experts. Thank you.
Thank you so much. So that was our last scientific session of the day 1. Ghosh will be there this evening playing for all of you. But before that, there will be another interaction and very important part which will be conducted by Dr. Amit Ghosh and Dr. Satyajit Mukherjee. And once again, thank you for being a part of SOGOCON 2024, to all the doctors, to all the delegates, all the dignitaries. Please be there with us till that time. Thank you so much.